we do in the emergency, and now we have something called modified Valsalva maneuver as well. Rarely used are the facial immersion in cold water or wet towel. I do not know anyone has experience in this. And forceful cuffing, not indicated these days, is applying pressure to the eyeball. Initially they used to do it, I have came to know, but now they don't because you can damage the nerve. So let's start with the Valsalva maneuver. I think there is some problem here. Okay, so carotid sinus massage, the word of caution is please, please, please put your stat before applying pressure. You never know there is a clot and you can allow him to dislodge to the cerebral circulation. Modified Valsalva maneuver is, let me go through. Okay, so there's a trial called River Trial for SVT, and what they did, they took two groups. For one group, they asked them to blow into a manometer, applying a pressure of almost 40 millimeter of mercury. And after applying that pressure, they wait for almost 45 seconds, and after 1 minute, they take out the ECG and see what is the response. And in another group, what they do, they start with applying this blowing pressure of 40 millimeter of mercury. After that, they change the position of the patient. Head down, passive leg raise up to 45 degrees. And after that, they bring the patient back to their previous position and they wait for next 30 seconds. After completion of 1 minute, again they have this ECG. So what they found, with the addition of this maneuver, the conversion rate after 1 minute was almost 93, as compared to 37 patients in the above group. So they said that this modified Valsalva maneuver is helpful in increasing the conversion rate of a paroxysmal SVT to normal sinus rhythm in the emergency room with NNT of 3.8. Okay, now moving on to the drug therapy, adenosine. Why beautiful? Because it has short acting half-life, only 8 to 9 seconds. And what it does, it increases the effective period of AV node, so you have less current, slowing of the heart rate, ultimately termination. The most important thing is the methodology, how to give adenosine. And what you do is, you select a large central vein, for example, antecubital vein, as close to the heart as possible. You give a rapid bolus injection, followed by a rapid saline, almost 10 ml, and the dose is 6. No response, titrate upward to 12. No response, some say repeat the dose, some say now you have to again titrate the dose. Go for 18 milligram. Whenever you go for the repeat dose, please wait for almost 1 minute before giving the next dose. Side effects, transient tachyarrhythmias and bradyarrhythmias. Mostly they are transient because the half-life is only 9 seconds, so nothing to worry. Most common facial flushing. You can have chest pain because of the coronary steal phenomena. Beware of bronchospasm. So whenever you are giving adenosine, please have a crash cart trolley with you. A word of caution for patient with reactive airway disease, asthma, SA node dysfunction, greater than first degree AV block. If the patient is WBW, this is a disaster, and patient is already on any rate limiting drugs. So when you're giving adenosine, what you want to do, you want to look at the cardiac monitor. You want to see whether the tachycardia is terminated or not. Fine. Just go through this ECG with me. So you're looking at a narrow QRS complex tachycardia. There is no doubt about it. So adenosine has been given. The adenosine kicks in and you have a few PVCs. Great. Everybody with me? And after a few seconds, what you have is the sinus arrest and the underlying rhythm starts to appear. And what you can see here is the short PR with delta wave, pre-excitation, evidence of pre-excitation. So when you have the documentation through an ECG, you are going to document and tell your seniors that afterwards I have this tachycardia. For example, the patient is coming for the first time in the emergency and you do not have the previous record. Always document the things. Narrow QRS complex tachycardia, no doubt about it. Adenosine kicks in, slows the heart rate, great. And what we have now? What is the difference between this ECG and the previous ECG? Anyone? What are these? So you have P waves here. Okay? The R interval is variable with flutter fib pattern. So you have now converted this narrow QRS complex tachycardia into something, a fib or flutter. Now my question is this: if on this big screen you are having trouble in locating these P waves, how you are going to locate them in a cardiac monitor? So when you will look at the cardiac monitor, you will say, okay sir, there is एक लंबी सर pause आया था और उसके बाद ये हो गया. The information you are giving to your senior that it is likely AV-NRT or AV-RT. Actually it is atrial tachycardia. So always document your ECG. Always document your ECG. It is very important. You can have a lot of information from the ECG. So AV-NRT responds to adenosine. You have sinus rhythm, go for AV-NRT. Narrow complex tachycardia. At the end you have sign of preexcitation. Think of orthotromic AV-RT. And you have multiple P waves. Think of atrial tachycardia, simple as that. With adenosine, you can have multiple responses, and you need to think whenever you are not getting any response. First of all, you need to think about in-educate dose, in-educate method. This is the most common. This is the most common. Upper septal VT, leave it. If there is gradual slowing without the termination, either it is a sinus tachycardia, autonomic atrial tachycardia, or junction atopic tachycardia. If there is continuation of tachycardia with AV block, the top line is atrial tachycardia, atrial flutter. If the SVT terminates with P wave at the end, the first line are the AV-RT, AV-NRT, you can rule out atrial tachycardia. And if you are terminating with URS, you can have any of these. So these can help you. Just looking at the ECG, the mode of termination, you can come up with a diagnosis. So what is the most likely underlying mechanism? So this was about adenosine. Regarding verapamil, half-life of 2 to 5 hours. Again, it increases the effective period. That's why it terminates tachycardia. Methodology, dose 5 to 10 milligram IV bolus over 2 minutes, please. Always keep an eye on your paramedics. It is 2 minutes, please. And then, if you want to repeat 10 milligram dose after almost 30 minutes of first dose. Nobody waits for 30 minutes, I know, but this is the what the literature suggests. Verapamil, hypertension, worsening heart failure with pre-existing LV dysfunction, and caution of word for SNO dysfunction, AV block, WPW. The next drug is metoprolol, available readily in every emergency of Pakistan, 3 to 4 hours half-life, increases effective period, 2.5 to 5 milligram IV bolus over 2 minutes. And then you can repeat the same dose in 10 minutes up to 3 times. Hypertension, worsening heart failure, bronchospasm, so caution of word for patients who have asthma, COPD, other something. Okay, so I'm not going to ask what is this, I'm just telling you this is a patient who was diagnosed as antidromic AV-RT. Now this is a wide QRS complex tachycardia, but SVT. What is the first thing that you would not like to do in this patient? क्योंकि अभी तक हम करते आए हैं. You would not like to give any AV nodal blocking drug, never ever. Procainamide, ibutylide, flecainide, propafenone. If ineffective, synchronized cardioversion, avoid AV nodal blocking drug. This is the most important thing. And another arrhythmia, everybody knows, pre-excited atrial fibrillation using accessory pathway, SVT, never give AV nodal blocking drugs. This is the message. Sorry. Ibutylide, procainamide, propafenone, flecainide, synchronized cardioversion, avoid AV nodal blocking drugs. Few words about synchronized cardioversion. Always get a written consent for cardioversion. Thank you. Secure IV line, oxygen, moderate sedation, very important. Arrange crash trolley, post-cardioversion ECG to document whatever you have done, and vital monitoring until patient is awake, that is out of the sedation that you have given. The last few slides, atripamil nasal spray. So a new drug in pipeline. Why? For patients with paroxysmal SVTs. The study is NOTE study. And atripamil, what it is? It is a fast-acting, non-dihydropyridine L-type calcium channel blocker. Intranasally administration with a nasal spray delivery device. Rapid onset of action, less than 5 minutes. And what they're doing is this. So if the patient is having paroxysmal SVT, they ask the patient to activate the cardiac monitoring system, perform Valsalva maneuver first. If there is relief of symptoms, do not administer the drug. If the Valsalva maneuver does not relieve symptom, push the cardiac monitoring system to document everything what is going on and administer this dose. This is the inhaler. So you just plunge it in the first nostril, then you wait for some time, and you go for the second nostril, and then you wait for some time. Refrain from blowing your nose. Breathe normally and remain seated while keeping head upright. If still experiencing symptoms after 10 minutes, wait for 10 minutes. Still you are having symptoms, blow your nose in preparation for this second dose. So you will take the second dose. So this is what they are doing, and they are looking at the response. It is a multi-center, multinational open-label study. Currently it is in phase 3. So if this drug manages to go to phase 4, obviously it is going to be FDA labeled. And the expected results are by 2024. Potential benefits will be avoiding side effects of prolonged use of antiarrhythmic drugs, rapid termination of SVTs without ER visits. You can do this at home. Alternative option for patients who are not willing for catheter ablation, maybe. Potential side effects, nasal irritation, discomfort, throat irritation, lacrimation, rhinorrhea, sneezing, and cough. So my take-home message for you is, always go for the stepwise approach. Secondly, please, most commonly drug we use is adenosine. Learn the proper method. Third one, always take out the ECG. While you are giving adenosine, press the button of the ECG machine. So the meanwhile the ECG is taking out, it will be get documented. Avoid AV nodal blocking drugs in antidromic AVRT and P-excited AFib. Always go for synchronized cardioversion. Synchronized. Just press the button of sync on the AFib. Thank you so much.
So I would like to invite Dr. Azam Shafkat to the panelists. And Dr. Azam Shafkat is professor of cardiology and cardiac electrophysiology at NICVD and head of the electrophysiology department at NICVD. Our next presentation is on arrhythmia management in pregnancy, for which I would like to call Dr. Ghazala Irfan to the stage. Dr. Ghazala Irfan is the first female electrophysiologist of Pakistan who have completed her fellowship in cardiac electrophysiology from Vergy University, Brussels, and currently she is working as an associate professor of electrophysiology at NICVD.
अस्सलाम वालेकुम. So one more thing जो हमारी थोड़ी housekeeping रह गई थी उस वक्त कि we will have the question answers at the end of every session and with the panel discussion. So I'll start my presentation, then we can have the question answers and panel discussion after that for both the talks. So arrhythmia in pregnancy, what are the differences? Because this is something I think all of us see in our daily practice, and we don't give it that much, I think, preference. But recently, in last few years, I have seen so many patients coming with pregnant patients with arrhythmias, and then issues that nobody is willing to entertain them. Even for a SVT, the gynecologist always send patient to the कार्डियोलॉजिस्ट के जी आप जाएं किसी बड़े अस्पताल में, हम यहाँ पे कुछ नहीं कर सकते आपके लिए, या नॉर्मल नहीं हो सकता, nobody knows कि ये आप नॉर्मल डिलीवरी कर सकते हैं या हर किसी का सी सेक्शन करने की ज़रूरत है. And there is one patient which I actually encountered who has actually antidromic tachycardia that was missed in the ER, that was cardioverted, and she went for elective C-section because she had an antidromic tachycardia, and somebody thought that it's a VT with a normal heart. And even with a VT normal heart, she can go for a normal delivery, not for a C-section. So she had actually a C-section needlessly with all the complications which she did not have, but she can have it actually. So that's why this time we thought that we should have a topic with this also, so, to just create an awareness what's happening and what we should be doing, all of us. So gender difference in arrhythmias, higher intrinsic rate and shorter sinus node recovery time usually are present in the females than males. Longer QTC interval and more frequent long QT syndrome is found in females. Higher incidence of drug-induced toxidipans and fewer sudden cardiac death episodes. 2-to-1 female predominance of AV nodal reentrant tachycardia. So the mechanism of these gender differences is not entirely clear, but usually the sex hormones play the role. Pregnancy may be proarrhythmic. Why? Because you have the altered hormonal status, increased estrogen, increased beta HCG, which can also have effect on the expressions of the ion channels. What are the hemodynamic changes? So what are the hemodynamic changes in the pregnancy? Vasodilation happened, which increases RTL compliance, increased sensitivity to nitrous oxide, vasoconstriction, and increased total peripheral resistance. Increased output, which is leading to increased blood volume, increased preload, increased heart rate, increased systemic vascular resistance, and increased red blood cell mass. What are the structural changes? Cardiomyocyte stretch happening, sensitivity increases, EDP volume increases, LV hypertrophy, and creation of uteroplacental circulation. Autonomic tone, vagal sympathetic hypersensitivity, and then increased catecholamines also. So how we are going to manage the arrhythmia in pregnancy? Fortunately, most arrhythmia is in this population benign, and therapy may take the form of reassurance only. However, there are cases in which drug administration is required, and in few cases in which invasive electrophysiology procedures are necessitated. The effect of drug administration and radiation exposure can lead to severe problems in developing fetus. Especially, we would like to avoid all medication in first half of the pregnancy, and the second half of the pregnancy usually increases the risk of childhood malignancy. तुम्हारा पॉइंटर नहीं चल रहा. क्योंकि ये कभी अपनी मर्जी से आगे जा रहा है, अपनी मर्जी से पीछे जा रहा है. दूसरा दो मुझे. Okay, good. Physiologically, if we see in the ECG what's happening, there is a shortened PR interval during pregnancy, shortened QRS in the pregnancy, permanent Q waves in lead 2, 3, AVF in V1 and V6, and there is stepping of the ST segment, specifically in the lead V1 to V3. An increase in resting heart rate is about 100 beat per minute, which results in decreased QRS, QT intervals in the amplitude of P and QRS complexes in T wave. Shift in electrolysis is more common leftward due to rotation of the heart, secondary to enlargement of the gravid uterus. And premature atrial and ventricular contractions are common. So these are the things which we need to understand, that these are the normal for a pregnant female ECG changes. Frequent reason for the referrals are the palpitation, study examined in which they have seen the Holter data of 104 patients, and 76% has no association of arrhythmias, and 24 arrhythmias are found which are mostly benign. So most cases we attribute to sinus tachycardia. What are the palpitation difference in the different stages of gestation? If we see in the middle of the gestation age, the patient have more palpitations as compared to the start, and by the end it started decreasing. Caution is advised with exercise testing. And 29% exhibition of SVT during pregnancy is noted. But it's a really very old data from 1995. I think after that there is not of so many studies in which you have pregnant females. Even if you see the multi-center studies, you don't even find the females, so pregnant females are really rare. I think recently whoever attended the ESC, there is a huge debate in the ESC with the thing that you need to have more and more female patients in all the studies so that we know what's the difference. Women with S3 pathway may experience a more arrhythmic response with pregnancy than those with the AVNRT. How are you going to manage? Vagal maneuvers should be tried first. As we have already discussed with Dr. Hasib's slide, if the tachycardia persists, intravenous adenosine is the drug of choice. Safety of adenosine during the first trimester is insufficient data. In second and third trimester is safe and effective. Fetal heart rate monitoring during administration of drug to detect possible fetal bradycardia. If it's possible, yes. But if it's not possible, adenosine is, as we already know, it's a very short-acting medication. So usually you don't have any issues giving adenosine to a pregnant patient. If adenosine fails, intravenous propranolol or metoprolol, verapamil should be avoided owing to possible prolonged hypotension. SVT cannot be chemically cardioverted, hemodynamically unstable, cardioversion should be performed. Chronic medical therapy should be withheld unless the episode of tachycardia become frequent, severe, and hemodynamically significant. So every patient who's coming with the SVT should not be put on long-term beta blocker or calcium channel blocker. If it's a first episode, ask the patient to watch and monitor. If she's having multiple episodes, then yes, she should be on medication chronically during her pregnancy. But if she's not having multiple episodes, then don't put the patient on a long-term medication. Because ultimately, whatever medication we are giving, that is going to pass to the fetus, and all of the medication which we are using, antiarrhythmic medication, none have been studied in pregnant patients. So we are just going by that. We did not find any harm, but we don't have any studies on that. Women with known SVT should be advised to undergo a curative catheter ablation prior to planned pregnancy due to the fact that SVT episodes can become more frequent, and all drugs should be avoided during this time. So this is the most important part, that if a young female patient came to you SVT and she has lot of symptoms, then she should be offered ablation to avoid having this thing again when she is pregnant and she is going to have some medication. If ablation is absolutely necessary during the pregnancy, it should be performed in second trimester, and a radiation shield over the abdomen and use of pulse fluoroscopy could be reduced radiation risk for the fetus, or we can use fluoroless 3D mapping system in which you don't use any fluoro, and just only with the 3D mapping system you can do the ablation. Atrial fibrillation and flutter rarely seen in pregnancy, commonly occur in patients with congenital heart disease, rheumatic valvular disease, or hyperthyroidism. Management of atrial flutter and fibrillation, ventricle rate control with beta blocking agents or digoxin. Electric cardioversion can be considered within 48 hours of onset of AFib to avoid need for anticoagulation. Coumadin is teratogenic and contraindicated during first trimester of pregnancy. And heparin is not absorbed the placenta, is considered drug of choice during first trimester. Long QT, difficult management problem in past, but retrospective data revealed that significant increase in the cardiac events in postpartum period. 40 weeks period post-delivery, but not during pregnancy. This delay might be related to the drop in the heart rate after delivery and increased stress for carrying infant. During pregnancy, heart rate normally increases and might have an actually protective effect. So beta blocker therapy should be continued throughout the pregnancy and postpartum if it's a known long QT patient. Ventricular tachycardia, most common VT which can be documented in pregnancy is catecholamine sensitive benign or idiopathic right ventricular outflow tract tachycardia. Rare causing in which you have a structural heart disease, peripartum cardiomyopathy, hypertrophic cardiomyopathy, coronary artery disease, rheumatic heart disease, congenital heart disease, right ventricular dysplasia, mitral valve prolapse, or long QT syndrome. So the general approach, if the woman has structural heart disease or long QT syndrome, by doing ECG and echo. So actually, if all these structural heart disease are present, the general approach will be the same as if the patient is having these disease, and you have to seek which medication are safe for during pregnancy and which medication you cannot give during the pregnancy. Monomorphic, if it's a monomorphic left bundle inferior axis, should be considered with diagnosis of RVOT tachycardia. Beta blocker is drug of choice. Finding of structural heart disease would put the mother at increase of sudden cardiac death. Antiarrhythmic drug therapy and possible an ICD might be required. Electrical cardioversion for unstable and lidocaine for more stable tachycardias. Presence of NICD should not deter a woman from considering pregnancy unless her underlying structural cardiac disease is contraindication. Please always remember this thing. If a woman with an ICD delivers vaginally, the device shock therapy should be left activated. The shock therapy should be turned off during a C-section to avoid an inappropriate shock secondary to electrocautery. If it becomes necessary to implant an ICD or PPM, the smallest size generator should be placed subpectorally, leads with the echo guidance, or with radiation shield, or you can do a fluoroless with 3D mapping. Actually, you can do the implantation also. So let's review what's happening here. So if it's a tachycardia, hemodynamic unstable, always go for cardioversion. Pregnancy is not a contraindication for cardioversion. It's not is a contraindication. Please always remember, we always get calls from the ER कि जी pregnant patient है, उसका heart rate इतना है, blood pressure drop हो रहा है, हमने सब medicine try कर ली, अब क्या करें? You should have cardioverted it, because actually if you are not cardioverting, she is hemodynamically unstable and the fetal blood flow is also compromised at the same time. So always remember, if it's hemodynamically unstable, you have to cardiovert. Hemodynamically stable, asymptomatic patient, no treatment. If it's a premature beat or sinus tachycardia, only conservative management. Treat the cause, AFib or flutter, narrow complex tachycardia, or there is ventricular tachycardia, AFib and flutter, same onset less than 48 hours. You can do chemical or electrical cardioversion, and then you can put on the rate control, metoprolol, digoxin, and verapamil. And rhythm control, flecainide, propranolol, and sotalol can be given. If it's onset greater than 48 hours, anticoagulate prior to cardioversion, and cardioversion can be done electrical or chemical. Narrow complex, vagal maneuvers, adenosine, propranolol, metoprolol, procainamide or verapamil, IV imidrone, definitely it's not it's not safe during the pregnancy, but if you cannot do anything, then yes. Long-term flecainide, procainamide, and propofol. And sotalol. Actually, sotalol is the medication which has a class B indication during pregnancy. That means it is a medication which can be given safely during the pregnancy. So if it's a VT sudden, you have to see if the structural heart disease absent or present. If the structural heart disease is absent, you can actually give a adenosine, same protocol which we use for all the other tachycardias in a non-pregnant patient. Drug risk, we have seen that most of the medication are class C, lignocaine is class B, and as I've already told you, sotalol is class B. Important thing, how you are going to, when these patients come, which patient should be referred to a center where they have a cardiology setup which can be taken as a backup, and which patient can go to a clinic or setup where they don't need a cardiology. So low risk are the SVTs, AFib, idiopathic VT, low risk LQTs, WP syndrome, that means level of surveillance is 1. And medium risk are unstable VT or with structural heart disease, and high risk are unstable VDs with structural heart disease. And let's see what are the level of surveillance we are seeing. Low, that means they just only have to consult the cardiologist, okay? So the medium they have to consult with multidisciplinary include, in which they should have a EP, a specialized center, mode and location of delivery as advised by the obstetrician. C-section and delivery recommended only in the high-risk patients. Other than that, rest of all the patients can go actually who have the surveillance risk for low and medium can go with the mode of delivery as advised by the obstetrician, that is any maternal or fetal indication for the C-section should be followed. Okay, this is we have done. Let's go more. Okay. So if drug therapy cannot be avoided, frequent monitoring of the patient ECG and drug levels to reduce the risk of toxicity. Plasma concentration can be altered due to increased renal blood flow, hepatic metabolism, and gastrointestinal obstruction. Teratogenic risk is greatest in the first 8 weeks of gestation. Begin ADs as late as possible in the pregnancy, and use lowest effective drug dose. A low dose drug combination may be preferable to a higher dose of a single drug because side effects can be dose related. Risk-benefit ratio should be considered in decision regarding antiarrhythmic therapy. Treatment should not be denied in a malignant arrhythmia. When possible, invasive procedure involving fluoroscopy should be avoided until after delivery. Known arrhythmia should be urged to undergo curative catheter ablation prior to pregnancy. So during pregnancy, significant changes occurs in hormonal and hemodynamic status of the women that may make arrhythmia more likely to occur. Palpitations are frequently reported, but usually found associated with sinus tachycardia. Incidence of SVT increase during pregnancy, whereas AFib and ventricular tachycardia are rare. So women with long QT experience significant more cardiac events in postpartum period, making beta blocker therapy most important during this time. Acute treatment of arrhythmias for pregnant women is much as same as that for the non-pregnant patient. And chronic drug therapy during pregnancy should be reserved only for frequent hemodynamically significant arrhythmias. Thank you. Dr. Azam, you can start with the discussion.
I have a few comments, but I tend to be long-winded, so I will let my other panelists say if they have something to say, and then we can bring it up from there. Sarah, would you like to say anything specifically from the, or Dr. Khalda, would you like to say something specifically about the last presentation from Ghazala, which pertained to?
SVT in pregnancy, it was a subject of debate since long time when I started practice in Liaquat Medical College. And we used to see these patients referred from the gynae department and as well as Dow University of Health and Sciences. It was really difficult decisions at the times to take. Whether they need medical therapy, vagal maneuvers, and or electrical cardioversion sometimes. So I'm really impressed by this topic, which was highlighted to this session, and for the learning of our postgraduate students. And actually the management is same as of the normal. We have to consider about the fetal well-being and the mother's well-being, and to decide about the short half-life of the drug, which is better. Adenosine is comparatively better than the amiodarone, which we used to give in our normal patients. Same is for the Dr. Hasib's presentation. It was really a good presentation, and very practical points which were suggested for our students and postgraduate fellows. Thank you so much.
Alhamdulillah, Bismillah ar-Rahman ar-Rahim, Alhamdulillah Rabbil Alameen. I'm very grateful for being given this opportunity to sit amongst all these wonderful electrophysiologists. I think we have a lot of grievances against the electrophysiologists. They are doing to the cardiologist what the cardiologist did to the cardiac surgeon. We took over their volume, and now you guys are taking up our lab space, and very justifiably so. Women with pregnancy is such an issue, especially with cardiology, that I think we should treat it as a subspecialty. And it is such a common thing that, and nowadays, with the people getting educated and become more aware, I think people are now more concerned about their I think we've blown up here. Women and the families are more scared about pregnancies now. They didn't have choices then. They would go to DICE and have it done. It was just you have delivery in the morning and you're working in the evening. And now they're more concerned about it. And doctors are more concerned about the litigations also. And you've gone over very exhaustively about the effects of pregnancy on women. I think we deal with a very fair share of women, because where I work right now, for the 4G Foundation Hospital, They're basically the dependents of the ex-servicemen, and they basically their wives and the children, which include daughters there. They come, and one thing you've not highlighted is that a huge number tend to have vasovagal syncopes. Yes. And they tend to come to you with tachycardias and palpitation. And when you talk to them, nobody's actually talked to them about their relationship to posture. And majority of their symptoms are posture related and vasovagal hypertension. In fact, half those who come to me with tachycardias and all the things, and you start working about DVTs and anemias, they tend to be vasovagal, at least the way I see. So you need to sit and talk to them, and they're very scared. And it's vasovagal syncope is the worst thing which can happen to a person. When your brain gets hypoxic, you think you're dying. You've lost your power. You get fuzzy, you get foggy, your brain bangs, there's tinnitus and everything, and you cannot think straight. You think you're dying. And they're the most scared people who come to me. And once thanks to Brother Azmat, he's hammered this, and Dr. Qurban and Dr. Tala and General Imran, they've been hammering it to us. And so we think vasovagal to me is a very important thing. And other thing is that it's so simple. If these women come to you, pick up things, just Google if you're not sure. And it's very important that you focus on this. The other thing about the SVT, the other aspect which was very important was I thought I knew SVT when I used to treat SVT. But now, unfortunately, I do not treat SVTs because they're treated by the time they come to me. And you've got these, in medicine, you've got these aggregators and segregators. The people who are going to lump things together, the people who are going to start separating them. And initially it was all clinical observations which, medicine was going on. And now with all these boys with toys kind of stuff, and these mappings and new mapping coming on and better mapping coming up, you're defining new things. So this is the real new challenges in discovery where no man has ever gone before, Star Trek kind of a thing. That's why, I feel so out of place that when I thought I knew SVT, and, one example I give is we all have taught in DIPCARD, and DIPCARD residents, they're the most underprivileged class anywhere. And we don't treat them the same as FCPS. So I went to check the papers of DIPCARD people, and the paper had been set by General Imran Majid. So this was like a guy gets this tachycardia. He's got a narrow complex tachycardia running, and so they diagnose and they give him Kalan, and he cardioverts. And so somebody's written SVT and paroxysmal, but because he didn't notice the access to all this, so this was an RVOT VT. And so, so I wish I modified the key for the DIPCARD. I said, if they're calling this SVT and treating it with Kalan and he reverts, he's not wrong, So at least he got something right. So I had to change the key, and I told him that I've modified your key scoring system. And so it's becoming very complex. And to be honest, when you talk to a real EP guy, first they're going to turn the ECG upside down because they're so scared it's wrongly pasted. And then they will talk about it, options. They will never end up giving you a diagnosis. They're going to say, it can be. Now, there's something very interesting. So they're going to talk for half an hour, and they still won't come up with something. And in the end, it'll be like, I think I know what it is. So, yeah. Yes. Yes. To cut the story short, what I learned from electrophysiology is that a specialist is somebody who knows more and more about less and less. And eventually he ends up knowing everything about nothing.
Sarah, So what we'll do is, if you have any comments,
Yes.
and go ahead with it.
Just
we'll
a couple
take.
of-
I have some things to say, and then we'll have 2 questions from the floor.
Yes.
Okay.
Well, thank you very much. First of all, I'm delighted to be here, and I would like to congratulate both the organizers and the presenters for continuing the culture of clinically relevant and interesting presentations. Just 2 points that I wanted to make for the first presentation. It was a very clinically relevant presentation. The 2 things I would like to add is the first one for our postgraduate residents, trainees, that when somebody comes in with what looks like a CNS presentation, altered mental sensorium or seizures, please take a very careful history, look at the ECG, monitor the rhythm, because it may end up being a cardiology problem, and a lot of patients suffer because of this. And the second thing I'd like to add is that for hemodynamically unstable arrhythmias, refractory angina is also a sign of instability. So those patients should also be cardioverted. So thank you very much.
So thank you very much. I think both these were very clinically relevant issues. I just put down a few points from my perspective. I think one of the new exciting things that's going to be coming around in SVT, things have been the same pretty much for many, many years now, is the etripamil, which is the nasal spray. This is a verapamil analog, and it has a very short life, about 8 minutes. So it's relatively safe. The NOTE trial is going on right now, but there have been multiple phase 3, phase 2 trials which showed a very nice curve on the, if you look at their, of the dosage curves, 35, if you use a dose of 35 milligrams, I think that's what they had initially, it's about a 40-50% conversion rate. Then you go to 70, it's about 80% conversion rate, and then about 90%. So it sort of keeps on going, a lovely curve, and as you go beyond 70 milligram dosage, you start to get the side effects, which include hypotension, AV blocks after they convert. So the NODE concept is that instead of giving one big dose, let's treat it like we give adenosine, give 1 dose, and then wait a little bit, and if it doesn't convert, then give a second dose, so that you avoid the side effects while still maintaining a slightly higher dose by using 8 milligrams. I think this is going to be really exciting for our patients, because most of our patients are, if you give them the option of taking a pill in the pocket or now a nasal spray in the pocket, I think they're going to be quite delighted with that. What is it going to mean in the future for electrophysiologists is also going to be very interesting, because there will be many, many patients who will now opt to do something like this if it works effectively, as opposed to proceeding with an invasive procedure. And how this is going to play out will be very interesting, I think, from the electrophysiology perspective. The second thing was, which I think that Haseeb showed was really nice, the REVERT trial, which was basically, there are 2 things I really liked about the REVERT trial. One is that it was a very, it showed how you can increase your efficacy by almost 50%. Half of your patients who come with an SVT will convert if you do the right vagal maneuver. And what is the right vagal maneuver is that you have them do a Valsalva. And I think one of the things we can also look at in our own practice is, instead of asking them to bear down, but to blow in a pressure monitor, bring it up to 40 millimeters like they did, and maintain it for 15 seconds. And then once this reduces the venous return because of this, and then when you raise their legs immediately afterward, the sudden influx of volume into the heart causes this increase in the vagal tone. This is the presumed mechanism, and it increases the efficacy of this maneuver. What I really liked about this study is the fact that it is a very simple study, and it carries so much weight. It can clinically change, practice changing, and something that we could have done. Important thing is that they standardized the Valsalva maneuver. And then they did this. So an excellent study, very clinically relevant. I don't know of anybody who's actually using it, but certainly now that Haseeb has reinforced, I think we will go back with more vigor to try and see if we can institute it in our ER. One of the things I would like to have the input of the senior cardiac electrophysiologist, Yaqub Saab, and Imran Saab as well, Dar Saab, is this concept of cardioversion for a hemodynamically unstable SVT. Now, if somebody has an AVNRT and their blood pressure is 80 millimeters of mercury, in true practice, I am not going to go and cardiovert them. I'm going to give them a drug which has a half-life of 8 seconds in the blood and see what comes out of it. If I'm going to cardiovert them, just the fact that they are going to get sedation and other sedation is going to make them even more hypertensive. So a short act, because if we are relatively sure that their hypertension is secondary to their SVT, a short-acting drug like adenosine is certainly, in my perspective, a much more reasonable option than cardioversion, even though the ACLS guidelines say something different. And keep in mind, the ACLS guidelines are just guidelines, and they exist for all levels of care providers. If you are somebody who's confident about your SVTs, I think it's reasonable to consider adenosine, and in reality, very few of us go ahead and cardiovert people without giving them adenosine before that. Two more things relative to Dr. Ghazala's presentation. One is I had the opportunity of visiting RIC not so long ago, and I was delighted to see that they have their obstetrics cardiology set up in the hospital as well. Maybe there are other places, but I think this is a wonderful thing to have an onboard cardiologist in a dedicated, onboard obstetrician, gynecologist in a dedicated cardiology setup, because this is truly the need of an hour. Our patients who are pregnant have to go through all kinds of hell to get care provided to them. So certainly I think this is a model we should all be looking at. And lastly, I think there is, Liaquat Zaman Saab is here, and he's going to be talking tomorrow about some of his cases regarding 3D. Perhaps at that time he can also enlighten us about some fluoroless ablations that can be done. And certainly there is more and more a growing role of fluoroless, zero fluoro, using 3D mechanisms for treating patients who have recurrent SVTs in pregnancy. So certainly that is something new that is available and can be used for in the future. So those were my comments, and thank you very much once again for both the pleasure. If it's okay, can we go ahead with a single question, or we should stop now? We are far.
Sir, we will go with the shield presentation now.
I'm sorry?
We will go with the shield presentation now.
Oh.
Okay. Now, I would like to call General Professor Sohail Aziz to present the shields to our presenters and the panelists. Our first presenter, Dr. Hasib Raza, please come on the stage. Dr. Hasib. नहीं, आप उनको करें. Dr. Ghazala Irfan. Dr. Azam Shafkat. ठीक है. Dr. Saira Bukhari. Professor Khalda Sumro. Dr. Khalda. And Dr. Azam Shafat, can you please come and give shield to Dr. Suhail Aziz?
We'll be starting our second session of ventricular tachycardia, and for that I would like to call the panelists for the session. Professor Mohammed Ishaq, I would like to call you on stage. He's a professor of cardiology at Medicare. And Dr. Liaquat Zaman. He's currently practicing as consultant cardiac EP at Shifa International Hospital, Islamabad. And Dr. Abdul Manan Bari. He's a Senior Registrar at Punjab Institute of Cardiology, Lahore. Dr. Bari. Dr. Abdul Manan Bari. Okay, our first speaker for the session. I would like to make a correction. He's an assistant professor of cardiology. Our first speaker for the session is a renowned name in the field of cardiac EP, Professor Brigadier Azmat Hayat. And he'll be presenting a talk on PVC, VT, and structurally normal heart.
Thank you so much, sir. And welcome to Professor Liaquat Zaman, sir. Sorry, I probably haven't met, but pleased to see you here. And Azam, I'm trying to show you some fluoroless procedures. So let's have a look at them, all right? So the topic, probably this is a bit misrepresentation of my topic. So I'll be talking about VTs, VEs, ablations, especially in the outflow, but probably with an epicardial angle as well. And especially looking after the LV summit. And then in the end, I may show so as you see, my first patient is a younger male, and he was serving military personnel, had an episodic palpitation with chest tightness, structurally and functionally normal heart, this one. 24-hour halters, couple of times, both showing a burden of more than 20%, and non-suppressible with IV lignocaine. This has been our practice for quite some time. We try and see if they can be suppressed with lignocaine, because if they can be, then it's very difficult to induce them on the table. So we always try and see if they can be suppressible with lignocaine. So have a look at these ectopies. As you can see, the ectopy is the looks outflow, and probably look from the LV. By the feature of it, if you can see an R and S complex in the V1, and as you can see in the bottom, these were some of the features which made us think that they may be coming from the left coronary cusp / epicardial. So we proceeded on, and what we do is we always go into the coronary sinus and map the coronary sinus, went up to the greater cardiac vein, and see if the ectopies are earliest at that site. So as you can see, my coronary sinus catheter. It's a decapolar catheter. It's almost close to the LV summit. Well, what we did was had a double stake. You can see a Judkin catheter delineating the coronary arteries, left main stem, and the bifurcation. Coronary sinus catheters in place, and the ablation catheter is in the left coronary cusp. This was the site where we had the earliest signals. This is a very beautiful map actually, but I think while I was previewing it, unfortunately this does not run here, but it's a very good video, and it was clearly showing that this site is the earliest. And as you can see, during ablation, the ectopies have gone. So the film down below, the running ECG, show the successful ablation. The second patient, again serving military personnel, 44 years of age, had episodic palpitation with shortness of breath, lately increasing for the last 4 or 5 months. We tried his EP procedure twice, I think in 2013 or 14, and then again. Both of the time we were unsuccessful. I think the first time we primarily mapped his RV, while the second time I think the procedure had to be abandoned because the patient became unstable. So this time we did 2 halters, maybe many more halters, but the last 2, as you can see, the burden is more than 20% and 26%. So have a look at this ECG. As you can very clearly see, again an outflow, but sort of double transition. Again pointing out towards possible LV summit or left coronary cusp. So keeping that in mind, we went in. Again, mapped the coronary sinus. This time, I think it was not, so I didn't use a decapolar, and I took the ablation catheter. I think this is one of the 3D mapping catheter. So as you can see, I think I couldn't advance it further. This was the maximum to where it would go, and almost touching the sort of left LV summit area. Again, the signals not very interesting at this spot. So we obviously did a 3D map, and as you can see, that's the left coronary. That's the left coronary cusp. That's the coronary sinus. So the origin was again in the left coronary cusp, and you can see the proximity of the area to the left main stem. And as you can see down below, with ablation, ectopies gone, and he is still ectopy-less. We will be following him up for quite some time now. He is doing obviously well. Third patient was a 23-year-old lady. She was very symptomatic, had palpitations all the time, especially during exertion. And no wonder, when we made her run on an exercise test, she was in VT. Again, structurally and functionally normal heart, and Holter burden-wise, ectopy was less, but considering that she was symptomatic, and especially during exertion, and then especially while exercising. So I took her onto the table. This is the VT. As you can see, a very late transition in the chest leads and strongly positive inferior leads. So this is the again the mapping system, and I think it's very clear that you can see Obviously, of all the videos, I've tried to pick up the one where I thought this may look much obvious to you. So as you can see in this videos, so this is the mapping system. That's the point of ablation. That's the site of origin. This is my ablation catheter, and it is on the anterior surface of the RV outflow. And you can see down below the tachycardia / ectopies terminated. And we have been following her for quite some time now, and alhamdulillah, she is symptom free. Well, this is a case which we, in fact, recently performed. This is a very interesting case. Well, General Imran actually knows this patient father. So you have been treating his father, sir, and I am treating his son. So the father has had an ARVD, you implanted an ICD, and then the son, a very good family. So the son had an ICD implanted, and he was doing very well. But then with passage of time, he was becoming more symptomatic, palpitation, shortness of breath, and chest tightness, and so on. So we tried many medication, and this is a patient who is also being seen by, I think, Asad in Shifa as well. So we are sort of mutually seeing this patient. So eventually, at some stage, we decided that we had to take him to the table and do an ablation. So as you can see, this is an ECG of ARVC, and I think if you can focus, probably you may see an epsilon wave as well. This gentleman, the problem with this gentleman was that he was having slower VTs, very slower VTs, which were difficult to manage, treated with many, many drugs. In fact, all available drugs were thrown on him, but somehow he will not respond. And this, as you can see from the cycle length, obviously is the underdetection of the ICD and not responding to the antiarrhythmics. So we decided to have a go at him, and keeping the possibility that he may have an epicardial origin, we decided to go by epicardial approach. And in fact, probably this may be the first epicardial approach-based case in Pakistan with the help of rhythmia mapping system. So what we did was, as you can see, this is the pericardial, standard pericardial access route. The proctor let us do it, but as you can see, with a potentially zero space, the complications will arise. So unfortunately, we also had a leak, but it was managed during the procedure. So we went in, as you can see, this is the ICD leads, that's coronary sinus catheter, and this is the access of in the pericardium. That's sheath, I think it's Zarpas sheath, and we first mapped the endocardial surface. Yes, so as you can see, this is the Orion catheter, and we are mapping the RV. The same gadgetry, ICD lead, atrial, ventricular, coronary sinus, RV catheter, and Orion catheter. Here, as you can see, in the pericardial space and going into the pericardial space with the Orion catheter, and mapped the epicardial surface as well. I'll just show you in a short while. So I understand not many people will understand this, but the people obviously who have the knowledge, these are a lot of areas of low voltage potentials, and they have been highlighted. I'll run the videos, probably you will understand more. So these were the sites which we thought were full of low potentials. And low potentials are the areas which probably denote the scar. So what we did was, this is, it should run, this one. इसको ज़रा चलाओ, ये चलना चाहिए इसको, हाँ, that's it. So as you can see, this is the propagation map, and you can clearly see there is a zone of slow conduction around here. After a lot of mapping, both on the endocardial side and the epicardial side, it was, so the most later signals, the most fractionated signals, they were on the basal part of the RV, inferior basal part of the RV, and also at the lateral part of the tricuspid annulus. So we went in. This is the ablation catheter in the pericardial space, and as you can see, this was the one of the sites. So we obviously it was ablated multiple times. So, but this was one of the site where I think it was the site where we thought that this was the most delayed and the low potential site. So post-ablation, as you can see again, one of the videos where you can see, so a line of ablation was drawn. This is the epi site. I couldn't show you the endo side, but you must understand this. So we ablated from the inside of the heart, and then we went in and ablated from the outside of the heart. And in the end, so this is the halter. As you can see, the burden of ectopy has significantly reduced. And I could not, unfortunately, could not show you the techie, which was terminated. I tried my best to catch that, specific moment, but somehow, with so many things going on, I was not able to catch it. But then, this is one of the repeat halter. And Alhamdulillah, it's about more than 2-3 weeks now, and no more VT and no more ectopy burden. With this, I thank you all. If you have any questions.
Especially the cardiac MRI, just to delineate the site of arrhythmogenic scar extending from endocardium to epicardium and what's its distribution. That will definitely guide for the practicing electrophysiologist just how to deal during the procedure and what will be the success rate and all those things.
Manan, I think you will understand the problem. Dr. Liaquat may not. And Jana Imran will probably understand more. So we have got the machines. We have got probably best cardiac MR machines. But you know very well that there are not very good reporters of cardiac MRI in Pakistan. But we did MR for him as well. I didn't show it, in fact, but MRI was done for him as well. And we do it routinely. Especially in our military people, we do it. But as I said, unfortunately, sir, you know that. It's long time now, and there are still not, I mean, it's all the cardiologists who are trying to work and report on it. So I'm not sure, to be honest, what would be but it should be done. So we do it. We have cardiac MRI, we do it, and we definitely get the help out of it. But end of the day, it's the EP and the signals which decide.
Brigadier Sahab, I'm not an electrophysiologist, I am surrounded by two very distinguished EP specialists. He's my classmate as well as roommate, so I met him after a long, long time. He will ask your technical questions. I just wanted to ask you about post-MI scarring, which we have now been able to see after MRI. How frequently, how much it contributes to ventricular tachycardia, and how easy it is to manage these patients, because myocardial infarction is such a common condition, and we used to just assume that this is electrical instability, and we didn't know exactly what was the basic reason. And since CMRI came into, scarring has come up as a very important finding.
Sir, a very good question. But I think this is probably the only area where EP in Pakistan has probably not come up to the expectation. I still remember General Imran would talk about it, doing these scar-related, post-MI related ablations and trying to reduce this burden as well. But ischemics or scar-related, generally in Pakistan, because they are tedious procedures, and mostly these patients are hemodynamically not that stable. So what we tend to do is, and not many people will be this affording. Yes, sir, go ahead.
I didn't understand, but I think is he talking about, for example, scar-related VTs? I mean, we would love to do that, and that's actually one of my interests. And we have the capability. I mean, I could show you a slide where it's complex because that is real electrophysiology. All of the other stuff is hodgepodge. Atrial fibrillation, we do it because we do it. The real electrophysiology after atrial fibrillation is actually post-ablation reentrant tachycardias, and that's really where the brain is. But regarding his question about scar-related, patients who are MI scar and they have ICDs and they have ventricular tachycardia, which is refractory to medications, and actually people like me, we think even patients who are having frequent shocks, we have one sitting in the hospital, we will be doing him, that's class 1 indication. And it's really not difficult, once you do it. It's just the main thing about electrophysiology, and I tell my nurses, they're back in States, a computer is a computer is a computer and is a damn computer. You could make any colors out of the map, 3-dimensional map, if you don't understand the basics of electrophysiology. So that is one aspect that is doable. The other thing is, I would make comment that I came geared to listen to PVCs and structurally normal heart, because that's a very broad topic and some areas of interest, which if I would have given a talk, I would have talked about, first of all, the outflow tract PVCs and VT are not simple. That's number one thing. They are not simple by any means. What you could think of an RVT, it could be coming from the coronary cusp and vice versa. Then the other one, the septal summit, that's another thing. And the mapping, I'm just going to specifics for the audience, the things which are missing, because you went more to epicardial stuff, but we come to, in the summit tachycardias, the thing is that you need to map, you cannot go with the coronary sinus catheter or definitely with not ablation, but you have to go either with micro catheters, there is a one which is made by Baylis, and you have to go selectively into the coronary veins, the septal branches, because lots of these arrhythmias are transmural. So you will have to ablate from remote sources, it's not, right. What's that? No, there's a lot more things. Bipolar, unipolar, there's a lot. We don't want to go into that detail because it's more. The other thing is, the other areas of interest in structurally normal heart and PVCs are papillary muscle, PVCs, and the other ones are the fascicular VTs. So we didn't go into that, but I think sometimes we can discuss those in future.
Azman Saab, if I can make a comment.
Another simple question from Liaquat.
Comment?
Just taking an opportunity. What is the role of surgical excision of this scar tissue? Is there any role of surgical excision of the scar tissue if you are refractory VT?
No, if you are going to have a surgery, right? Obviously not. You know, we won't send patient for surgery because he has a scar, we will do ablation. But if the patient is going to have surgery, then since long time, since we were doing in the 80s surgery, the thing is, you know, the arrhythmias do not, okay, two things, I will correct myself. The arrhythmias do come within the scar, and we will show you sometimes you get these slow potentials, and the coherent mapping is not yet into ventricle, it started with atrium, but the area for the surgical excision important is that the border zone, which you will see in the 3D map, the green color and the yellow color area, you also need to take care of the surrounding area. So that would be surgical, not just the scar, but the additional surrounding, and the MRI would be of a great help in that sense.
Thank you.
So,
Thank you.
permission of the chair, just a
Dr.
comment.
Sohail, I'm really sorry, but we are running short of time. Can we do the next presentation and then we'll take the discussion and everything? Thank you.
We'll proceed with the second presentation. Our next talk is on practical approach to management and risk stratification of ventricular arrhythmia in post-MI setting. And for that, I would like to call Dr. Faisal Qadir to come on stage. He's an associate professor at NICVD EP department. Thank you.
Okay, thank you very much. It's really a pleasure to be here, and I thank the organizers for the kind introduction and invitation. Sorry. So hopefully a few things that came up in the discussion. Maybe I'll show some slides, and maybe I have some CMR tracings, the images to highlight the scar and the arrhythmia mechanism. So we know that with the advances in coronary artery disease care, that we are seeing the incidence of sudden cardiac death is actually reducing, and it has decreased over time. And despite the improvements, the mortality after an acute MI remains very high. And especially these patients had very high risk of sudden death in the first year of life, and especially in the first few weeks and months. It's just an obligatory slide just to show the magnitude of sudden cardiac death. And you can see on the left the number of deaths that are caused by different diseases like stroke and cancers. Sudden cardiac death are much more than all these combined. And if we look at the SARS-CoV, the amounts of deaths that we had in the US, it's all US data, so it was almost more than what is there for sudden cardiac death. But we know that how good we have been in managing these patients rather than the sudden cardiac death that we see in our perspective. So just highlight this Myerberg paradox, which means that patients who die of sudden cardiac death, the incidence increases as you enrich the different populations. So in general population, the incidence of sudden cardiac death, the total events are actually very high. But as you go down and see the high risk groups, like the patients who have post-MI high risk patients, their sudden cardiac death incidence may be actually something of the order of 30% in first year, which is very high. But this is a very small group of patients of the overall general population who has sudden cardiac death. So sudden cardiac death mainly will happen mainly in patients who have structurally normal hearts. And we have good evidence from different studies that we just target these high-risk populations. But we are not making really a big dent on patients in the general population who are at high risk for sudden cardiac death. So what about the timing and incidence of sudden cardiac death after an MI? So the mortality increases, especially in the first 6 months of an MI. And this is the data from the Valiant trial, which was a very large trial, more than 14,000 patients. And it was autopsy records of patients who had sudden cardiac death. And they showed that in the initial period of MI, the majority of the sudden cardiac deaths were because of mechanical causes. And we know that patients implanting ICDs in the first 40 days of MI is not beneficial as data from the Dynamite and the IRIS trial shows us, because these patients certainly are at very high risk for sudden death, but these patients actually die because of non-sudden death, which is cardiac rupture, recurrent MIs. So they are really mechanical causes in the first few weeks, which causes sudden cardiac death, which causes death in these patients. And device therapy for early primary prevention of sudden death. So as I just mentioned about these two trials, so these trials, the Dynamite and the IRIS, did not show any survival benefit of implanting ICDs in the early MI period as compared to controls, even though these patients had high arrhythmic risk. And the guidelines would not suggest implanting ICDs in the first 40 days of MI or 90 days post-revascularization. A variable defibrillator can be thought of, but it's a class 2B indication in these patients in that initial period. Patients who have inducible VT can undergo an EP study, and if an EP study you have inducible VT, then you can place an ICD. But usually the ICD is reserved for after this period. This was a West trial for the variable defibrillator and did not show any improvement in arrhythmic death as compared to controls. What is the pathogenesis of sudden death after MI? So as has been discussed, it's basically the scar. So when you have an MI, you have a big scar, a big area which get necrosed, and then this is you can see the isthmus. So that's the scar tissue, and there are border zones where there's slow conduction, and these create reentrant circuits for arrhythmia generation and reentry. Usually it's an interaction between the substrate, which is the scar, then you have triggers and some autonomic conditions like their sympathetic increase and parasympathetic, which is the vagal the parasympathetic decrease, which predisposes to arrhythmia generation, arrhythmogenesis in post-MI patients. So during the acute phase of MI, arrhythmias occur. It's not a scar, so just an acute hit, acute MI. So it causes ion channel dysfunction and causes arrhythmias. Due to these transient cellular insults, arrhythmias occurring in this acute phase of the MI, usually in the first 24 to 48 hours after onset of MI, are associated with increased in-hospital mortality, but not with late mortality. So if the patient presents with a VF initially in the first 24 hours of an MI, obviously he would have been in high risk, but it's not panned out to be shown that they have late mortality. So what about timing of risk stratification for sudden death after MI? The optimal timing is a bit unresolved when to risk stratify these patients. It has been suggested that the different methods of risk stratification in the early MI period are less useful than performed later on after like 10 to 14 weeks. Now just a few things about the sudden cardiac death risk stratification methods. So you have the substrate, which is the center part, and as I told you about the triggers, so different things can be looked into. The patient's general things like the presence of atrial fibrillation, the patient's heart failure status, and the renal function, because these can all be very important. Autonomic tone has been seen by baroreflex sensitivity, heart rate variability, heart rate turbulence. So these are different methods to look for autonomic dysfunction. Then echocardiography, which has been the standard, and by which we base our decision to implant ICDs in these patients by measuring from echo or from imaging studies. EP study, which is an invasive study, which can also be done to risk stratify these patients, and other things like microvolt, T-wave alternance. But however, in the early period, in the less than 40 days after MI, if you look at these different risk stratification methods, they have really not shown to be predictive of arrhythmic death if you risk stratify using these methods in the early period, even if you combine with LVEF. And it's mainly observational studies for most of these in this group. So we don't really have good risk stratification tools in the early period after MI. However, and there are also issues with sensitivity and specificity of these tests. And there was some suggestion in some different studies to combine these different risk stratification methods, and that probably gives a better discriminator for arrhythmic substrate identification in these patients. A few words about left ventricular function, which is the commonest way we identify patients and categorize for implantation of ICDs. So the current guidelines are heavily weighted towards use of LVEF. But however, it has low sensitivity and low specificity. Low sensitivity because a majority of the sudden cardiac deaths occur in patients who have relatively preserved EF. So it is not very sensitive in picking up those patients. And low specificity of EF because even though the cardiovascular mortality increases, there is also a risk of non-sudden death increase when the EF goes down. So the EF does not really discriminate these two subsets very clearly. Then the role of electrophysiological study. EP study is kind of the induction of arrhythmia, and Dr. Azmat Hayat showed you those good circuits of arrhythmias in structurally normal hearts. But if you have that re-entrant mechanism with the scar and re-entry, EP study is kind of, you induce tachycardia, induce re-entry, and have arrhythmogenesis, and you confirm that this patient has a tendency to develop ventricular arrhythmia. But it is an invasive test, and recently there has been some renewed interest. We know that the MUST trial stratified patients using EP study, and the MADIT-1 also used EP study to stratify patients for ICD implantation. But these were like the late 90s and 2000, so it has been renewed interest. And two studies from Australia, and they're observational studies, and they recruited more than 1,000 STEMI patients, median of 9 days after MI, and did the EP study in patients who had an EF less than 40%. And both studies demonstrated that the patients with inducible VT at EPS had a high rate of spontaneous ventricular arrhythmias, with a high proportion occurring within the first 40 days. And patients who were not inducible during EPS were discharged without a defibrillator, and they had a low occurrence of arrhythmic mortality. So there has been some interest in with the EP studies. This is an ongoing multi-center randomized control trial, which will assess the role of EPS to guide primary prevention ICD implantation within the first 40 days after MI, and maybe we can get some answer when the results would be available. About cardiac MR imaging, in patients remote from an MI, talking about patients who have had a scar and late after an MI, a relationship between peri-infarct tissue quantified at CMR, which is called the gray zone. So it's you have the infarct tissue and the peri-infarct tissue, which is called the gray zone, which you can see on cardiac MR. So ventricular arrhythmia correlation has been found with that gray zone. Despite promising results of CMR in risk stratification in the chronic stages, there's limited evidence in the early post-MI period of doing CMR. However, this study, it's an observational study of some patients done in the first week, and they did CMR after a STEMI. At 2-year follow-up, they found that the vast majority of arrhythmias and sudden deaths occurred in patients with both EF, which was down less than 36%, and the infarct size was higher, as quantified by this 23.5 grams per meter square. And the infarct size at CMR was used in addition to LVEF and optimize arrhythmia risk prediction. So CMR does have a role, and some interesting data with CMR. For both sudden cardiac death risk stratification and ablation planning also, and this is something like computer modeling of the arrhythmia and using CMR guided images So they create a 3D computer model of a MI patient's individual heart. It's a personalized heart model. So it's like a virtual heart, which is constructed from contrast-enhanced CMR data. The heart model incorporates the patient's ventricular geometry and MI structural remodeling. And it creates a personalized part of the model, as well as the electrical functions from cellular level. So this was from the Johns Hopkins group, and they're working on it. And they have done some simulations. So they pace-induced ventricular tachycardia. These few images show the gray zone on the left, and the scar. And then this is VT induction and VT stimulation. So you can see the re-entry on the C, the endocardial, the scar, and the re-entrant circuit, and the VT originating. And that's the activation map. The D is from the epicardial. So they stimulate. They have their CMR images, and they can outline the circuit. And it has also been used to guide VT ablation. So very, very interesting CMR data. Now something very late-breaking trial, ESC, EHRA 2022. So it's a PROFID trial. So it points to the role of CMR in predicting sudden cardiac death risk and aims to develop a risk prediction model for identifying which patients will benefit from ICD. So a lot of research is being done with imaging. And then finally, for risk stratification, they have multivariable models. So they have also been assessed to see the competing risk between arrhythmic and non-arrhythmic death. So whenever a patient who is at risk for sudden death, there should also be a consideration for non-sudden death, other than arrhythmic death. So the studies have shown that from the MADRID population, there was a risk model, MADRID2 risk model, a FADES risk score, and recently the Seattle heart failure model and Seattle risk proportional model can also characterize patients who are higher risk of sudden death post-MI. So in conclusion, although the overall risk of sudden death has declined in the contemporary era, it remains unacceptably high in the early post-MI period. And impaired LV function, although routinely used to guide remote post-MI implantation, is neither sensitive or non-specific for arrhythmic death. And non-invasive markers of autonomic dysfunction have proved to be successful in selecting patients for defibrillator implantation. And a combination of CMR and EP study using an optimal induction protocol appears to hold the most potential for risk stratifying these patients. Unfortunately, there will always be uncertainty around an individual patient's risk of sudden death, as well as a benefit associated with ICD implantation. And clinicians should educate patients about this uncertainty while following current accepted guidelines and risk stratification and implantation. And I'll just end with death is always sudden, however long one waits. Okay, thank you very much. Any questions? I'll be happy to take them.
Faisal, CMR is not available in all the hospitals. Is there any other alternative to predict this kind of VT in post-MI patients?
CMR I told you, and the other different risk stratification tools that I mentioned. So it was there in the presentation. The heart rate variability, the autonomics, the clinical risk prediction scores, the imaging, the EPS.
So which sort of patients you will subject them to MRI after myocardial infarction? Obviously, you can't subject everybody.
Yeah,
numbers are too many, you see.
Yeah,
so what are the markers that will you pick up these patients and do an MRI?
So in the initial post-MI period, if a patient has a low EF, he certainly would be at high risk for sudden death. And the debate is that how to select these patients and how to risk stratify them and identify who will benefit from an ICD. So then CMR would not be done for all patients. We just do an echo and see the EF. And if the patient has some Other things like in the hospital that the patient had some arrhythmia or is having some non-sustained ventricular tachycardias or things like those. Maybe those patients would be some subset of patients who you will do some risk stratification in predicting as if they have a higher risk, or maybe consider a wearable defibrillator for prevention of sudden death in that initial period.
My question was, starting with the comment that all the modalities of treatment tend to affect the people who have the maximal effect of the disease. Like the ACE inhibitor in the initial trials worked best with people who had worst LVs. Surgery had best outcome in patients who had worst LVs. Similarly, the landmark trial for me was the MERIT-2, which came out 10 years ago, that maybe more than 10 years now, that if you put an ICD in a person 30-year ejection fraction or less, the annual mortality in that study, if I remember correctly, came down from 30% to 2%. I was really amazed how could this happen when there was no substrate for VT. And now we talk about the scar and the VT, and you cannot get rid of the scar, but so lower the ejection fraction, more the scar. That stands to logic. And so more the substrate for scar, more the benefit from an ICD. And then, of course, then you talk about how to locate this, map this scar with mapping and with MRIs. You can take all the modalities. Now, ejection fraction would, on an average, I'm sure, if you put them together, correlate together. So for a basic concept that we talk of all these drugs and different modalities, I think this ejection fraction and ICD seems to, that trend seems to continue and persist in whichever modality we go and however we look at it. That was the comment I want to make.
Kindly forgive me for a very naive question. Structurally normal heart, VT, no scarring, no myocardial infarction. Have we ever considered endocrine metabolic abnormalities that may induce VT? And do we do any basic workup on these patients or not?
Endocrine abnormalities like hyperthyroidism or hypothyroidism or Cushing's syndrome, probably. So these may act as triggers by increasing the heart rate and increasing the adrenergic drive, which may predispose these patients to arrhythmias. But it just would at best be like a trigger. So the substrate would be there for an idiopathic VT, but it needs to have a trigger, and the trigger would be can be electrolyte endocrine abnormalities. We don't really do it unless the patient also has some other evidence of clinical features of endocrine abnormality, but usually it's not done.
Faisal, I was just asking about two prongs of my question, because we have limited resources. We can't put ICD in every patient. We see left, right, and center, sometimes even primary prevention, for sake of primary prevention, patients are getting ICDs, and once you have a patient who already had a cardiac arrest, you don't have its availability there. So what are those who are very high risk and should be considered as the prime, that these are the patients, they should have ICD, irrespective of that whole list of indications? Second, how important is it, since you discussed about variability, autonomic variability as a very important factor, optimize beta blocker prior to, especially in a primary prevention patient, we see patients with heart failure, 80, 90 rates going on. Nobody really tailor-made their management according to the guideline based on especially controlling rates and optimizing ACRBs and others. So what's the role of these things in preventing cardiac deaths, or especially arrhythmic deaths? And who should be given ICD out of those all indications as a prime risk?
Okay. Beta blockers, obviously, data from early 90s has shown a mortality benefit post-MI, and that it should be optimized. There's no two things about that. The patient's heart rate should be controlled very well. Beta blockers should be titrated to the maximal tolerated doses. So that is fine. So general rules of indication for ICD will be guidelines. So for primary prevention ICD, as I told you, so it's very clear with EFs from different trials, 35, less than 35% and 30%. It's only in the immediate post-MI period that you have debate as to how to risk stratify those patients. So I'll just go with guidelines and see what the guidelines have to offer for ICD recommendations generally.
It's an excellent question, I think, and all the time it's been asked to us that how you identify a very high-risk population who needs an ICD. So I think one thing which we have to assume, the tools that we have at the moment, they are not excellent tools to identify the real high-risk population. What we have is probably the left ventricular ejection fraction, which is again not an excellent tool to identify real high-risk population. But I think Saira probably have something to say about the MRI guiding us, especially in non-ischemic cardiomyopathy. I think Faisal will agree to it as well, that if the LGE is more than 20%, that probably gives you a better high-risk population to identify those patients who are at risk of sudden death. Whether that will translate to patients with ischemic cardiomyopathy, I think there are still trials which is happening at the moment, but probably the imaging modalities, especially the MRI and the use of MRI in these populations, will guide us about the specificity of how to identify those high-risk population. So until then, we only have the tools that we have at the moment.
I think I can see the moderator time-wise. Okay. So I request my co-panelists to give their short comments and then we conclude. So.
Sure. Go for it.
Whenever we have patients who has been referred for ICD, I think we always come across that their anti-heart failure and anti-ischemic treatment, most of the time, they are not optimized. So whenever we saw those patients who are having appropriate ICD shocks, we always just concentrate on the IV oral imidazole. But all the other guideline-directed medical treatment, they are anti-heart failure, anti-arrhythmic, especially ARNI, empagliflozin, beta blockers, and mineralocorticoid receptor antagonist. So I think takeaway message from my side is that we not only have to concentrate what's the effective, we just have to concentrate on what are the other options just to modify the arrhythmogenic substrate by just looking at the guideline-directed medical treatment. That's the best way of reducing the appropriate ICD shocks and all those things.
Thank you so much.
I think for the sake of time, I will skip my comments.
Do you want to say a few words? Can we proceed with the shield distribution? Dr. Imran Majid, I would like to call General Dr. Imran Majid to come on stage and proceed with the shield distribution to the panelists and speakers. First, Dr. Azmat Hayat. Actually, they have. Our next speaker, Dr. Faisal Kader. Professor Mohammed Ishaq. Dr. Liaquat Zaman. Where's Dr. Dr. Abdul Manan. We'll be going for a short tea break. So see you all after 20 minutes.
10 minutes.
20?
10 minutes.
10 minutes, okay.
So we have tea at the back and we can take it and then we can start the session again in 10 minutes. Thank you.
Everyone. Okay, everyone, let's get seated. Okay, everyone, let's get seated. We are going to start our next session. Please take your seats. I would like to call Professor Feroz Memon to the panelists. Professor Feroz Memon is Vice Chancellor of University of Modern Sciences, Tando Mohammad Khan. And Professor Ashraf Dar, who is Consultant Cardiology and Electrophysiology and PIC. And Professor Shahid Memon, who is Associate Professor at Liaquat University of Medical and Health Sciences of Cardiology and Interventional Cardiology. Our next session is on primary prevention in sudden cardiac death in non-ischemic cardiomyopathy. Who should we offer? And for that, I would like to invite Dr. Faria Sadek, who has completed her fellowship in electrophysiology from Canada and is Director of Medical Education at Taba Heart Institute and electrophysiologist at the Taba Heart Institute.
Assalamu alaikum, everyone. Thank you very much for joining us here for this summit. The topic that I'm going to talk about is primary prevention of sudden cardiac death in non-ischemic cardiomyopathy. And the punchline is, who should we offer? And there was a lot of question from the audience. Please identify the highest risk who will benefit from the ICD. So this I'm going to take forward. Dr. Faisal Khader made a very nice presentation on ischemic cardiomyopathy, and just taking that forward, I'm going to talk about non-ischemic cardiomyopathy. We all are aware that patients who have heart failure and LV dysfunction, they not only die of pump failure, but also because with ventricular arrhythmia. And we all know that intracardiac defibrillator is a tool available to us that we can use and has a proven benefit for prevention of sudden cardiac death. But the question is this tool equally beneficial to all cardiomyopathy groups? And unfortunately, it's not. There's a discrepancy in the benefit of ICD in cardiomyopathy based on the etiology. So ischemic cardiomyopathy, we have all seen proven results, massive large trials showing all-cause mortality. And unfortunately, all the trials to date, including the latest Danish in 2016, it has not shown any mortality benefit in non-ischemic cardiomyopathy. However, the risk of sudden cardiac death or arrhythmic death in non-ischemic cardiomyopathy exists, and it is actually benefited with ICD. So while we are talking about the discrepancy in the benefit of ICD, we also need to take into account the cost effectiveness of ICD in various groups. And we all know from the trials that the incremental cost-effective ratio is very, very high for non-ischemic cardiomyopathy as compared to ischemic cardiomyopathy. So with all this data of ischemic and non-ischemic cost-effective and benefit, what do we do with all this data? Should we not implant ICD in non-ischemic cardiomyopathy in general as a population? I think that's not the plain, simple answer. The answer is that we should be able to risk stratify in a better way to identify the highest risk group that will benefit from ICD and also be able to identify the patients who will not benefit and get a harm of it. So we should be able to identify at least 2 groups. And in that way, we will be able to channel our resources effectively to the healthcare, and we will be able to give personalized device care to the patients. Historically, the arrhythmic risk classification has been based on ejection fraction and heart failure classification. But the trials have shown that all patients who get, and I'm talking about non-ischemic cardiomyopathy as well, all patients who get guideline-directed primary prevention ICD, only 20 to 25% of patients will need therapies from the device in 5 years. And so what about the rest? We implanted device, and it's not useful for them. So we need to go beyond ejection fraction. And this actually shows us that at a given level of ejection fraction, there will be 2 kinds of death in a patient: all-cause mortality and arrhythmic death. With progressive decline in ejection fraction, the proportion changes. With lower and lower ejection fraction, the arrhythmic death decreases. So, and it's very challenging to make a decision of primary prevention ICD on just ejection fraction. So we should have better tools, better parameters to make us more informed in making decisions for the device. This chart will show us what other parameters that we can use other than ejection fraction. So the first thing is, how can we risk stratify patients who will have highest risk based on their personal and family history? So somebody who has disease of non-ischemic cardiomyopathy of a very long duration may have high risk of arrhythmic death. Those who have unexplained syncope and those who have family history of sudden cardiac death will have high risk. On the contrary, those who have advanced heart failure, their risk of dying with pump failure would be greater than with arrhythmic death, so we can make that difference on history. Now, what about the etiology of non-ischemic cardiomyopathy? The low risk is found in patients who have etiology of non-ischemic, which can be reversed or they can be treated, like myocarditis, alcohol, or tachycardia-induced cardiomyopathy. On the other hand, those who have familial cardiomyopathy, especially with lemon gene or SCN5 gene, they have highest risk of dying from non-ischemic cardiomyopathy. So it is very prudent to say that genetic workup should be performed in individuals who we think may have a genetic predisposition to cardiomyopathy, and it should be part of workup of cardiomyopathy. Now, what about the ECG? Can ECG help us in risk stratifying? Yes, on the ECG, you can have a fragmented QRS. That will be a high-risk predictor. You can have a longer QRS duration as a predictor of sudden cardiac death, arrhythmic death, and also presence of non-sustained VT, frequent ventricular ectopy, or couplets on a 24-hour Holter monitor. So we're moving forward and looking at many other parameters. Then imaging. We underestimate the imaging and we just rely on ejection fraction, but we have many imaging modalities that help us to risk stratify, and among them all, cardiac MRI actually stands out. It is one of the most important tools in predicting arrhythmic death in non-ischemic cardiomyopathy. We have strain pattern imaging on LV on echo, but it is developing and we don't have data on it to say for sure, but for cardiac MRI, we have definite evidence that LGE presence is a high-risk marker. Also, the distribution of LGE may also predict the risk of sudden cardiac death. And this cartoon from 2021, and I'm just only going to focus on the top of the pyramid, which is the highest risk. Somebody has an ejection fraction of less than 35%, non-ischemic, and they have LGE positive. They fell into the highest risk category, and they will definitely benefit from ICD. And patient who has, at the bottom of the list, lowest risk, less than 1%, are those who have ejection fraction between 20% and 35%, low ejection, but they're LGE negative. And surprisingly, you'll see that they fall into the lowest risk. So we now identify two patient population, highest risk and lowest risk, and we can make informed decisions for them. Nevertheless, talking about all these parameters, the biomarkers are very in. We use them to risk stratify our patients for heart failure, and make our treatment strategies. The natriuretic peptides also may help us risk stratify, and from the Danish study in non-ischemic, the level of 1177 was used as a marker for ICD benefit and lowering the all-cause mortality. However, beyond this cutoff, there was no mortality benefit with ICD in non-ischemic. So what does this mean? That we can use the BNP levels to risk stratify patients who will die from heart failure and will not benefit from ICD therapies. Now, coming on to, after talking about all the bad prognostic markers, let's talk about a good prognostic marker. Left ventricular reverse remodeling. We don't talk about it much, but it's actually a good prognostic marker. And what does that mean? That we were able to increase an ejection fraction by 10% and increase the LV end diastolic volume within 6 to 18 months by 10% after the diagnosis. Now, this is a good sign. What are the positive predictors of reverse remodeling? If you're able to identify those patients who will have good prognosis and have good reverse remodeling, we may be able to withhold our therapies. CMP, secondary to inflammatory and post-myocarditis, means they will recover and they will not have scar. That's a predictive for left ventricular reverse remodeling. Those who have hypertension at baseline will have a positive prediction because you may be able to use drugs that will reverse remodel. Shorter duration of symptoms will have a better reverse remodeling. Patients without family history of cardiomyopathy will have better reverse remodeling. Those with a narrow QRS will have less scar and better reverse remodeling. Ironically, if you look at the guidelines, they say wait 3 months with GDMT and then assess for ICD. Well, the LV reverse remodeling actually starts at 6 months and they may continue up to 2 years from the initiation of therapy. So what does that mean? Should we wait for 3 months? Should we wait for 6 months? Well, if we figure out that patient will have a positive response based on the parameters, we can actually wait for that 6 months to 2 years. And this was published in 2021, showed there was no increase in lethal events or cardiac events if we kept waiting on patients who had positive predictors of left ventricular reverse remodeling. So we have to be confident on patient history and the clinical predictors to give them that chance and withhold therapies for that time. Now, how do we reverse remodel the patient? We have both pharmacological and non-pharmacological therapies. Beta blockers, top of the line, understanding that it is a time-dependent reverse remodeling agent. So we need to give beta blockers a time. MRAs, they also have both time and dose dependent. ARNI, our best friend nowadays, actually has dose-dependent reverse remodeling. So just initiating a teeny-mini peanut dose does not mean that it's going to work for you, for that patient. So we have to give dose-dependent, time-dependent drugs. And in the end, I'm going to talk about the non-pharmacological therapy, the CRT, which has a very positive response on left ventricular reverse remodeling, more pronounced in non-ischemic cardiomyopathy, and that I say because in patients who have left bundle branch block, they do not have a better LVR response on medications. So with medications, if we give them CRT, because it's an electrical dyssynchrony, we may enhance their left ventricular reverse response and reduce the need of primary prevention ICDs in them. Now, the question that we ask ourselves, if a patient is going for CRT, should we give them P or D? Well, again, the same thing, risk stratify based on the LGE, based on the reverse remodeling criteria, and then make an informed decision of whether this patient will benefit from primary prevention ICD in non-ischemic cardiomyopathy. So those who have high risk of dying from sudden cardiac death will benefit from CRTD, and this is a very small group of patients in non-ischemic. This is my final slide. crux of all the presentation. How do we go about if a patient has non-ischemic cardiomyopathy? The first thing is we identify high-risk features. If somebody has positive LGE with non-ischemic cardiomyopathy with high-risk distribution, or they're genetically positive for lemon or SCN5A gene, we give them ICD. Then, if they don't have high-risk features, we talk about special population. If the patient falls into a special population, means that they are renal failure patient, dialysis dependent patient. They are old age patients, 70, more than 69 years of age. They are pediatric population. Or they have class 1 or class 4 heart failure where the data is not existent for primary prevention. Or they have adult congenital heart disease. If your patient falls into any of these criteria, then the decision would be individualized. It will be a shared decision with the patient and for the need of device. Now, if your patient either does not fall into high-risk category and does not fall into special population, and most of the patients will fall into that, then we look for the presence of predictors of LV reverse remodeling. So if they have narrow QRS, absence of LGE, hypertension, absence of family history, shorter duration of symptoms, and absence of a genetic variant, they have good predictors. You can wait on them. And while we are waiting, we should consider clinical follow-ups, Holter, echo, and ECG. But if they have no reverse remodeling parameters, you can offer them ICD as a treatment strategy. So with this, I thank you all for patiently listening to my talk, and I'm hoping to answer questions after the second talk, and if the moderators allow me to do that. Thank you.
Thank you, Dr. Faria. And now I would like to call Dr. Qurban Hussain for a next talk on VT storm. Dr. Qurban has completed his fellowship in electrophysiology from AFIC and is assistant professor of electrophysiology at Rawalpindi Institute of Cardiology.
Assalamu alaikum, everyone. I just want to commend Dr. Fariha and all of the other speakers. Just excellent presentations. I hope I can follow suit. I'm going to talk to you about a topic which is very scary for most people, very scary for most doctors. It's ventricular tachycardia storm, otherwise known as electrical storm. This is the way I like to think of it, electrical storm. It's very scary. It's thunder, it's lightning, it's loud. There's very few things that terrify a cardiology or an electrophysiology trainee more than someone who's getting repetitive bouts of ventricular tachycardia, which obviously is a terminal rhythm. So what am I going to talk about today? Well, I'm going to focus on initial definition, etiology of VT storm or electrical storm, a few basic management steps, and if there's time later on, we can talk about a few MCQs. So what is electrical storm? Well, it's a syndrome of recurrent episodes of sustained, not non-sustained, sustained ventricular arrhythmias in a very short time frame. How short and how many? Well, we typically talk about three or more ventricular arrhythmia episodes within the space of 24 hours. And if you have an ICD, then the definition encompasses 3 appropriate shocks, emphasis on appropriate shocks from your ICD within a period of 24 hours. 3 doesn't sound like a lot, does it? But often these people present with much more than 3. You can get people with 50, 60, 20, 30, and it's very scary. Why does electrical storm or VT storm matter? It shortens your life. There is data showing that even if you have 2 ventricular arrhythmia episodes occurring within quite a long time frame of 3 months, it actually increases your mortality. These events, they occur in clusters. There is a 2.5-fold increase in mortality in patients with electrical storm compared with non-clustered VA, ventricular arrhythmia. And there's a 3.3-fold increase in mortality compared with people who have no sustained ventricular arrhythmia. So this matters. This really does. Why have I brought up this slide of pathophysiology? Pathophysiology slides often come up when the understanding of the pathophysiology is related to the understanding of the management. You need three things to occur when you have electrical storm. You need a substrate, which is usually a myocardial scar in the case of monomorphic VT, arrhythmia syndromes like long QT and other channelopathies. They can think of them as a substrate as well. You need a trigger. Those of you doing cardiology, think of the 4 H's and the 4 T's that lead to ventricular tachycardia, so ischemia, metabolic, toxins, drugs, thrombosis, all these types of things. And the important one here, very important, autonomics, adrenal hypertonia. Your sympathetic system is going crazy, and you may have a suppression of your parasympathetic system. Now, this is very important because in terms of your therapeutics, this is what you can target. You can target this, but provisionally or initially, this is what you can target in everybody. So who gets electrical storm? The usual suspects: structural heart disease causes monomorphic VT, inherited channelopathy causes other types of VT like polymorphic. Ischemia is a trigger. Electrolyte disturbances are a trigger. Worsened heart failure, sepsis, these are all triggers. This is one that all electrophysiologists are familiar with, people not taking their medications or not taking their medications properly. And obviously, bradycardia can lead to torsade de pointes. And how does it present? Well, the typical, the scary example is people with ICDs, without ICDs, repetitive, getting VT again and again and again. You can get syncope, you can get heart failure, you can get cardiac arrest. In some patients who are slightly luckier, instead of getting shocks, the VT doesn't cross the threshold for shock, and the patient reverts with repeated anti-tachycardia pacing. This is important because of something we're going to talk about later on related to mortality. Okay, so what do you do? Well, what do you do in any cardiology patient? The first thing you do is you assess their hemodynamic status. Do they require resuscitation? Do they require any kind of compressions or DC cardioversion? Go down the ACLS pathway. Very important this, and it's an important concept. Shocks are bad in this situation. Shocks are good in a situation where you're getting an isolated ventricular arrhythmia. The ICD is doing its job. But if you're getting VT again and again, and the device is shocking, whether the shock is appropriate in the case of the VT, or whether it's inappropriate in SVT, recurrent shock increases your mortality. It's a very bad thing. Search for potential triggers. This is quite exhaustive. Ischemia, electrolyte abnormalities, hypoxia, all those things you need to search for. But this is a basic schema for your management, and we'll get into management in a bit of greater detail. So what do you do with your ICD patient who presents with multiple shocks? It's kind of a positive feedback cycle, if you can imagine. You get a shock, you get more sympathetic overdrive, and as a result of that more sympathetic overdrive, you get more shocks. Shocks increase mortality. So the distress, the anxiety, the sympathetic activation promotes and sustains ventricular arrhythmias, which then causes more shocks. We've mentioned that shocks increase your morbidity. Importantly, they increase your mortality. So you need to do an urgent device interrogation. And this is something I want to emphasize particularly to this audience, that if you're a cardiology trainee, you need to know how to use the programmer. You need to be confident enough to put the wand on the patient and then communicate with your electrophysiologist, or if you're very good, you know what to do. Interrogation tells you, is it an electrical storm? Is it something else? Is it VT or is it SVT? Is it monomorphic VT or polymorphic VT? Hopefully you get an idea on your ECG. And also importantly is the initiation of that ventricular arrhythmia. Is it because of a PVC, for instance? Is it one PVC comes and leads to the initiation of that ventricular arrhythmia, or is it something else? So critical step in an ICD is getting the wand on the patient and looking at the programmer. All right, what do you do then? So you can disable shocks. That's the best thing that you can do in this situation. You can prolong the detection time. There is a detection time, a fixed number of seconds, sometimes 30 seconds, sometimes longer. You can focus on anti-tachycardia pacing. You can make it do anti-tachycardia pacing, more, focus on your anti-tachycardia pacing, so when you get VT, it does anti-tachycardia pacing, because anti-tachycardia pacing does not increase mortality. So that's the emphasis. That's what you do with your ICD programmer. This is a diagram. If you're going to take one thing from this entire presentation, it is this diagram. Okay, so if you were switched off for the beginning part of it, this is the one part you need to be switched on for. So, VT storm. There's a picture of a device electrogram going on there. There's VT going on and then a shock. So, ICD reprogramming, very important. Antiarrhythmic drug therapy, I'm including beta blockers in this. Very, very important. Suppress that sympathetic drive. Get the patient to calm down. So sedation is going to be discussed as well. Ablation, if it's still not working, consider ablation. Ablation in people with recurrent shocks or people with recurrent VT is an option. I'm going to talk about data from the VANISH trial. And there are advanced therapies, such as thoracic epidural anesthesia, denervation, and other therapies that we're going to talk about. So this is the diagram, this is the management, this is what you need to know. This is another way of looking at the diagram. You've got electrical storm, hemodynamically unstable, we know that you go straight to the ACLS protocol. Recurrent ICD shocks, disable your tachycardia therapy by placing a magnet over the device. So a magnet will turn off your anti-tachycardia therapies. In a pacemaker, a magnet will lead to pacing in asynchronous mode. Pacing will carry on if you put a magnet on an ICD, but tachycardia therapies will be disabled. Next, beta blockade is usually appropriate. Beta blockade dampens down your sympathetic nervous response. You need to treat reversible causes like electrolyte imbalance, myocardial ischemia, heart failure, and bradycardia-induced torsades. And if there's ongoing ventricular arrhythmia, then you can upgrade your pharmacological therapy, deep sedation, which is what we're going to talk about in a few minutes, catheter ablation, and these are, if it's still not working, things like ECMO, VADs, or LVAD, and cardiac transplant. If you have the facilities, then this should be in your mind, and it should be in your mind anyway if you're training, because you need to know all the options, whether they're available in your country or not, you should know. Beta blockers first. If you don't have hemodynamic compromise, beta blockers are your first line drug. IV esmolol and propranolol, either IV or oral. IV is obviously better initially. It dampens your sympathetic activation. There is evidence that propranolol and esmolol are superior to sympathetic beta-1 receptor antagonists. Amiodarone, the electrophysiologist's worst enemy. We usually discourage use of amiodarone, but in this situation, it is highly synergistic with beta blockers. The two of them work together and they dampen your sympathetic nervous system. Amiodarone blocks lots of receptors, potassium, sodium, and it works with the beta blockers to dampen the effect of the sympathetic nervous system. One thing you should know is amiodarone increases the defibrillation threshold, and that basically means that if you give enough amiodarone, eventually you need to have a higher energy output in order to achieve the same response. So there's one counter effect of amiodarone. Long term, we all know amiodarone has lots and lots and lots of side effects. So in the short term, it's great. Load the patient up 1 gram, 1.2 grams of amiodarone along with your propranolol or IV esmolol. It's a great first option pharmacologically. Lidocaine works by blocking late activating sodium channels. It's brilliant for ischemia. It's not so good with healed myocardial infarction. There was a famous trial in the year 2018 where they compared upgrading your antiarrhythmic therapy in people with VT using mexilotine, which is an oral version of lidocaine. It's a class 1B channel blocker. And it was found that catheter ablation of VT was superior to adding antiarrhythmic drugs. So if you get to a point where you're adding lots and lots of antiarrhythmic drugs, you should be considering ablation, because ablation has been found to be superior. This is a very complicated diagram, but I just wanted to go through the options for pharmacological options for what you have to do when you're dealing with a VT storm. Monomorphic VT and most forms of VF, the first thing you do pharmacologically is amiodarone beta blockers, amiodarone beta blockers, amiodarone beta blockers. The exception is Brugada, where quinidine is useful for VT storm, isoproterenol. When you have a polymorphic VT, then lidocaine comes into its own with a normal QT. And if you have a prolonged QT, then you want to shorten that QT. So what do? You can pace, you can add isoproterenol, and you can consider replacing magnesium and potassium, which is often involved in the etiology of these prolonged QT polymorphic VTs. Sedation, very, very, very effective treatment. Very effective treatment. Don't be put off by sedation. If you sedate the patient, you are reducing their sympathetic drive, which is part of the pathophysiology of this disease. If you have a good response, if you have a termination of your VT within 15 minutes, it's associated with a 55% lower risk of death. So this is great. It's a predictor of in-hospital survival. Not out-of-hospital survival, but in-hospital survival. And the great thing is that if you sedate these people, 47%, half of them, they get better within 15 minutes. So it's a great treatment, and you should consider it after you're using your beta blockers and your amiodarone. This should probably be next line. You need to be aware of myocardial depressant action of sedative drugs. So this is an algorithm. You've got an intractable electrical storm. Use antiarrhythmic drugs, beta blockers, amiodarone. Consider lignocaine or lidocaine if there's an ischemic element. Go for deep sedation. Still not working, then you can consider hemodynamic support, catheter ablation, and neuroaxial modulation. And this is the data of acute termination with sedation. So the red is no acute termination, and the blue is acute electrical storm termination. And this is the mortality. So obviously the mortality is greater if you don't manage to terminate with sedation. Catheter ablation, very good for ischemic cardiomyopathy, where it's a class 1 indication in drug-refractory VT storm. It's a class 2A indication for non-ischemic etiologies. As I mentioned before, the VANISH study, you've got patients who took amiodarone with ischemic cardiomyopathy and VAs. They benefited from ablation compared with escalation of anti-drug therapy with high-dose mexilotine. All right, methods of autonomic modulation. Not going to go into it. I wish we had more of this, more data on this, particularly in Pakistan, but the centers where people know what they're doing with this are getting great results. Thoracic epidural anesthesia, you can go to your anesthetist and get that done. Percutaneous stellate ganglion blockade, use ultrasound and inject long-acting anesthetic in the area of the stellate ganglion. Surgical cardiac sympathetic denervation, they're doing that in some centers. There's a risk of Horner's syndrome, obviously. Renal sympathetic denervation, doing it in selected centers and getting good results. That's something you need to think about once you've tried your antiarrhythmic drugs, you've tried your sedation, ablation, and still not working. This is the next step. Then you get to sort of more experimental treatments. This is ECMO. ECMO is a bridge to definitive treatment, such as ablation in some cases, or cardiac transplant, if you have those options. This is a basic diagram of everything we've talked about. So initially, you've got these episodes, acute care, if hemodynamically unstable, ACLS protocol, identify reversible causes, amiodarone and beta blockers, procainamide and lidocaine if appropriate, deep sedation, and then alternative treatments such as device programming, autonomic modulation, hemodynamic support. Okay, MCQs, we'll just do one MCQ, and it's for the trainees really, and then we'll stop. Easy question. 55-year-old man, history of ischemic cardiomyopathy, EF 30%. Presents to the ER with palpitations, blood pressure's okay, oxygen saturation's okay, respiratory rate is okay, he's got monomorphic VT, he's been DC cardioverted 6 times in the last hour, but each time he's gone back to VT. His labs are normal. So which option out of these represents optimal pharmacological therapy? Is it amiodarone and mexilotine, lidocaine and mexilotine, esmolol and atenolol, double beta blockade, amiodarone and oral propranolol, or amiodarone and metoprolol? A, B, C, D, E. Okay, good. D, beta blockers suppress the drive. Propranolol is superior to metoprolol, and beta blockers are synergistic with amiodarone. Let's do another one. The same patient that we discussed before remains in VT despite treatment with IV amiodarone and oral propranolol high dose. Which of the following is the best option? Is it ECMO, sedation, sotalol, quinidine, or put an ICD in? Okay, deep sedation, well done. ECMO is last resort. Sotalol we don't give with propranolol. Quinidine is effective in Brugada syndrome, but not in this situation. And ICD, before you control your rhythm, is crazy because the patient's going to get shocks again and again. This is the diagram. Okay, that same patient is still, despite deep sedation, here in VT. What's the next step? Is it A, catheter ablation, B, ECMO, calcium channel blocker, digoxin, or mexilotine? Which one is it? Excellent. Geniuses, all of you. So it's catheter ablation, sedation, and all that other stuff you've done. Mexilotine, we know, is not as good as ablation. ECMO is a last resort. You wouldn't really put digoxin and calcium blocker in a scar-related VT. Okay, basically 20 seconds. ICD implantation patient presents to the ER with several shocks. 26 shocks in the last 8 hours. Which of the following is the best one to do? Increase the energy of the shocks, decrease the energy of the shocks, turn off shock therapies temporarily, only turn off tachycardia pacing, or do not reprogram the device. Well done. Device shocks are associated with increased mortality. Anti-tachycardia pacing can be used to treat, and ATP doesn't increase mortality. And that's it. Thank you very much.
Thank you, Dr. Kurban. So now we can have panelists' opinion and question and answers for the next 10 minutes. Can we have 10 minutes on the clock, please?
I don't see any question coming up. I must say this was an excellent talk. Azam, you want to?
I thought both excellent talks, I must say. I really enjoyed them. I just wanted to add something to what Dr. Kurban was talking about. I think one of the, when we talk about mortality and acute outcomes of an electrical storm, those are all fine in that space that we are in. But keep in mind that these have really very severe trauma. These patients suffer from post-traumatic stress syndrome after this, every time they have shock. So they end up having extreme anxiety when they leave the hospital and often coming back with phantom shocks and other issues. What I found very useful is that, as soon as somebody gets a shock, in addition to my amiodarone and starting them on propranolol, I start them on something for like benzodiazepines or something to get rid of the short-term memory so that they don't remember this as much. And I find that that is very, very helpful in the long term. So I would urge, and such patients, I often tell them to keep this with you. Take your Lexotanil before you come to the hospital or as you come to the hospital. And I think this is an analog to what Dr. Qurban was talking about in terms of deep sedation. It's certainly a very underutilized modality that we have. So certainly our colleagues, we often put these patients in the ICU, and we have them with backup of sometimes intubating them and sedating them. So all in all, two excellent presentations, thoroughly enjoyed them, and congratulations to both the speakers.
We do discussed about VT storm in a patient who are having instability. We do get some time while treating ischemia and other issues, the patients repeatedly having non-sustained VTs without symptoms, short runs of VT, and they're in sinus rhythm, and that's repeatedly going on. So what to do in that particular situation without symptom?
Qurban?
I was just talking to my teacher, or the teacher of my teacher, General Imran, and he said the first thing to do is not to panic. And I would emphasize that. Yeah, well, I didn't want, I used the English version, I didn't want to go down that route. VPC or PVCs have different functional significance. I think, in my own limited knowledge and understanding, I think it depends on the context. Is there structural heart disease? Is there no structural heart disease? Is there a family history of sudden death? Where are they coming from? Are they coming from the outflow tract? Are they coming from somewhere else? Are they coming from a papillary muscle? All these things, they do matter. So, and how much? I mean, is it, we know that PVCs, even what you might think of as PVCs from a relatively benign area, such as the outflow tract, we know that if you're getting more than 20%, some say 10%, that this can lead to non-sustained. I would say, in my practice, I think of non-sustained and PVC in the same way. Maybe other people would disagree with me. We treat, in our center, we treat them pharmacologically, and we, exactly the same things apply that I talked about, the principles of non-sustained VT. Are they symptomatic? What is the burden? And we would ablate if somebody was getting very, very symptomatic and they were in an area, whether it was, if it was structurally normal heart, we consider ablation if a patient has non-sustained VT, but we primarily manage pharmacologically.
Qurban Sahib, if I may ask a question, and excuse my way of putting it, may sound not very serious, but it is. Like Pitas Bukhari said, कि भौंकते कुत्ते काटते नहीं हैं, but what to say कि भौंकना बंद कर देगा और काटना शुरू कर देगा. So at what point does non-sustained become sustained, and can you rely on this discrimination?
The technical definition,
because we have an arbitrary number of saying this is sustained and non-sustained.
Sustained and non-sustained, if you use a temporal relationship, sustained VT is any VT lasting longer than 30 seconds. And there's also a definition based on symptoms. If it's symptoms, by definition, it comes under, we manage it as a sustained VT. So 30 seconds or longer, or causing symptoms, or causing hemodynamic compromise. Yes, less than 30 seconds and hemodynamically unstable.
Okay, we do not have to worry. There is this not uncommon entity of what is called repetitive monomorphic ventricular tachycardia, typically coming from outflow tracts, more frequently from the right ventricular outflow tracts. Now, over the years, if you just follow them, nothing happens to them. Nature knows best. Some of the human body knows better than electrophysiologists too. So anything that is well tolerated by the body and doesn't disturb the autonomics, is not upsetting the body, let it be. और उसमें it's interesting because in all those studies where repetitive monomorphic ventricular tachycardia has been followed over long term, how many of them developed reduced ejection fraction? Very, very, very few. So, nothing. You know, if one is tolerating anything, just leave the guy alone. So we don't have to. We don't have to.
I think if the question was related to VT storm in a patient with an ICD, then there is a different answer. If your question is recurrent non-sustained VT in a patient who is symptomatic or asymptomatic, then there is a different answer. So I don't know which was your question related to. No, I was first asking the questionnaire that whether his question was related to a patient with ICD who is having recurrent non-sustained VT very frequent. I don't know what. Eh? No, so are you asking question of anybody with? No. Okay, so you.
Showing a non-sustained VT runs in between sinus rhythms. A number of times they are kept in CCUs or ICUs because of only that rhythm without symptoms. But now it's clear that if they are stable, they are tolerating it, there are no further symptom, then they should be treated as a normal. This rhythm shouldn't be treated. That's what I got from your explanation.
What Dr. Liaquat is saying, here comes a caution. What I was referring to was structurally normal hearts.
Oh.
But you know, if there is an underlying pathology, तो उसमें वो जो सुहेल कह रहे हैं ना कि a dog that is not biting may start biting. तो underlying structural heart disease में you would have a lower threshold to interject if you are having frequent ventricular tachyarrhythmias, which have as yet not started destabilizing the individual, may well start doing it. So आपके पास थोड़ा सा reaction time है, better act when there is known underlying structural heart disease or low ejection fraction.
Assalamu alaikum, Dr. Qurban. Very good talk. Just a couple of practical questions. One is about amiodarone. If you start someone on IV amiodarone, for how long you can continue if somebody is repeating? I mean, you are not able to put an ablation straight away. So for how long you can continue with IV amiodarone for these patients, number one. Number two, I think what Dr. Dr. Fawaz suggests, I think he's worried about the VT cardiomyopathy, you know, because we heard the term that the tachycardic cardiomyopathy will develop on the later stages. So if somebody is having continuously non-sustained VT, when we should worry about?
First question. When you're faced with that situation, somebody is, let's say they have an ICD and they're getting recurrent shocks, or let's say they don't have an ICD and they're still getting recurrent episodes of ventricular arrhythmia. I think you start off with a beta blocker, and amiodarone is synergistic, so you would load the patient, and then obviously you would monitor the patient. If amiodarone and beta blocker has worked, you've started the patient, you've loaded the patient on amiodarone, so I think you would need to play that out a little bit. You would need to, once you've loaded, you need to get the patient onto a maintenance dose, and typically you taper off the dose of amiodarone while maintaining a dose of beta blocker. At least that's the way we do it in our institution. Second question, I think, was about tachycardia-induced cardiomyopathy. It's sometimes very difficult to make the diagnosis of tachycardia-induced cardiomyopathy, because when you have a cardiomyopathy, you are more likely to get re-entrant circuits, you're more likely to get a tachycardia. So your history certainly helps a great deal. If you've got an echo after the tachycardia or before the tachycardia developed, before the patient's symptoms develop, then that is useful. There is research on this. It's an ongoing area, but to the best of my knowledge, there's no kind of 100% sensitive and specific way of telling. You need to go back to the history, you need to go back to the echo, you need to go back to the Holter and sort of put it all together in your head. Thank you.
Okay, thank you, Dr. Qurban. Now I would like to call upon Dr. Azam Shafkat to present the shields to the presenters and the panelists. Dr. Faria Sadeh. Dr. Qurban. Professor Feroz Memon. Professor Ashraf Dar. And Professor Shahid Memon.
Thank you. We'll be starting our next session. It's on heart failure. And for that, I would like to call panelists on stage. Dr. Nadeem Hassan Rizvi. He's a professor of cardiology and interventional cardiology at OMI Hospital. Dr. Fawad Farooq. He's a professor of cardiology at NICVD. Dr. Suhail Abrar, working as consultant cardiologist at Tabba Heart Institute and director Echo Services. And Dr. Faisal Ahmed. He is an assistant professor of cardiology at Liaquat National Hospital. Thank you. I would like to call next speaker. He'll talk on physiological pacing and heart failure. He has over 25 years experience in the field of cardiac pacing and clinical and interventional electrophysiology, and currently appointed as consultant cardiac and interventional EP at PIC. I would like to call Dr. Professor Ashraf Dar on stage.
Assalamu alaikum ji. So I will talk about the heart failure, few slides about the incidence and mortality, and then about the history of cardiac pacing, and then history of physiological pacing, and in the end I will discuss about the His bundle pacing. यार इसको देखो भैया As you all know that heart failure is a very, very dangerous and very it causes mortality and morbidity, and different types of heart failures are defined that heart failure with a preserved ejection fraction, heart with a reduced ejection fraction, acute heart failure, chronic heart failure. उधर से कर देना। मैं अपना लैपटॉप रख लूँ, हैं? हैं? अपना लैपटॉप रख लूँ, अगर हैं? आ गया? तो ये तो बहुत दूर चले गए ना आप। पीछे जाओ ना, शुरू में जाओ, फर्स्ट लाइन। यस यस, उधर से करेंगे आप। इधर आ जाओ। So heart failure is defined as the inability of the heart to meet the body's metabolic demands. It's a complex syndrome, and the epidemiology is about 6 million American people are affected with heart failure, and every year about 500,000 people, they are new diagnoses. People who develop heart failure, half of them die within 5 years. तो बेटा ये करेगा, कराओ ना काम। ये इधर रखो। अच्छा, ठीक है। So readmission and mortality, when the patient is admitted in the hospital for heart failure, the outcome is really bad. So after 1 year, readmission rate is about 50%, and 1 year mortality is about 35%. And this is the 10-year mortality figure. Females do better than the males, and then the 10 years, 80% people die from the heart failure. And some few slides about the conventional pacings. The first RV apical pacemaker was implanted in 1958 by Swedish surgeon Senning. And decade later, it proved to be non-physiological because a lot of people were having problem with the single chamber pacemaker, RV apical pacing. They were having pacemaker syndrome, they have an incidence of heart failure and atrial fibrillation due to AV dyssynchrony with the single chamber pacemaker, with the RV apical pacing. The term physiological pacemaker was, that comes into picture after the Canadian trial of physiological pacing. But that was actually a dual chamber pacemaker. They introduced the dual chamber pacing, and they thought this is more physiological because this decreases the AV synchrony. It restores the AV synchrony as compared to the RV apical pacing. But dual chamber cardiac pacing was introduced as a physiological pacing mode in that era. And then comes the mode selection study. This was published in like 2000, and this started in September 25, 1995, and this was actually a dual chamber pacemaker were implanted in those who have sinus node disease, and they actually randomized them with the single chamber RV apical pacing and the dual chamber pacing. And the primary endpoint was death from any cause. Sorry. यार ये क्या बकवास है, हैं? बस ठीक. So the primary endpoint was death from any cause or non-fatal stroke. Secondary was the composite of death, stroke, heart failure, hospitalization for heart failure, atrial fibrillation, and pacemaker syndrome, and quality of life. So there was no statistical difference when comparing single chamber with a dual chamber, and there was a significant reduction in incidence of atrial fibrillation with patient with a dual chamber pacemaker. So high incidence of pacemaker syndrome in atrial fibrillation was seen single chamber. And this was, you can see that there was a significant difference in the incidence of atrial fibrillation on the end with the dual chamber pacemaker. Then the David trial, in which they put dual chamber ICDs in all patients, and then they randomized them to backup VVI pacing of 40, and the patients were like New York Heart Association class 1 to 4 sinus rhythm, and the primary endpoint was hospitalization or death. They were basically patients, the primary endpoint was death from any cause, heart failure, hospitalization, but they were going to the clinics just for the heart failure treatment. But you know, it proved that those patients who had dual chamber pacing, they did bad at the end of the study. Because the patients who have backup pacing of the 40, they did not use their RV apical pacing most of the time, but the patient who had dual chamber pacing, they used all the time. So the RV apical pacing was bad in those patients. So each 10% increase in RV apical pacing increases the risk of death of heart failure events by 16% in that study, David trial. And then Canadian trial of physiological pacing showed that incidence of stroke and cardiovascular death was similar in single chamber RV apical and physiological DDD pacing at the end of 3 years. Incidence of atrial fibrillation was significantly less with physiological pacemaker, which was dual chamber pacemaker. And this is the cumulative risk of cardiovascular death and stroke in the first slide, and the second was that the significant difference between incidence of atrial fibrillation in single chamber pacemaker as compared to dual chamber pacemaker. But at that time, this was supposed to be physiological pacing. What are the adverse effects of RV apical patients in normal patients with normal baseline ejection fraction? There is a change in functional class, worsening of walk talk, and then increased BNP level, left ventricular dysfunction, heart failure, AF, and death. And especially in patients with LV ejection fraction with history of MI and worse New York Heart Association class, they do very bad with the RV apical pacing. Despite all these provocative observations, indicates that the majority of the pacemaker with RV apical pacing do well. In most trials, they did about 10% of the patients had RV apical induced cardiomyopathy. This is the definition of pacing induced cardiomyopathy. The incidence is about 10 to 20% at 3 to 4 years. What is the definition? Either patient has drop in LVF to less than 50%, drop in LVF from baseline but still more than 50%. You do their echo, serial echoes, and if the patient is dropping, his EF is going into pacing-induced cardiomyopathy. Worsening of pre-existing cardiomyopathy, heart failure symptoms, heart failure hospitalization, atrial fibrillation, abnormal myocardial function without symptoms or drop in LVF, increased natriuretic peptide. And this is the slide about the dyssynchrony-induced cardiomyopathies. These are majority of these patients like this. These are pacing-induced cardiomyopathies, left bundle branch block cardiomyopathies, and PVCs-induced cardiomyopathy. These are the three conditions which cause dyssynchrony of the ventricles, inter and intraventricular dyssynchrony. So the markers of dyssynchrony are in pacing-induced cardiomyopathy. So the dual chamber pacemaker in different randomized controlled trial failed to show its superiority over the single chamber RV apical pacing in terms of death and progression of heart failure. So as a consequence, investigators search for alternative site with a more physiological activation pattern and better hemodynamics, especially in heart failure patients. So what is the definition of physiological pacing? This is an approach to treat patients with Brady or without Brady that minimizes pacing-induced cardiomyopathy and heart failure. This is an alternative site pacing with a more physiological activation pattern and better hemodynamics. Direct His bundle branch pacing, parahesian pacing, left bundle branch pacing, and endocardial LV pacing are the most physiological ventricular sites. Flock heart failure study was published in 2013 in New England Journal of Medicine. They took about class 1 to class 3 people, and those patients were having ejection fraction either 50% or less. And they put all the patients either CRTP or CRTD, and then randomized them to either RV apical pacing or CRT pacing, triple chamber or dual chamber pacing. And you can say that the patients who have like biventricular pacing, they did well in terms of right ventricular pacing. So biventricular pacing was superior to conventional right ventricular pacing in patients with AV block and left ventricular systolic dysfunction with NYHA class 1, 2, or 3 heart failure. So this was the first study in which they put, before that, those patients who had complete heart block, they were not included in any trial of the CRTP. But this was the first study in which they picked up only those patients who have complete heart block and they need pacing. And they are having heart failure, like less than 50% ejection fraction. And this study showed that they did well with the biventricular pacing. So what is the history of His bundle pacing? So Sherlock et al. In 1957 first time recorded the His bundle pacing potential in dogs, and later he recorded this His bundle potential in humans. Narula in 1970 demonstrated that His bundle pacing impulse to ventricular activation time is equal to HV. So he proved that. And then in 1976, William et al. Defined non-selective His bundle pacing versus selective His bundle pacing. In 2000, Deshmukh et al. Demonstrated that in those patients who have persistent atrial fibrillation and cardiomyopathy, they have developed cardiomyopathy due to atrial fibrillation, they can have good results after they can be eligible for the His bundle pacing. Not only they did the normal pacing, they proved to be having the normal pacing, but they did very well in improving their cardiac parameters and hemodynamics. So this is the slide of the anatomy of His bundle. It's a cord-like structure about 20 millimeter length and 4 millimeter depth, arises from anterosuperior extension from the AV node, penetrates in the fibrous body of the septum, and then at the crest of muscular septum, His bundle continues at a right bundle branch block, right bundle. You can see. The left bundle fans out and left posterior fibers branch out first, followed by left interior fibers. Right bundle is direct continuation of His bundle. Fibers of the left and right bundle are predestined. Basically, they come from the beginning as a separate bundles. So they are separate fibers. So direct His bundle pacing utilizes the native His Purkinje conduction system and is supposed to be the most physiological ventricular pacing site for patients with AV nodal or intrahisian block. And these are 2018 ACC/AHA guidelines on the evaluation and management of patients with bradycardia and cardiac conduction system. So all patients with atrioventricular block who have an indication for permanent pacing with an LVEF between 36 to 50% and are expected to require ventricular pacing more than 40% of the time, they can choose the pacing method that maintain the physiological activation, either cardiac resynchronizer therapy or the his bundle therapy. And those patients who use the less than 40% of the pacing and EF is 36 to 50%, they can also choose the right ventricular pacing as a mode, as a CRT or his bundle pacing. In normal patients who need who are having complete heart block and need pacemaker, and they have normal ejection fraction, they can be benefited with the CRT or with the his bundle pacing, and this is the class 2B recommendation. And these are the tools of his bundle pacing. The his bundle, there is a 4.1 French lead, which facilitate multiple lead implant in the various system and minimize the risk of subclavian crush. Then there is the sheath, then there is the lumenless design lead, and then these are the full paraphernalia of the his bundle pacing. And during the his bundle pacing, we put the lead, first we put the sheath and then we put the lead, and then we look for the his bundle far field his bundle potential. And when we find this potential, on the bottom line you can see that there is his potential, then you can screw the lead in that area. And this is the full-fledged implanted CS his bundle lead, and you can see the difference. And then there is the pacing, and also on the right side that the pacing, CS pacing. This is an example of this is a 57-year-old woman presented with months of fatigue and shortness of breath, and you can see that there is a second degree AV block, 2 to 1 AV block with the narrow complex. She was implanted with a dual chamber pacemaker. It's a pace rhythm. Then 3 years later, she came with the shortness of breath, and you can see the dilated left ventricle. Then she was offered his bundle pacing, and you can see the result, narrow complexes. But this is not the true selective his bundle pacing. This is non-selective his bundle pacing, because there is a delta and everything you can see. And after 45 days, EF went up to 60%. And these are the echo results. But there is a problem with the his bundle pacing lead. There is a lead instability. There is a higher his bundle pacing capture threshold. There is a potential darker for lead placement in his bundle is smaller than RV pacing, resulting in a prolongation of the procedural and fluoroscopic time. The development of low infrahisian block. Sometimes people have proximal block, and then it can develop downside, and then they will not be benefited from them. Then you have to put another D. So development, and there is a procedural and fluoroscopic delay as compared to the RV apical pacing. In conclusion, permanent his bundle pacing is a physiological alternative to RV pacing with the potential to alleviate the unfavorable outcome of chronic RV pacing. It promotes an AV intraventricular and interventricular synchrony, resulting not only in improvement in LVF but also NYHA class, quality of life, and exercise capacity. It's a safe, effectuous, feasible, and has shown promising result in published data to make it to 2018 AHACCH guideline even without randomized controlled trial. There are no randomized control trials on this, but this efficacy is so good that it makes its place in 2018 guidelines. So it represents an attractive physiological pacing option for patients who are conventional candidates for RV apical pacing as well as bi-V pacing. Provides a more definite electrical desynchronization and can be considered in heart failure patients with wide QRS who are non-responder to bi-V pacing. However, randomized controlled clinical trials are necessary to firmly establish the role of physiological pacing in these unusual and unique situations. And now there is a slide, future of CRT. And this is going on. There are a lot of studies going on, like heart CRT, his-sync CRT, and they are not leaving any person with a broad complex tachycardia, I tell you. Either he has right bundle, he has IVCD, he has left bundle. So if you have right bundle branch block, they do his bundle pacing, and if there is no or partial correction, they do his bundle pacing plus RV pacing. And then left bundle branch pacing, branch block, you do his bundle pacing, if partial correction, do left bundle pacing plus LV pacing. And if the his bundle threshold is 1.5 or more, left bundle branch pacing, and then be happy. And in IVCD, his bundle pacing or left bundle pacing plus LV pacing, and be happy. Thank you very much.
Thank you, Dr. Dar. Our next talk is on AFib ablation in heart failure, who will benefit. And for that, I would like to request Dr. Talha bin Nazir to come on stage. He's the General Secretary of Pakistan Heart Rhythm Society and a consultant electrophysiologist at Rawalpindi Institute of Cardiology.
Yeah, sure, not an issue. Okay, I think it's fine. Assalamu alaikum. It's great to see an excellent audience over here and a fantastic talk by Professor Dar. Okay, thank you. So atrial fibrillation ablation in heart failure, who will benefit? It's quite a difficult question because the problem is there are two elephants or two pandemics we are actually dealing with in cardiology. One, atrial fibrillation as its own self, and the other one is heart failure. And interestingly, the thing is this, with atrial fibrillation ablation, already I would say that is something which is relatively new in terms of catheter ablation, although it's been there for decades now, but still it's considered new. We are also starting to think now, how about we start ablating in heart failure patients? So just a very quick few notes on the natural history of atrial fibrillation. So as we know that atrial fibrillation, it's like a chronic progressive condition. It starts with maybe some ectopics, then it spreads and it turns into non-sustained runs, atrial tachyarrhythmias, atrial flutters and atrial fibrillations. Could be paroxysms, could be then progressing over time to persistent, which is lasting for weeks and months, and then perhaps even chronic, long persistent, and to a time where the physician and the patient make a mutual decision to say, well, look, let's not revert it back into normal rhythm. Now, the problem with all of this occurs that, one, as we can see with a lot of data that has gone around, this is back in 2003 and 4, that with paroxysmal, the life expectancy was shown to be actually reasonably better as compared to the one where we said that it's permanent. So maybe we can consider that when things are burning out from a myocardial or from an electrical point of view, does this atrial fibrillation become more persistent? Moreover, we know that with the presence of atrial fibrillation, we're putting oil on the fire because in heart failure we are dealing with remodeling, and with atrial fibrillation we are dealing with remodeling in its own sense as well. So there are data to suggest which sites with atrial fibrillation may well become fibrosed earlier. However, obviously more work needs to be done in order to put that. The whole point over here is just to put in your mind, it's not a standstill kind of a condition, it's a chronic progressive situation. Prevalence, as we know, atrial fibrillation, it's a global, it's the commonest arrhythmia worldwide. In addition, we know that heart failure and atrial fibrillation, they often coexist and they make each other worse, actually. Just from the Framingham Heart Study, we can see that almost about 1,800 new individuals who had atrial fibrillation, 37% of these actually were patients of heart failure, whilst almost about 1,100 odd patients of new heart failure were actually patients who were suffering from atrial fibrillation. Now, these could be reduced ejection fraction or preserved ejection fraction patients. The presence of both atrial fibrillation and heart failure, they concur predicted mortality, which is a bit more as compared to a condition on its own. For example, AF with heart failure will have a mortality which is more than heart failure alone, and also as compared to atrial fibrillation alone. So it's important to actually address this as well now that we consider that we can provide some sort of intervention for a true atrial fibrillation. Just another depiction from the ESC guidelines. As we can see, Pakistan, although we have limited data from here, and there is another thing as well which I'll come to in the presentation, but it is somewhere around 600 to 699 over about 1 lakh patients. They would be suffering from atrial fibrillation. I do believe this is an underestimate, obviously, because we have extremely little data and in all aspects of medicine at present. One thing we must understand, that whenever it comes to atrial fibrillation, even in heart failure, it cannot be just we rely on a single thing. It has to be a holistic approach towards a patient. It's a patient. We need to address risk factors, some of which are on this slide, commonly hypertension, hyperglycemia, physical inactivity. I think this is turning into a national character. We're very lazy people, I think, when it comes to taking care of our own selves. Obesity, overweight, jab tak parathe nahi khayenge, us waqt tak aaram nahi aayega hame. And these are things which we need to look into. Obstructive sleep apnea is a very underdiagnosed condition in our setups, and I think this is something we often miss. Even in the cardiology clinics, we have patients coming with arrhythmias, uncontrolled hypertensions. We are overseeing these things. Smoking is another global problem, dyslipidemias, and obviously with the society norms changing as well. So in essence, when we talk about atrial fibrillation in heart failure, we would always talk about, treating the patient in the ABC format, as it is done overall, as with all atrial fibrillation ablation patients. We would consider anticoagulation. We would consider better symptom control. We would use, obviously, tools to identify how we're going to assess these controls. And we would consider either rhythm or rate control strategies after a mutual consensus with the patients. Not to forget the comorbidities which need to be taken care of. Only then, when these three things are taken into account, in addition to the heart failure, we can actually provide benefit. And then benefit has many meanings. Does it really mean only symptom control, hospitalizations, mortality benefit? I'm just going to come to this right now. So it's just another way to say the integrated approach. At the center of the whole image is a patient. Just remember, it's always a team effort. I cannot sit down and I can say I can manage atrial fibrillation alone myself. I have to have a team. We need to remember this. This would include all people from cardiology, all the paramedical staff, including specialist nurses. So we need to remember these little things in order to give the best to our patients, and then, only then we can give the true benefits to our patient. So where do the guidelines stand at present? So the ESC guidelines of 2020, these are for the atrial fibrillation, and because we're precisely talking about heart failure, I'll just take your attention towards the left side. So whether it's paroxysmal or persistent atrial fibrillation, in a patient of heart failure with reduced ejection fraction, the patient has to be symptomatic. Now, one might ask, how on earth are you going to delineate who is symptomatic and who's not? Because the symptoms of atrial fibrillation are often overlapping with heart failure, and vice versa. So obviously there are mechanisms to do that. One can consider DC cardioversions, a trial of antiarrhythmic therapy, and then ask the patient, well, when you were in atrial fibrillation, how do you feel? And after that, how do you feel? So these are ways to unmask the adapted symptoms in a patient. Obviously, we would have a discussion with the patient. After discussing with the patient, we can consider a trial of catheter ablation. This is primarily reserved as a Class 1A indication for patients of heart failure who have atrial fibrillation, and the atrial fibrillation is actually responsible for the systolic heart failure. So in that, obviously, if you treat the arrhythmia, which is the etiology, then obviously that will be the most beneficial for the patient. On the other hand, if there are other choices, then obviously we can consider antiarrhythmic drugs, Class 1, Class 3, and Class 3 amiodarone is one of them. Then obviously we understand the toxicities that come with it, but giving it wisely we can consider. If that the anti-arrhythmic drug therapy fails, we can obviously consider patients to be either destined to be undergoing catheter ablation, which is a Class 2A indication at present based on the data, or we can try a trial of combination of antiarrhythmics or change the antiarrhythmic at all. So just on the other side, the heart failure guidelines from the ESC, from the European Society, they also reiterate one thing, that they say, look, go for mortality benefit, which is established mortality benefit with all the medications first. Control studies were done, and they've showed that, well, look, there's no real benefit or inferiority in terms of controlling rhythm or rate amongst with medicines. Whereas when we came into the era where there was catheter ablation, then catheter ablation, the guidelines have been basing their the guidelines have been based on these data from these trials, namely the CASTLE-AF trial, which stirred up a lot of discussion back in a few years back. Then it was followed closely by the Cabana heart failure trial, and then there was a subgroup analysis in the heart failure patients. So long story short, what this was doing was all these trials were mixing and matching patients of atrial fibrillation. Okay, so the PABA-CHF trial took, what if we take patients, we go for the AV node ablation plus CRT implantation and compare these two catheter ablations. They found that, well, the PVI, or in other words, the catheter ablation was marginally superior. However, because of the trial limitations, we cannot make absolute conclusions from all of these. Then there were other trials such as the camera MRI, which actually looked at medical rate control with the catheter ablation and saw what effect it had on left ventricular ejection fraction. Another thing that particular trial took into account was late gadolinium enhancement, which is a surrogate for myocardial fibrosis. So they saw that patients with myocardial fibrosis did poorly, and their ejection fraction did not improve after atrial fibrillation ablation as compared to patients who did not have any myocardial fibrosis. So with these trials, there was a lot of mix and match. Just one trial that I would like to put forward to you is just because it's discussed the most and it set the basis of this mortality benefit of atrial fibrillation was the CASTLE-AF trial. Essentially, this was the strongest evidence supporting the use of catheter ablation. Prior to this, safety of catheter ablation was established by the ATTACK trial, which I'll just give you a glimpse of. But in this trial, they were randomized patients who were heart failure patients, quite sick, with an ejection fraction of less than 35. They were either, having this will for going for catheter ablation, or were not willing for antiarrhythmics. They had the ICD implanted as well. The primary endpoint was a composite. There was a combination of death from any cause or hospitalization for worsening of heart failure. And there were fewer patients who had this composite endpoint in the catheter ablation group. Also, fewer patients died from any cause. Also, that was clinically, statistically significant. The time, the AF burden, the amount of time one patient was spending in atrial fibrillation, that was also lesser in the catheter ablation group. Just a glimpse, it was a fairly equally divided population in the medical therapy versus the ablation. It's just another way of depicting the endpoints. I'm not going to bore you with all of this data, but I think it's just important to glance at it. The graphs, as you can see in the ablation group, so essentially we've got the probability of survival. So this was about survival. They extrapolated and they saw, well, the ablation group did better, whereas the medical therapy group, which was resorted to medical therapy, did not have much of a survival as compared to that. But death from any cause initially, in the initial months, which was around about 2 to 3 years, it was pretty much similar, but later on the trial actually showed that, well, ablation patient group actually survived more. Worsening heart failure hospitalizations, they were lesser in the ablation group as compared to the medical treatment group. The forest plot, essentially what I just need to bring your attention to is ejection fraction less than 25. If the patient had that and they were resorted to ablation, they didn't do so well. Actually, the group that was resorted to the medical therapy did better as compared to the ablation group. So maybe who would benefit? We would probably say that, well, look, heart failure patients, but those with an ejection fraction of maybe more than 25%. But anyway, these are speculations because we don't have any concrete answers as we say so right now. ATTACK trial, that compared the amiodarone to the catheter ablation essentially, and essentially what that saw was patients, they were having more free periods from atrial fibrillation in the catheter ablation group and that from the amiodarone group. The Cabana trial, the heart failure subgroup analysis, essentially because they also saw and they tried to address the situation, what about patients with preserved ejection fractions? How do they perform? And they thought, well, they are doing pretty fairly well, but because of the design problems and the anomalies and obviously the way it was designed, they could not extrapolate all, or they cannot validate everything from the CASTLE-AF trial or the AMICA or the ATTACK trial. What they ended up saying was, they said, well, look, one thing is for sure, or at least not sure, but suggestively that patients with catheter ablation should be considered sooner than later. These patients would be having more advantage in terms of symptom control and reduced hospitalizations and maybe not, but mortality, but we can't comment on all of that. Although again there was a bias with that. The EAST-AF-NET trial, which was led by one of my senior colleagues, Paulus Kirchhoff, that also went for something which what they tried to do was, rather than keep the patient on medical therapy, they tried to go for the catheter ablations much earlier on, because they thought, well, if you leave earlier on, so essentially they made two groups, those with the usual care and those with the early rhythm control. So in the early rhythm control group, they found, well, the incidence of atrial fibrillation was well, not far, but it was less as compared to that with the usual care. So this set out, obviously, and with this there were other meta-analysis of trials as well. However, the impact they had was essentially what we saw in the guidelines. Class 1 for tachycardia-induced heart failure, or 2A for the failed antiarrhythmic drug. Then there is a plethora of trials that came after the publishing of the guidelines. These were the cryo first, stop AF first, and the early AF. All three said, okay, what if we go for catheter ablation early on, that with the cryoballoon technology, and we take the other group and we just give it antiarrhythmic drug therapy and we delay their ablations. They found doing catheter ablation earlier saw more favorable results. Now, that was primarily driven from the incidence of atrial arrhythmias. However, how these will affect guidelines is still yet to be decided, because when the new guidelines come out, then hopefully we can see the impact of all of these guidelines. One thing is for sure with these guidelines, the burden on the healthcare services in developed countries has reduced. So it's reduced hospitalization, it's reduced healthcare utilizations, the adverse events, the quality of life of a patient is improved. Having said this, one has to be very careful with whom to select and whom not to select. And I'm just going to skip this part, because which patients could we consider, based on all of this data, to be better candidates who would have better, more benefit from catheter ablation as compared to patients who may not. So younger patients, so in a nutshell, if I can put it, ideally speaking, a structurally normal heart undergoing catheter ablation for atrial fibrillation who is highly symptomatic or symptomatic and very early on in the disease situation will probably derive most benefit. But now in heart failure patients, how do we do that? Because heart failure things have progressed a bit further. But maybe rather than delaying catheter ablation until the patient is more sick, we can perhaps consider earlier catheter ablation. However, because there are so many factors which are playing, and these are both very complex neurohumoral syndromes or chronic progressive disorders, one has to be very careful. So as the guidelines say, right now we control them on medical therapy, but if we were to select, I would probably want to go for a younger patient who is definitely highly symptomatic. He has had the try of proper antiarrhythmic drugs, and I failed with him. His LA remodeling has not gone beyond 45, so this is a value that we had to say. It could be, in some patients, 44, 46. So, no other arrhythmia. You know, if I end up doing an atrial fibrillation ablation, then there's about 3 or 4 other arrhythmias coming with it. How many arrhythmias am I going to ablate? So maybe some antiarrhythmic drug might cover all of those arrhythmias. So low on AF. However, this is a bit of a debate because by the paper I've taken this from is from 2017. After 2017, there has been a couple of things. Well, look, low on AF, really? But in a way, if we can just consider it AF with a structurally normal heart. Obviously, then the other factors, if they are under control, for example, the patient is willing to take up, look, I'm going to doctor, take care of my blood pressure, I'm going to take care of my obesity, I'm going to be taking care of my thyroids and each and everything. And I mean, what would be the thing if we were to ablate and the underlying problem which actually perpetuated the atrial fibrillation or triggered the atrial fibrillation further was to remain there. So these patients would do better as compared to otherwise. It's been seen with a couple of trials that in patients who have had amiodarone, they didn't fare with catheter ablation. Now, what's the reason? Maybe more sicker myocardiums, more atrial cardiomyopathy. It's a bit difficult to ascertain. So patients who have not been tried on amiodarone, and or at least heavy doses of amiodarone, they may well actually respond better to atrial fibrillation ablation. Other factors from the trials that came along were the camera MRI trial showed that patients with late gadolinium enhancement in the ventricle, not the atrium over here, in the ventricle, actually didn't do well as compared to patients who had no gadolinium enhancement. Advanced heart failure patients who are sicker, NYHA 3, 4 first, it's very difficult to actually perform their procedures as well because they're having a difficulty in lying down, and secondly, maybe we're just a bit more hesitant in proceeding, and they've got a more sicker heart which is going on down the way, and they've got more factors which are playing on the heart. LVEF 25, pulmonary hypertension, because that is a surrogate for advanced heart failure. Inotrope dependence or LVAD destination therapy. More comorbidities, as I've already said, that are addressed in these patients, we can have worse outcomes. The biggest question I actually, and I think my teacher, Jan Imran Majid, I think we always used to talk about is, well, in Pakistan, are all atrial fibrillations really true atrial fibrillations? Because this is a question that I'm still finding words for. I really don't know, because we have an immense burden of rheumatic heart disease, and that begins, remember, it's a pancarditis. It affects the pericardium, myocardium, endocardium. The mitral stenosis, which we see it, is one aspect of it. So really, are we talking about mini circuits, or are we talking about true atrial fibrillation? So really, there's no data to support that, no significant data where I could actually say. So we've got to be very careful with what we do and what we select over here. I think I've run out of time, and I'll just conclude 5 minutes before I've totally ran out of time. I just want to summarize this. Sorry. They're going to eat me. Right. So in summary, all I just want to say is, look, things are in their elementary times. Who will benefit, who will not benefit, it's very difficult to say. But yes, what we're seeing is catheter ablation in the state set, which I've mentioned, addressing it in the ABC manner, according to the guidelines, we can get most benefit out. But remember that one has to be very careful in patient selection. One has to optimize heart failure therapy first. It's not जाके जल्दी से catheter ablation कर दो और heart failure गई side पे. No, you have to address the underlying problem first. Bit by bit, you may need to consider cardioversions in these patients to see really are they symptomatic because of AF or is it because of the heart failure. So what I will recommend is we should keep our minds open. We should keep our eyes open and we should be looking for or making efforts to identify these patients early on by the appropriate multidisciplinary approach. And then we can address more aggressively their treatments. Not all patients, remember, will benefit from atrial fibrillation ablation. Usually what happens even right now is that if I get 10 referrals, I would only ablate one of them maybe, or two of them. So it's that. But it is, because it's very complex, I have to take every thread away step by step. Careful selection, which I've just gone through, is something, but one thing is this, that it has to be a mutual decision. Discuss with your patient, please. This counseling aspect is actually very important to set the real targets and expectations with your patients. There is nothing right or wrong. It's a mutual decision. It's relative. Lastly, as things stand, look, at present the catheter ablation aims to definitely provide symptomatic relief. This is something that we can say. It improves the quality of life as seen by these studies. It does reduce the AF burden really, but how does that translate is still in the air. And then it does reduce recurrent hospitalization. Mortality, well, we've got bits and bobs coming out, but really these need to be validated. There's really nothing concrete at present. One trial says, yes, mortality benefit. The next says, well, we're not sure. So really, I think data has to come out. With this, I conclude. Thank you very much for your patience.
We have 5 minutes for panel discussion.
I have just one question, because the features Dr. Talha showed for a worse outcome, most of the time heart failure in AF patient we see at least 70–80% of the features of worst outcome. So what's the local experience of recurrence? First, I need to know what's the local experience of catheter ablations, how frequent we are doing locally, and what's the outcome in terms of recurrence of local experience?
Sorry, do I have this mic? Hello? Yeah. So locally, there are centers that are doing it. One, we are doing it in Dalpini Institute of Cardiology. Peshawar is doing it. AFIC is doing it. NICVD, Dr. Ghazala is doing it. We are doing atrial fibrillation. Now, the main means that we are using is the cryotechnology. And the main cohort of patients that I'm dealing with are actually very early on in their stages of atrial fibrillation ablation with structurally normal hearts. So we started off, the first time we did is in October 2020. So it's been almost about 2.5 years. We've done almost about 42 ablations. We have one recurrence. We had one patient who developed atrial fibrillation in the blanking period. So I presume, based on data, they will be having a recurrence within the next maybe year or so. One patient we couldn't actually complete our procedure of because of a phrenic nerve palsy. So 3 to 4 patients we could not. Recurrence-wise, we've had one definite. Now, the problem we're having in detecting recurrence, not all atrial fibrillation recurrences are clinically evident. We could be having some subclinical runs of AF as well. But if we were to answer this in this way, the primary reason I did atrial fibrillation ablation was to get rid of symptoms. So in terms of that, how many patients have returned to us claiming they are having symptoms and those symptoms have coincided with atrial fibrillation? We've not seen much, but since it's been only 2 years, we could be having definitely recurrences down the line as well. And I'm sure the other institutions would be able to answer themselves as well.
Assalamu alaikum. with your permission. I'm Dr. Faisal Ahmed. I'm professor of cardiology at Liaquat National. We interventional cardiologists, आम इस्तिलाह में हमें बलून वाला कहते हैं, तो आप लोगों को करंट वाला कहेंगे या शॉक वाला. There's this one point, as far as my understanding is, the atrial kick contributes to 25% of the cardiac output. So whenever someone goes into atrial fibrillation, you lose 25% of the output, and someone has an ejection fraction of 50%, so it gets reduced to 37.5%. So would it be appropriate to consider all people with atrial fibrillation, not all, but most of them, as if they have systolic dysfunction, not systolic dysfunction, but heart failure, one. If you keep this as ground zero, then perhaps atrial fibrillation ablation in most of the patients would be a big indication, don't you think? And the other thing is, what percentage of people with atrial fibrillation stay in sinus rhythm after successful ablation? And what percentage of these patients are successfully ablated? If you have 100 patients with atrial fibrillation and you ablate them, how many are done successfully and how many persist in sinus rhythm? And one more thing, it's a little digression from our subject right now, but there was a lot of hoopla about leadless pacemakers a few years ago. So I haven't seen any leadless pacemakers in Pakistan. And if there's still a thing, then I don't think you can do physiological pacing with leadless pacemakers, or am I wrong in saying that? Thank you.
They are too expensive. Pakistani population will come like maybe next year.
I don't think you can.
Those pacemakers are they are like they have a delivery system and that is implanted in RV apex. So the same thing as before the
Pacing kind of.
They are pacing basically.
There's just one question in relation to His bundle pacing. So how frequent is it to you start having a His bundle pacing and then subsequently, without any prior evidence, your patient develop infrahisian blocks in bundles? So what's the frequency of that? Because that's the reason we don't use to put atrial pacemakers, because this patient may come across AV blocks in future. So same applies to when you're putting a His pacing. He may develop infrahisian or even left bundle block in future. So what's the frequency?
That mostly depends upon the age of the patient and also the ischemic status of the patient. If the patient is having ischemic heart disease, he has infra block, and it may progress to. These patients have severe His-Purkinje system disease. And in the initial stages, they don't have any infrahisian block, but they have infranodal or intrahisian block, and it may progress downward, and patient can have.
So would you prefer then or directly put in a CRT rather than?
Yeah, yes, because putting in His bundle pacing is not like comparable to the CRT pacing. If you have failed CRT, then you can try His bundle pacing, and they have shown good results.
I can. Oh, sorry.
Professor Nadeem Rizvi and Suhail Abrar, if you have some comments, then we can close the session and go for the lunch.
Yeah, I just want to have a general comment. I think with all these devices and everything, my only comment would be that general electrophysiologists have seemed to be working in silos. And they now, for an interventionalist, they've become like a cardiac surgeon. And we see patients, we hardly refer anyone for it. I think एक चीज़ ये ज़रूरी है कि आप लोग वापस कोशिश करें कि जनरल कार्डियोलॉजी की कॉल में आ जाएं. आखिर जैसे स्ट्रक्चरल होता है और पेरिफेरल होता है, वो पार्ट ऑफ इंटरनेशनल सोसाइटी. अगर आप जनरल कॉल नहीं लेंगे तो फिर आपको सिर्फ वही रेफ़र होगा जो हम चाहेंगे कि अच्छा अब यार ये बहुत ज़्यादा सिम्टोमेटिक या ट्रीटमेंट नहीं हो रहा है. आई थिंक दिस इज़ a problem. I've been in NICVD for 30 years, 25 years, and I've seen people evolve. I think ये बड़ा important है कि आपके जो leaders हैं वो ये अब इसमें आए, because इतने अगर benefit हो रहा है जो आप trials बता रही हैं तो devices prices तो कम हो जाएंगी volumes जब बढ़ेंगे, और volume उसी वक्त बढ़ेंगे जब आप लोग mainstream में calls पे आएँ. तो I think this is something that you need to think about, that सारे tertiary hospitals में जनरल कार्डियोलॉजी की कॉल्स जो हैं, जिस तरह इंटरवेंशनलिस्ट लेते हैं स्ट्रक्चरल हार्ट, पेरिफेरल हार्ट, तो आप लोग जनरल कार्डियोलॉजी की कॉल्स लें.
Okay, both excellent talks, the physiological pacing and AF ablation. These are the icing on the cake, so we don't forget to bake a good cake. That's a medical treatment, and often this is not optimal guideline directed, and people jump onto the device therapy and ablation. So now we have a very good treatment, like 4 pillars in the medical treatment. One should start simultaneously according to new European guidelines at a lower doses and try to reach the guideline directed doses, and then go to this area which is icing on the cake.
Okay. Thank you so much. I would like to request Dr. Imran Majid to come on stage and distribute the shields. Our first presenter, Dr. Ashraf Dar. Please come on stage. Okay, Dr. Talha bin Nazir. Now panelist, Professor Nadeem Hassan Rizvi. Professor Faisal Ahmed. Professor Fawad Farooq. Dr. Sohail Abrar. Okay, we'll take lunch break now. It would be of 45 minutes. See you all after lunch break. Thank you.
Welcome back, everyone. Now, our next session is on atrial fibrillation. And for that, I would like to call the panelists. I would like to call retired Surgeon General Imran Majid, who is Vice Chancellor of the NUMS Cardiology. Professor Tariq Ashraf. Welcome back, everyone. So for the next session, we have atrial fibrillation. And for that, in the panelists, I would like to invite Professor Nawaz Lashari, who is head of the Department of Interventional Cardiology at Civil Hospital, Karachi, and now University of Health Sciences. Dr. Tariq Farman, who is head of Department of Cardiology at Dow University of Health Sciences, and Professor Tariq Ashraf, who is consultant cardiologist and interventional cardiologist at NICVD. And retired General Surgeon Imran Majid, who is cardiologist and electrophysiologist at AFIC and VC of NUMS Cardiology. For the talk, I would like to invite Dr. Yawar Saeed. Dr. Yawar Saeed has completed his fellowship in cardiology and clinical electrophysiology from University of Toronto, and he's assistant professor of cardiology and electrophysiology at Aga Khan University Hospital. And the talk is New Era of Atrial Fibrillation, How Should We Proceed with It?
Assalamu alaikum, everyone. So before and after lunch, it's all atrial fibrillation. So hopefully you all have a big lunch to accommodate all our talks about atrial fibrillation. So new onset atrial fibrillation, as we all know, as the name indicates, it's something that previously not known to a patient. Okay, so whenever a patient comes in and has atrial fibrillation and has not been known to have atrial fibrillation, it's been called new onset atrial fibrillation. So what we are going to talk about, we are going to talk about a little bit about the background of atrial fibrillation, why we electrophysiologists got very interested in atrial fibrillation, how to proceed when you come across this new onset atrial fibrillation, and just to stimulate ourselves, we go through case-based discussions, how to manage these patients. So, epidemiology of atrial fibrillation, as you can see, the lifetime risk of atrial fibrillation is about 1 in 3 individuals. This is from the European data. And AF prevalence increases as we grow old, much more common in patients above 65. And as we grow old, the lifetime risk of developing atrial fibrillation increases. And as you can see here, the atrial fibrillation is much more common in males as compared to females. So what is this relate to a Pakistani population? Although we don't have data, but the data is accumulating now. There is multiple studies which has been going on at the moment. Few of the studies has been published, few are in the pipeline, in which we know real true prevalence of atrial fibrillation in a Pakistani population. On average, we estimate that the population is around 600 per 100,000 prevalence, which equates to about, so Pakistani population in 2019 is around 220 million. So at one time, about 1.3, so this is a conservative estimate, about 1.3 million population of Pakistan have got atrial fibrillation, okay? And if we think that atrial fibrillation risk in somebody who is older than 65 is 4.3%, which is growing at around, almost around 1% per year, you can very well assume how many patients will have atrial fibrillation in the near future in Pakistan. So the atrial fibrillation, as Tala also indicate, is going to be a pandemic. It's already a pandemic, and atrial fibrillation and heart failure is going to affect a lot of our populations. And remember, almost 1/3 of the strokes have been attributable to atrial fibrillation. So when we talk about atrial fibrillation, we are talking about if you don't diagnose atrial fibrillation properly, don't anticoagulate them properly, almost 1/3 of them end up with a stroke. Now, so let's start with our first case, okay? So this is, as you can see, this is somebody who is 65 female and come to you in emergency room. Presented with shortness of breath, palpitations for the last 4 days, heart rate is around 160 beats per minute. She's never been admitted to the hospital, comorbidity is not known. So we go back to the ECG. What do you see? So broad complex tachycardia, irregular broad complex tachycardia, most likely atrial fibrillation, okay? So what comes to mind straight away? So yes, it is atrial fibrillation, but with the left bundle branch block, what are you thinking? So you are thinking already that this patient may have heart failure. So it's already have low ejection fraction, okay? Now, when you, and then obviously if you look at the vitals in this patient, she have got a low blood pressure, she's got a saturation of 90%, and she's tachycardic. So how would you treat this patient? Catheter ablation, no. We are not talking about catheter ablation yet. We will, but we are not talking about it yet. Yeah, that's also in the emergency room. So that brings us to how you manage a new onset atrial fibrillation in an emergency room, okay? And that's very important, that who will you admit for further treatment and who will you discharge after initial treatment, okay? So clearly, if the patient is hemodynamically unstable, have showing signs of shocks, okay, which is obviously hypertension, drowsiness, low blood pressure, you need to admit these patients and then manage them. Ischemia, any patients who come in with chest pain, and you see on the ECG that these patients have ischemic symptoms, so you need to admit these patients. Severe heart failure, orthopnea, PND. So these are the patients you cannot let them go from emergency room. We have seen this on multiple occasions. It's not just you. A lot of people have done that they see atrial fibrillation and they see those signs, but then discharge the patient after 6 hours, and the patient then end up in our clinic the next day and needs to get admitted. So you have to make sure that who to admit and who to discharge. And important thing is atrial fibrillation with pre-excitation, okay? So that's very important. If you see that there is atrial fibrillation with pre-excitation, and or you see an atrial fibrillation in somebody who come in with a syncope, then you have to admit the patient, because it could be anything. It could be post-atrial fibrillation, conversion, sinus pause. So anyone who come in with syncope, these are the signs which you should look for, not just the ECG, because you're not treating the ECG, you're treating the patient. This comes to our next discussion about urgent management of atrial fibrillation, who needs cardioversion. So all the patients that we have discussed before, especially the patient that come in to us in an emergency, yes, you need to know about the onset, when the onset is. If the patient onset is more than 48 hours, then obviously you opt for a transesophageal echo and then to go for cardioversion. Or otherwise, if the patient onset is within 48 hours, then you go for a cardioversion. So emergent DC cardioversion, hemodynamically unstable patient who have chest pains, heart failure signs, these are the patients who will need cardioversion, okay? Now, so this is an algorithm which makes you decide about how to manage these patients who come in with new onset atrial fibrillation in your emergency room. Immediately assess if the patient is stable. If the patient is stable, fine. Or if the patient is not stable, if the AF is causing hypertension, cardiac ischemia, pulmonary edema, then obviously consider electrical cardioversion, especially if the late control is not effective or your amiodarone is not working and you're giving it for a while. Antithrombotic therapy. So that is extremely important even if the patient has not had been anticoagulated before and you don't know the onset. So you need, in these patients, it definitely needs to have transesophageal echo. And then if the patient is stable, then obviously you have to assess the risk of a stroke, and then you come to this algorithm on the left side of the screen. And this is from the Canadian College of Cardiology. Now, so this is just a quick recap of emergent management of atrial fibrillation in patients who are presenting to the emergency room. It does not cover every part of it, and we'll talk about it as we go along, okay? So second case, this is a 24-year-old male who comes to you with paroxysmal episodes of palpitation over the last few years. He has vitals, the heart rate is 70 beats per minute, normal, comorbidities is not known. And he has shown you this ECG. So again, what is it? Broad complex, tachycardia, okay, and it's an irregular, but what you see is these pre-excited ECG, okay? So now this comes to the second part of our discussion. Young patients who present with atrial fibrillation, what are you guys thinking? So it's somebody who's in the 20s or 30s or 15 show atrial fibrillation. What are you thinking? Yes, very good. So you're thinking of valvular heart disease, and go one step more further. Yes, excellent. Could be a cardiomyopathy. So young patients who present with atrial fibrillation, there is almost always a cause, okay? Pre-excitation, so accessory pathways, okay? Hyperthyroidism, cardiomyopathies, okay? Congenital heart disease, not very commonly, but rarely sometimes can present with atrial fibrillation as well, okay? So again, these are, again, this is a patient who is you are seeing as an outpatient, but these are the scenarios when the patient comes to you in the clinic, a stable patient, and showing you that ECG. And are you going to admit this patient or not? Yes? No? Discharge him? Send him home? Huh? So you need to, so these are patients who are at high risk of sudden cardiac death, especially those who have got evidence of pre-excitation and atrial fibrillation. And if they are showing you and saying that they have syncope, so they are very high risk, so they should need emergent admission and then ablation. Obviously not more so in somebody who's got mitral stenosis. So always try to identify a cause in young patients, or also old patients. You do all these investigations, and also those patients who you are admitted from the emergency room, you need to do all these investigations, which include your blood test, you check their thyroid status, you exclude valvular heart disease, and assess whether they need an EP study or not. Very rarely we come across young patients with atrial fibrillation with inherited cardiac conditions. They have a mutation which actually cause atrial fibrillation. Again, rare, not commonly seen, but sometimes can be present. Okay, so this is obviously your run-of-the-mill, again, narrow complex tachycardia, irregular atrial fibrillation, which is very fast. And this patient, again, comes to you in an outpatient. He's stable. He's got a heart rate of 160. He's having paroxysmal episode of atrial fibrillation. These are the vitals. Again, you don't know the comorbidities. What you're going to do with him? Again, so the first question is he stable enough? Yes? Okay. He's having paroxysmal episodes of atrial fibrillation. Okay, so its fibrillation is coming and going. Does he need admission? Okay, again. So that's important, okay. So the first thing, atrial fibrillation, stable, unstable, how you proceed further. Okay. I always, once you see a stable patient with atrial fibrillation, these are the 4 S's that I always think that all of us should try to ascertain in a patient to assess the stroke risk. So what is the risk of a stroke in these patients with atrial fibrillation? Then what is the symptom severity? How bad is the symptoms affecting their daily routine? Okay, and then assess the severity of their AF burden, and then what is the substrate severity. Okay, so this is a good way of remembering what you have to do in the patient, a stable patient who come in with atrial fibrillation. So risk stratification of anticoagulation, we know it's a Chadds-Vasquez score, and the Chadds-Vasquez score is actually a very good way to assess or tell you what investigations you need to do. And one thing you remember, these patients, yes, new onset atrial fibrillation, you do all these investigations, and whether they've got hypertension or not, you need to look for it. They've got congestive heart failure or not. If there is any LV dysfunction, you need to order an HbA1c in this patient, see if there is any history of a stroke. A recent study, Intisar is here, he has done it, and it has shown almost 18% of the patients who are presenting in Aachen University Hospital with atrial fibrillation already had a stroke. So this is very, very dangerous. So somebody who's coming to us in a tertiary center hospital, new onset atrial fibrillation, 20%, almost 20% already had a stroke. Okay, so if this is, you can see if we have 1.3 million people with atrial fibrillation at a given time, conservative estimate, how many already had the stroke? Okay, so that's why it's important. Okay, so coming back to the Chadds-Vasquez score, make sure you do it at, it's not something which you can do once and then leave it. So let's say the patient comes to you after 1 year, you need to do the Charts-Weske score again, okay? Especially those in which the Charts-Weske score is 0 because, or 1 in females, in which you decide they don't need anticoagulation. So whenever the patient comes to you in those who are not anticoagulated, repeat this exercise of assessing, because this is the most important thing to prevent these patients from having the risk of stroke, okay? So this is HRS, APHRS guidelines, very simple, there is no confusion in it. If the Charts-Weske score is 1 in males, you would anticoagulate with NOACs. If 2 or more, you can anticoagulate with NOACs or warfarin. In females, although, the only being female should not make you anticoagulate the patient unless they have other risks as well. Okay. Now, what anticoagulation? That's again the question. So, the rheumatic heart disease patient, recent trial, Invictus, multi-center trial, Pakistani hospitals have also been included, have shown that warfarin is superior to NOACs, and all patients with rheumatic heart disease should be anticoagulated with warfarin, not with NOACs, okay? Somebody who have got renal disease, you have to think about what? So the recent trials have shown that you can use apixaban, which have got more evidence, but however, the dialysis patient, if they are on dialysis, you should use warfarin. So that's what is this license for. There is data which is gathering up in this group of population that we may be able to use NOACs, patients with severe renal disease, but their dose needs to be adjusted. Okay. Now, the choice of anticoagulants, there are multiple trials which has done comparing NOACs with warfarin, and it has shown there is a non-inferiority trials, and it has not shown that either of them. So if patients can have NOACs, those with VKA have a stable INR levels, they can continue with warfarin. Those in which you need to restart NOACs, you can restart NOACs. Definitely less bleeding with NOACs. Okay. Now, what are the risk factors for atrial fibrillation in our population? We briefly touched about it, but this is what is happening in our population. Look at this. Hypertension in Pakistan is 1 in 4 of us have hypertension. Dr. Ishaq is here, and he's telling me the other day about a study that he has done. It's almost 50% now. So the hypertension prevalence in a Pakistani population, according to WHO standard, is 50%. Type 2 diabetes mellitus, 17%. Okay? Coronary artery disease, men 6.1%, women 4%. Valvular heart disease, anywhere from 5.6 to 9.6%. These are very alarming numbers. Okay? No matter atrial fibrillation, ablation, no matter if you don't control the risk factors, we are going to head for calamity. We cannot, our healthcare resources are limited. We cannot manage that many strokes. We cannot do that, okay? We cannot manage that many patients with ischemic heart disease. We cannot manage that many patients. So these are alarming numbers, and they are 3 years old, okay? So remember, these are the risk factors for atrial fibrillation, and prevalence is going up and up and up. And now comes to the final part of our discussion, which is about rate control and rhythm control, and there are multiple questions in the previous talks that has been asked, and we'll try to answer them during this. So when we talk about rate control in a stable patient, we are looking for medications, okay, which is beta blocker. 2 minutes, okay. No, not long. I kept it small, okay. Calcium channel blockers, and then we go for, obviously, age-old digoxin, hardly used now. And then, obviously, in symptomatic patients in which you decide not to go for rhythm control, pacemaker implantation with AV node ablation can be considered. And we talk about rhythm control, these are the antiarrhythmic drugs, and then the pulmonary vein isolation. Why we are discussing all this? Okay, it started here, AFFIRM trial, 2020, New England Journal of Medicine, shown no benefit of either rate control or rhythm control. Okay, so this is where this discussion started. all of us quote this, oh, there is no benefit in rate control or rhythm control. We should choose either. However, it changes. Okay, look at this, what the medication they have used. They have used almost 62% of the patient with amiodarone, which obviously a drug which causes side effects in 1 in 4 populations, use sotalol, procainamide, quinidine, and very few patients end up with flecainide. Okay, this is the Cabana trial, recent trial. Okay, look at the mortality, strokes, MIs in patients with rhythm control versus rate control, again drugs, catheter ablation versus antiarrhythmic drug therapy, and it has shown no hard benefit, which means there is no improvement in mortality. But look at the figure on your right of the screen, which shows that catheter ablation is superior by reducing the risk of atrial fibrillation. Okay? So this is one thing which Cabana have proved, that yes, no mortality benefit, no strokes benefit, no MI benefit, but definitely reduction in recurrent risk of atrial fibrillation. So then obviously the question starts again, oh, rate control or rhythm control. This is CASTLE-AF trial, which Talha has presented. Okay, I have clearly shown the ablation is superior. We don't question it anymore. But now the recent data is emerging about early rhythm control in patients with atrial fibrillation. So let's say an example of supraventricular tachycardia. We don't wait. If somebody has SVT not being managed with medication, we offer ablation, and then there is a lot of acceptance to it, okay? Because we are so successful in ablating AVNRTs and AVRTs. AVRTs have got some mortality benefit as well. So early rhythm control is getting more and more. This is again a data looking at rate control, rhythm control in patient with AF and atrial fibrillation with preserved ejection fraction showing benefit. One more. So this is the way we do atrial fibrillation ablation, which is pulmonary vein isolation, and then this is the way. This is obviously a voltage map of ablation, and this is the cryoballoon ablation for atrial fibrillation, in which you see a balloon in which we occlude the vein and then freeze around it. One is a burning, one is freezing. So what you guys have to remember in rate control, what is the rhythm control, is that there is definite symptomatic benefit in rhythm control with catheter ablation, and that's, you have to offer this to the patient. And there will be data coming that early rhythm control have improving hard endpoints. So when you see atrial fibrillation, you go for rhythm control, you're likely to have long-term benefit in hard endpoints, which is mortality, stroke, or MIs. But remember this, just last minute, okay? But remember, this is the last slide, and then we call it a day. Remember, this patient's atrial fibrillation is not just here, okay? Atrial fibrillation, when the patient comes to you, is new onset atrial fibrillation, is when the symptomatic AF is started. But actually, atrial fibrillation has caused a lot more damage already, especially in our population in which the patients downplay their symptoms, okay? So what I always advise is, these are the screening tools that you have. The most important one is doing a pulse check. So whenever the patient comes to you, no matter where you are, if you put your hand on the patient, okay, you are a tool yourself to diagnose atrial fibrillation, okay? So simple things will make a lot of difference in preventing this patient from having the strokes. Okay, thank you.
Thank you, sir. I would like to invite Dr. Ahmed Noor, who is a consultant cardiologist at Inter Hospital, as a panelist to the stage. He's here. And for the next session, we will have it on Zoom. For that, I would like to invite Dr. Mohsen.
So for next session, which is on Zoom, and Dr. Divyani Chaudhary from Philadelphia, US, is going to talk about risk stratification of sudden cardiac death and family screening in most common inherited cardiomyopathy, that is hypertrophic cardiomyopathy. So Divyani Chaudhary is the medical director of adult congenital heart disease and also the director of inherited arrhythmia program in Philadelphia. With her, we also have Georgia Sukulia-Brugada. She is the pediatric electrophysiologist and inherited arrhythmia specialist in Barcelona, Spain. So she will also be online. We welcome both of you. And over to you, Divyani.
Thank you, Hussein. I'm going to. Can you guys hear me? I'm going to. There's a lot of echo, right? Can you see my screen? Yes. Okay. So, thank you everybody. Thank you for Riyadh and Hossein for inviting me to be a part of this Khiepsummit in Pakistan.
Sorry, Divyani, for interruption. If you can, if it's appropriate, you can turn on your camera so people can see you as well.
Thank you for having me take part in this session today. And I'm very excited to be part of this meeting. And we've recently seen Pakistan a lot in the news. I hope things are going well and you guys are doing your crisis, you know. So my topic today is risk stratification for sudden cardiac death and family screening in hypertrophic cardiomyopathy. So I want to illustrate this with a case. So I'm a cardiologist in Pennsylvania, but I do take care of the Amish community, which resembles a lot the community that we have in our lower middle income countries, patients who are not insured and they have to pay for their care. So this is a 50-year-old Amish woman who presented with a heart murmur. She was in addition also feeling very fatigued and tired and lightheaded, had some loss of consciousness. She believes that her mother may have had a cardiomyopathy, died in her 70s. Her father is still alive. She has 8 siblings, and the patient has 7 children. So she's gone through 7 pregnancies, but all her pregnancies have been premature. And one child is born with some major disability, but every child was premature. So this is her echocardiogram. And as you can see, there is concentric left ventricular hypertrophy. And as you look at her in the outer tract, there is a basal circular hypertrophy with obstruction. And there is dynamic obstruction with Valsapa and even without. And the rated low SI is 230 millimeters of mercury. And this is a resting gradient of about 128 to 130 millimeters of mercury. Her left atrium is dilated, and her strain pattern is very abnormal. So when we look at a patient like this, they have isolated progressive myocardial hypertrophy, and hypertrophic cardiomyopathy has is an age-dependent disease onset, and disease cannot be excluded until later in life. There is a risk of sudden death, which is about 22%. There are systolic and diastolic changes, and it's caused by mutations in contractile proteins of the cardiac myocyte, the beta-myosin heavy chain, and the myosin binding protein C. So, unexplained wall thickening in hypertrophic cardiomyopathy greater than 15 millimeters, so Z-score of 2.5 or more, greater than 13 millimeters with a family history or a positive genetic mutation. There are several genes that cause hypertrophic cardiomyopathy. There is also gene-negative hypertrophic cardiomyopathy, which most likely has polygenic inheritance and contribution of comorbidities like hypertension and clinical screening of family members, and we'll talk about that a little bit. And then there is a HCM that is gene positive, which has a Mendelian inheritance with phenotypic variability, and there is clinical and genetic screening of family members. risk stratification for sudden cardiac death. So, so any risk stratification approach that we take is plagued by a low positive predictive value. And a good percentage of implanted ICDs may never deliver an intervention and the price to pay for saving young lives. And there is a high risk of sudden death in the competitive athletes, probably because there's a possibility that there is disease acceleration with exercise, and we do not recommend competitive sport participation in clinically aberrant hypertrophic cardiomyopathy. So in a patient with hypertrophic cardiomyopathy, undiagnosed patient, a young death is something that is very hard for all of us to take. So we want to avoid sudden death in these patients, and in order to avoid the sudden death, we have to look at some risk stratification tools. And the risk stratification, the incidence is only 1 to 2%, so as a result, it is a little bit of a challenge to get, you know, any kind of a stratification that's going to be perfect, you know. So the risk of sudden cardiac death is 1 to 2% annually. Number one cause of sudden death in young adults and athletes. Patients can present with heart failure symptoms or sudden death, and most of our young patients will present with sudden death. They can have a family history, unexplained syncope, ventricular tachycardias, arrhythmias, and the common cause of sudden death in HCM is ventricular fibrillation. So how do we risk stratify these patients, and what is the goal of risk stratification? The goal of risk stratification is to sort of identify patients who are going to be at risk for sudden cardiac death, you know. We want to avoid sudden death, and that is one of the main reasons we are doing this risk stratification and trying to figure out which patients should we be putting an ICD in and which are the patients that are going to be really high risk for this, you know. So family history of sudden death attributable to hypertrophic cardiomyopathy in first or second degree relatives. Number 2, unexplained recent syncope. 3, massive LV hypertrophy, wall thickness greater than 30. Multiple repetitive non-sustained VT on ambulatory monitor or ECG monitoring. And then hypertensive or blunt blood pressure response to exercise, although the latter two markers have proven less applicable in patients less than 18 years of age. So these are the guidelines that have come from the American College of Cardiology and the American Heart Association. So these are sort of the US guidelines that we have for prediction of sudden death. Now the European guidelines are a little bit different. You know, there are certain differences in the ESC guidelines. So in the ESC guidelines, they also talk about recommendations for doing cardiac MRI and recommendations for doing genetic testing. So in the ESC guidelines, they look at the age of the patient, and they have shown that that risk factors appear to be more important in younger patients, okay? Especially those with non-sustained VTAC, severe LVH, and unexplained syncope. So that is one additional feature that the ESC guidelines talk about is age. Non-sustained VT, again, greater than 3 consecutive ventricular beats at greater than 120 beats per minute lasting less than 30 seconds. You know. So then maximum LV wall thickness, and this is again on transthoracic echo, and same thing, extreme hypertrophy greater than 30. And they do mention over here, and I'm going to discuss this in a minute, that there is very limited data in patients with extreme hypertrophy. You know. Family history of sudden death at a young age, less than 40, that's a risk factor. Syncope can be seen in HCM, but it's very hard. Like our patient also reported syncope, but she said she only passes out when she sees blood. But it is a difficult thing sometimes to sort out how much of this is to be attributed to the HCM and what is the non-neurocardiogenic syncope. Left atrial diameter, again something not mentioned in the ACC-AHA guidelines, mentioned in ESC guidelines, that LA has been a positive association between left atrial size and sudden death. Left ventricular outflow tract obstruction, another thing which has been again mentioned in the ESC guideline, and then blunted exercise response, blood pressure response on exercise, you know. So when you look at these guidelines, again, as we mentioned, that the number of sudden death is small. So in the ACC-AHA guidelines, they dichotomize wall thickness into 30 millimeters. So there's a lot of discussion about that. What if the wall thickness is 29? How does this work, So based on the ESC guidelines, there is a score calculator, and I'm going to talk about that in a second, So some of the factors in the ESC guidelines are the same as the ACC-AHA approach: wall thickness, family history, and syncope. But in addition, there is an addition of age, outflow tract gradient, and left atrial diameter. So these are additional features that are in the ESC guideline. The ESC model allows inclusion of some factors as continuous rather than dichotomous variables. So the output when you look at the calculator and the output, the patient is put into one of 3 categories and given a 5-year risk of sudden death: less than 4%, 4 to 6%, and greater than 6%. The ability to include some non-binary factors as wall thickness as continuous variable leverages more information content, and it is a web-based tool. So if we go back to our patient and we do her risk calculation, so this is the calculator over here, and this is web-based. You can log in and you can look at it. Age of this patient is 55, maximum wall thickness was 35, left atrial size was 50, LVOT gradient was 120, family history of sudden death, it's not clear, but probably non-sustained VT we didn't have, unexplained syncope we did not have. And then if you look at the results, it pops out a result. So risk of sudden cardiac death at 5 years is 5.3%. So she's somewhere in the middle. ESC recommendation, ICD may be considered, So this is the little tool that exists, and sudden dose risk calculator. Important thing to remember that it's a risk of sudden death in 5 years, and it cannot be used for pediatric patients, okay? So that's important. It should not be used for pediatric patients, elite athletes, other causes of HCM, like Fabry's disease or Noonan's disease. And patients with previous history of aborted sudden death or VT who should be treated with an ICD for secondary prevention. So this is a primary prevention sudden death scoring to really predict if we should be putting ICDs in these patients or not, What about CMR? As you can see that neither ACC nor the ESC guidelines incorporate the extent of late gadolinium enhancement on cardiac MRI, which has significant and biological plausible association with sudden cardiac death. So you see scarring on the MRI, and can you really, why is that not a part of the score? So one of the things that you read about is that the big circulation paper, which came out in 2014, came out after the guidelines. So prognostic value of quantitative contrast-enhanced cardiovascular MR for evaluation of sudden death risk in patients with hypertrophic cardiomyopathy. So this came out after the guidelines, so the guidelines did not incorporate this. And compared with the results of the ESC recommendations and the ACC recommendations, so the ACC-AHA recommendation have higher sensitivity to detect those at risk, with more lives saved with ICT implantation at the cost of low specificity. So there is a false positive identification of risk resulting in what may be unnecessary ICD recommendations. ESC risk categories and recommendations result in lower sensitivity, missing more patients at sudden death who do not receive ICDs, resulting in more death, So the ESC recommendations are more specific, and the question is, so it really comes down to the point that what is fundamental to the differential impact of sudden death? It's a value judgment, I think, at the end of that. What cost are we and the patients willing to tolerate to minimize the loss of young lives? Unnecessary implantations with attendant complications of risk and financial implications. And you have to make a judgment, and I think some of these judgments have to be made individually about the risk tolerance threshold. What is your tolerance for that? And some of this risk tolerance is really dependent on where you are, and who you are working with. So like my patient, who is an Amish woman who pays for her care, she's 55. In her mind, if she lives another 10, 15 years, it's pretty good for her. That's what she's thinking. So does she want to spend $60,000 to $100,000 getting an ICD, or she wants to leave that money for her family? So it is really a very individual decision. It comes down to depending on your resources as to what your risk tolerance is and what can you do to prevent sudden death in these patients. And some of these things in terms of complications and what the outcome says is going to change. Now we have subcutaneous ICDs, technologies advancing, and these things are going to get better and better. And maybe we get to a point that it doesn't cost that much. It is not, there are not so many risks that are associated, and these guidelines will change. So this is a very dynamic process to prevent primary prevention and how to do that. So to summarize, the sudden death risk, non-sustained VTAC, severe LV hypertrophy, abnormal blood pressure response, unexplained syncope, family history of sudden death, and then in addition you have age, and then so the age is an LVOT gradient are all added into the ESC guidelines, but what we don't have is findings on the MRI. The outflow tract gradient is a part of ESC, but what about the genetic mutations? We still don't have that put into the guidelines as to which specific mutation it is. So in the world of precision medicine, with Georgia and Anwar on the call, these guys will tell you that which of these are bad guys and which of these are guys, mutations that are not so high risk, Now what about children? So in children, the risk prediction model for sudden death is a little bit different, and you can see that the LVOT gradient is not important, So the most important thing is the maximum wall thickness with a z-score of 0.005 and the LA diameter. So these are the things that are important in patients who are pediatric patients. So this study showed that there is a difference in the risk stratification model for the children and adults. So briefly to talk about family screening for phenotype and genotype. So we have the identification of asymptomatic carriers, cascade family screening. If a disease-causing mutation has been identified, specific genetic testing can be performed in the offspring. So again, genetic testing has challenges with access, So even now in the US, we are in a very privileged situation because we are able to get no-cost genetic testing or low-cost genetic testing. $250, patient who doesn't have insurance can get genetic testing. But I know it is not so easy in the lower middle income countries to get access to genetic testing. So mutation and precision medicine is harder in some parts of our world, But I want to just go back to our Amish community. We are able to do, we've actually done a lot of genetic testing within the community. And what I find is that using precision medicine, especially in limited resource environment, is a great way for optimizing resource allocation. So it is something to think about, that I think in LMIC, if we did have access to genetic mutation, we may probably be able to do a better job preventing sudden death and also doing some better resource allocation. Now, if the mutation is absent, clinical examination is recommended every 3 to 5 years before the age of 10, every 1 to 2 years between 10 and 20, and every 2 to 5 years after 20 years. Now, this 10-year age is again changing. There are some newer pediatric data which says that we should go lower in age group, and there are some changes that can be seen earlier in patients who carry the genetic mutation. So our patient was positive for MYBPC3. She has 8 siblings, 4 of whom tested positive with the mutation. She has 7 children, 3 of whom are positive. So now when you look at the burden of cost on this family, it is huge, So they have a lot of family members who are at risk for sudden death. So we have to, again, use our judgment and try to see what our risk tolerance is and what do we do with this family, So there's another patient we get in the office. Father is diagnosed at the age of 36. The daughter and son were evaluated and genetically tested, and they were MYBPC3 positive. Father and daughter have ICD. They have a 9-year-old son who's asymptomatic and was found to have just possibly a slight muscle thickening on echo. So this child we are going to follow, and we are going to see, we're not going to run to put an ICD in him till we see some more evidence that we would do that for him, So if you are genotype positive and phenotype negative, so you became a carrier, you have no phenotype, and you're asymptomatic, you will still continue to get regular evaluations and family counseling and screening. On the other hand, if you are genotype negative or positive, but phenotype positive, so then stage 1, 2, and 3 have been described. If you just have isolated ventricular hypertrophy with or without LV outflow tract obstruction, no symptoms, and you have very little diastolic dysfunction, then you do again get regular cardiac follow-up. And then when you get to stage 2, there is progressive hypertrophy, and you have diastolic dysfunction, and you have a positive CMR showing gadolinium enhancement, then I think the discussion comes up about ICD implantation for primary or secondary prevention. If they have AFib, that has to be treated, treat diastolic dysfunction and pharmacological intervention. And stage 3 is end stage, and that's the time you're headed towards a VAD or a heart transplant. So this is in brief just talking about the sudden death risk calculation and phenotype for patients with hypertrophic cardiomyopathy. Thank you for having me over here. Thanks.
Thank you, Devyani, for an excellent presentation. I also wanted to welcome Dr. Anwar Chahal, who is the adult electrophysiologist and inherited arrhythmia expert in Philadelphia. So I think we are open for questions, if anyone has any questions. Okay,
Anwar,
so
do you want, or Georgia, you guys want to make some comments?
I wanted to ask Anwar how you put the specific genetic mutation into the equation when you are planning to put an ICD. Does it have any implication in your decision, or is just for the screening purpose?
Yeah, thanks for that. And thanks to Devyani for a superb summary and presentation on how we manage sudden death risk. So the big promise and also the peril of precision medicine is using genetics to help guide how we're going to manage patients, whether that's in terms of direct interventions or actually helping us prognosticate. Initially, there was a lot of buzz in the hypertrophic cardiomyopathy area with sarcomeric gene mutations, and then several studies showed that it actually didn't help predict. So most people just went by clinical phenotype to help decide. Now that's starting to change now as we've started to test more and more people that we're finding particular gene mutations there. The first thing to think about is it syndromic hypertrophic cardiomyopathy or is it sarcomeric hypertrophic cardiomyopathy? And you'll recollect that Devyani looked at the sudden death risk calculator, the one that my colleague Kostas O'Mahony wrote, which was used in the EST 2014 guidelines. It is not applicable to pediatric patients, which are under 16 in the UK, under 18 in the US. And that's because hypertrophic cardiomyopathy usually presents in an adult. If it presents in a child, it's actually giving you a clue that it's not likely to be a usual single gene sarcomeric or autosomal dominant type. It could be other things that are a little bit rarer, such as Pompei's disease. So that's the first clue that you should look aggressively for those things. So genotyping there will make a big difference. And then in the adult world, when we actually look at this, troponin T has been identified as a particularly hot gene where you can have very little hypertrophy, but a real high propensity for arrhythmias. The MYBPC3 MY87s, which are the most frequent ones seen, and the other troponin mutations, the difference with those are it really depends on whether you've got a double hit. I think people who are homozygous for it, or they actually carry a second gene hit, it can make a big difference. But we have plenty of patients who have the exact same mutation, and yet one has particularly aggressive severe hypertrophy, scarring, etc., and another family member is just not as aggressive. It tells us that it's not a one gene, fits all story. There's more going on, whether that's environment or whether there's effect modifiers. So at the moment, coming back to your question, sudden death risk calculation, think about it as pediatric, where the genetics is very helpful actually, because you're trying to find the other non-sarcomeric causes or see if they're homozygous And then in adults, troponin T is one that does get us a little bit worried, but generally we don't go by the genetics in adults because we go by phenotyping. And sudden death is a rare event now in hypertrophic cardiomyopathy. It's roughly 1%. So you're trying to cream out, pick out those 1%. Therefore, to identify them, the majority are middle to older age who have hypertrophy that it's actually going to be okay. And AFib is a bigger problem in them actually rather than sudden death risk. So I hope that answers your question.
Thank you, Anwar. Georgia, I have a question for you as well. As being a pediatric electrophysiologist, there are two different risk calculators in the last 2 years. Nourish and et al. And from the Toronto group, Seema Mittal group, also published a risk calculator. How those calculators are different for the pediatrics. And I also want you to comment on the ICD implantation in pediatric population, because as a pediatric electrophysiology group, we have a lot of concerns of a psychological impact on children for inappropriate shocks. And the take-home message should not be that we have to have implant ICD in all the patients with a hypertrophic cardiomyopathy.
Okay, thank you. First of all, thank you for letting me be here. In fact, these two questions, well, now since 1 year, we have the risk calculator for children, a specific risk calculator for children, which I really think it's very interesting. And I have the feeling that we maybe over define the risk, but it's true that it's good for those straightforward cases. There are another whole group of patients which I'm really worried about are the mixed phenotypes, those carrying two pathogenic mutations, which, or sometimes I just was managing a case while you were talking. This girl, she's 4, she has a pathogenic mutation in MYBPC3 and also synonymous genetic variant in MYBPC3, so it's a biallelic case. She has a super severe phenotype, and she's only 4. And if you put her on the risk calculator, actually she should not be implanted, and she has already had 2 appropriate shocks. So it's true that those mixed phenotypes that are the ones that should not be taken as a whole, but in a very personalized way. Second, concerning ICDs in children. Well, it depends on, you have to really program them very well, and that's mandatory. We have to take into account that children move a lot, even if they are implanted, and they need to have movement. I mean, we cannot make them sit down on the couch. So we have to, for the programming, we have to accept that they will have sinus tachycardia, and it's very important. Normally, when we have inappropriate shocks in children, are because the electrodes have a problem, probably because they have crashed. That we can minimize that impact with home monitoring, because we have a control, monitored on which is the situation of those electrodes. And of course, we have to be with them. So it's not a fact us as doctors being on them, but especially us accompanying them, being next to their growth when they are 4, when they are 7, 8, 12, teenage adolescents. And that's very important, because then they will be responsible of their own body. And that's crucial for their lives and also their, I hope, long-lasting life.
Thank you. There is a question from Dr. Najma Patel.
Small and younger children, like 4 or 5 years, usually present with some sort of congestive heart failure. And sometimes if it is not, they are not in congestive heart failure, their ventricle is dilated. Ejection fraction is low, not like super in 80s, but it in 70s. Do you think that these patients can get benefit with ICD or some rhythm control things? And I have found in my practice, these patients have very bad prognostic and almost all die within 5 years.
Georgia, if you want to take the questions.
Oh, I think it's
Georgia, go ahead, take the question. Yeah, you take the question. Yeah.
For sure? I think that for those, it will mainly depend on which is the underlying condition. So probably genetics is going to be really helpful here. If it's related to, for example, myocarditis, it will depend on how attacked the myocardium is, on how affected the myocardium is. If it's a lamin type mutation, LMNA, probably this has a very poor prognosis, and we have to be very intense on treating them for congestive heart failure. Sometimes doing resynchronization might be of help if there is really something to synchronize. Normally those very early presentation dilated cardiomyopathies, they affect both ventricles, so trying to resynchronize them, it's probably we won't get any further with that. We have to remember that normally when in adults they resynchronize because the adult has left bundle branch block. Normally our patients have right bundle branch block. So in fact what we should do is just to try to resynchronize from the left, not from the right. So probably some type of normal pacemakers or normal ICDs that we put on the right ventricle will increase this right bundle branch block. So we will then have a situation of asynchrony or desynchrony. So it's very important when we think about implanting to take into account to have our echo colleagues next to us and to be very strict on the way where we implant, if it's indicated, and which is the technique.
Okay, thank you.
Thank you.
Thank you, Divyani, Georgia, and Anwar. We are done for this session.
Thank you. Thank you. Thanks.
Thanks for having us.
Bye-bye.
Our next talk will be on atrial fibrillation and management in these special situations. For that, I would like to invite Dr. Amir Hamid on the stage. Dr. Amir Hamid has completed his electrophysiology training in Canada, and he's professor of cardiology at Al Khar University Hospital.
Thank you. Assalamu alaikum. So, is it changing slide? Okay. So I have nothing relevant to disclose. So this is a topic, the use of anticoagulation in special populations, and so it's a kind of a dry topic. I'm going to talk about 3 conditions: coronary artery disease, especially when you have an intervention, chronic kidney disease, post-stroke patients, and post-surgery patients. Now, in all of these, the common theme is bleeding. They've not been well studied in a very randomized, robust manner with large landmark trials. The only thing that we've actually looked at in a scientific manner is the risk of bleeding. But you need to remember that when you are balancing the risk of bleeding, the risk of thrombosis remains. Whether it is neutralized, whether it goes up, needs to be understood. So I'll present 4 cases. So this is a 64-year-old man, atrial fibrillation, diabetic, hypertensive, run-of-the-mill AFib, has acute coronary syndrome, admitted, had a 99% LAD, got stented with a drug-eluting stent. This current admission, his EF is preserved. He's on good medical therapy. So what is the anticoagulation strategy? So the question is, does chronic oral anticoagulation therapy with or without antiplatelets have a role over here? So we need to decide whether we want to use aspirin, clopidogrel, or vitamin K antagonist, or DOAC. So we've got a lot of drugs in our armamentarium, and we need to make a wise decision. So I always tell them that it may not be the best decision, but it is going to be a safe decision. That is the strategy that we follow in this population. Now, in acute coronary syndrome patients who are receiving long-term oral anticoagulation for atrial fibrillation, when they undergo this stenting or fixing, what is the optimal antithrombotic regimen that you're going to use? So I'm going to show you that. And we need to remember that approximately 10% of the patients who have a PCI will have concomitant AF. So it's not a low number, it's a high number. So out of every 100 patients, 10 will present with this problem. I don't know whether it's projecting nicely or not. So if you, do I have a pointer? Yeah. Okay. So if you look over here, patients with atrial fibrillation who need PCI and either taking vitamin K antagonists or DOACs, and you go on to this side. So I will, because I cannot read this from this angle, I don't know. So if I take you down here, so you during the PCI process, you will follow the PCI guidelines. This is on this side, so I won't go through it because frankly I cannot read it. So keeping on this side, you have the procedure done, how to follow up. Now you can restart if you're on oral anticoagulant, you prefer a DOAC, and you can initiate that, and you can initiate clopidogrel therapy. If you're using a vitamin K antagonist, you can do the same over here also. When you go down, now the question is, how long are you going to give triple regimen or dual or a single agent? So if you go down here, so you have PCI for stable coronary disease. So if it's a stable coronary disease patient who's been fixed, you will go with continue clopidogrel for at least 6 months and overlap with the DOAC that you're using according to the prescribed dose. After about 6 months, you can switch to either aspirin or continue with clopidogrel. You will assess bleeding risk at all levels. Once you have finished the year, you can actually go off antiplatelet therapy and you can stay on the DOACs because they will suffice, because by that time you have endothelialized stuff and the risk has gone low, so the bleeding risk is then weighed with the benefit. On the unstable side, if you've stented someone, you do not go to the cutoff 6 months, you continue this for about 1 year, and after 1 year then you go to no antiplatelet therapy and continue the oral anticoagulant and prefer DOACs, because now the DOACs data is safer for bleeding. Although if you use vitamin K antagonist in a proper way, that is 77% of the times if you are in therapeutic range, then these are non-inferiority trials. So you can continue with that as well, depending on how comfortable you are with the use of the drug. Now the second case is again the same person, but now this person has CKD, that is chronic kidney disease. Now what is important to understand is that increasing bleeding risk in CKD, the platelets become lethargic and dysfunctional. All DOACs have renal excretions. So if you are dysfunctional, you will start rotating. So you need to adjust dose if that has been recommended. And dabigatran, unfortunately, is the only drug, DOAC, that has been studied in a randomized fashion with a low dose. We prescribe a lot of 2.5 milligrams of apixaban. Apixaban has not been randomized. For that thing, it was a post hoc analysis, albeit in a scientific manner, but hamari jo holy grail hai of randomized control trial, that is not the case over here. Now, dabigatran is the most excreted from the kidneys. Anticoagulation therapy with vitamin K antagonist is associated with increased nephropathy and renal vascular calcification. That has been studied. If you keep someone on long-term warfarin, they tend to develop vasculopathy as well. Therapy with DOACs should be more advantageous in such situations, so more data is coming through. Data from clinical studies seem to show that the use of dabigatran and rivaroxaban in these patients may lead to a reduction in the inevitable deterioration. So if you're using DOAC, intuitively it makes sense that it will do better. Now, there are 8 RCTs and a meta-analysis that showed that apixaban or rivaroxaban dose, apixaban and edoxaban dose adjusted was superior to other oral anticoagulant therapies in reducing bleeding events in these CKD patients. So these two have come through. And dose-adjusted apixaban was more effective than edoxaban for these mild to moderate dysfunctional renal patients. And in hemodialysis patients, apixaban has been approved by FDA for usage, although when it was studied, oral anticoagulates increased the risk of bleeding up to 28%. That's relative risk reduction without significant beneficial effect. So what I was saying was that your risk of bleeding goes up, your other effects remain neutral. So at the end of the day, the net effect may not be very beneficial. So you have to tailor your therapy. And the other thing to remember is all these trials have been done on other populations. And we have to accept sometimes कि हमें नहीं पता हमारी population में क्या होगा. And that is not a good answer. We should actually do a study and see what the effects are for our patients. Now, another study showed that 4 hours of hemodialysis session in patients with terminal CKD treated with apixaban 5, that is full dose, resulted in drug exposure almost comparable to that of healthy volunteers. And on the basis of this, FDA has approved apixaban, which probably is the only drug that is recommended in this situation. Now, in patients with terminal CKD, the effect on ischemic events and other mortality was neutral, as I had already said, with a significantly increased bleeding. So we need to weigh and analyze as we go along. And other more recent meta-analysis with warfarin associated with neutral effects on ischemic stroke mortality, major bleeding with a significant increased hemorrhagic risk. So warfarin is doing the same. Although we were led to believe that if we are using warfarin, because there is data and we can use it, does not take us away from the point that that warfarin is also causing increased bleeding and in this high-risk population giving a neutral benefit. Now, try to understand, when we do research, we try to weigh the risk and benefit. So the higher the risk is, the more the benefit. And as we go along, you will realize that in लोगों में हम अगर थोड़ी देर के लिए भी anticoagulation छोड़ेंगे, because the risk is very high, thrombotic risk बढ़ जाता है. और अगर हम इनको enthusiastically anticoagulate करते हैं, तो we actually cause more bleeding. So treating them, we have to be very, very astute and very, very on with it, making these decisions. So this meta-analysis, which is very recent, in 2021, they concluded that the study suggests that DOACs are superior to warfarin for the prevention of thrombotic events, as has been seen in all other trials. So they are extrapolating that data and a comparable or less bleeding risk in patients with AF, with kidney disease. So when you have kidney disease, DOACs would probably be preferred, and you have the apixaban FDA recommendation. But remember, FDA recommendation does not mean that it's a randomized controlled trial suggesting us. It's a weak observation. But that's all we have. The third case is again the same man. This time, he has a thrombotic stroke. So he comes in with that. Remember that people who are going to have thrombotic strokes are very high risk for having a repeat event immediately. So the early phase is very, very important. And that is what we should take home today. Now, 13 to 26% of all ischemic strokes are related to non-valvular atrial fibrillation. So that's what we're seeing a lot, because our rheumatic atrial fibrillation burden is still there, but the non-valvular, as people are aging, is going up with risk factors and with rampant coronary artery disease. None of the DOAC trials included patients who had experienced recurrent stroke or recent stroke. So this is an area, again, which is a blind spot. We have trials, and can we extrapolate data of the main trial to these populations? Maybe not. RCTs have shown that DOACs, all of these, are at least as effective as VKA in the primary and secondary prevention of AF-related ischemic stroke with half the risk of bleeding. So ये तो हमें पता है, इसीलिए ये अंदर आई हैं कि they have about the same benefit if warfarin is used decently, not exceptionally, decently, and the bleeding risk is less, which in these populations that I'm describing today probably means more. So evidence suggests that prospective observational studies and two small, sorry. So I've used the wrong. So prospective observational studies and two RCTs have investigated the risk and benefit of early DOAC administration in these patients, that is 3 to 5 mean days in mild to moderate AF-associated ischemic stroke. So this again is a very well-defined mild to moderate AF, so they have not taken again severe strokes. And so early DOAC treatment was associated with a low frequency of clinically symptomatic intracranial bleeding or surrogate hemorrhage lesions on MRI. So this, they have specifically looked at this for bleed for the DOACs. And recurrent stroke, later DOAC administration, which is more than 7 days or 14 days. And why have they marked 7 or 14 days? Because most guidelines have touched on 7 and 14 days. And they've shown that this window of 7 to 14 days is actually not a good window. Because in that, there is an increased frequency of recurrent stroke. So in acute AF-related ischemic stroke, the risk of both early recurrent stroke and hemorrhagic transformation is highest in the days immediately after the stroke. That's a problem. जहाँ risk जितना benefit ज़्यादा है, उतना treatment का नुकसान भी हो रहा है. So again, you are not actually breaking the barrier, you're just playing in between. And I'm sure everybody over here has experience and will have something to say about it. So the ERA, the European Heart Rhythm Association, gave us this rule of 1, 3, 6, 12. That is when to initiate at what event. But this is, I think, redundant now. What was recommended by ACC-AHA is 4 to 14 days. The UK guidelines suggest after 14 days, the German guidelines 14. So 14 has been a constant safe figure that electrophysiologists or cardiologists have kind of taken to heart and are sticking to it. But as I've shown you, the evidence suggests that this window of 7 to 14 days is dangerous. And so the EHRA rule, if we follow that, then we're actually impinging on this window. This is very latest from stroke. And this is, the Japanese have worked on this. And what they've shown is that patients with AF and acute ischemic stroke or TIA, with the exclusion of hemorrhage, by CT or MRI. So again, defined population. If you have a TIA, start DOAC, and these are preferred on day 1 after the event. This is 1, 2, 3, 4 rule. If you have a mild stroke, according to classification, and you can actually objectively look at it, then you can start it on day 2. And consider additional clinical factors favoring early delayed DOAC. So high-risk features would be, factors favoring delayed would be huge infarcts, hemorrhagic transformation on MRI, which you can see, or CT scan, and uncontrolled hypertension. These are patients who will bleed on you, so you can wait on them. But other than that, have the courage to go in, and for mild strokes, the neurologist will tell you if you cannot calculate it, you start it on day 2, because that is the recommendation being asked of you. And if you have a moderate stroke, you can go with day 3. And if you have a severe stroke, then day 4. So we are actually even within the American Heart Association, which is suggesting the earliest. So you go with severe. So this is all evidence-based. This is something that can be followed. And in the interim, evaluate hemorrhagic transformation by CT MRI on the same day of the DOAC initiation. That is when you're actually going to make the decision. That is the day you should have the information right then. You should not have a day old or 2 day old, because this is a very critical area of 4 days. Now, let's say that we favor bleeding. Then we know through evidence that in this period, you will get recurrent strokes. And we do that. Sometimes they're subclinical. Sometimes हम कहते हैं hemorrhagic infarction हो रही है because the patient is worsening clinically. Something is happening. So this population needs to be, I think from electrophysiologist or cardiologist point of view, need to be looked at in a better way in coordination with the neurologist. So the last case is a woman for hip replacement. Now this is a very common situation. And so what do we do over here? So interruption of anticoagulation temporarily increases the thromboembolic risk, and continuing increases the bleeding risk. Again, what to do? Both of these outcomes, that is bleeding and thrombotics, can actually increase mortality. So we are now pushing on the limits of mortality, and therefore we need to make the right decision. Estimate bleeding risk, although it may be transient or may be permanent. If you're using platelets uselessly, मीठी गोली की तरह दिया हुआ किसी को aspirin बंद करें, your risk will come down. Or it can be a permanent risk. You're hypertensive, you're old, you can't change that. Estimate bleeding risk, and that can be changed. Timing of the interruption, kitna zyada interrupt karna hai usko. So try to go with bare minimum. And whether bridging is needed. Now in this day and age with DOACs on board, bridging is minimalist. You don't bridge very often patients. Now, so for VKA, recommendations is hold for 5 days. So that means the last dose should be given on -6, that is day 5 before. So 6 minus -6 के ऊपर आपने लेना है, day -6. Bridge with enoxaparin if the risk is high, and if we used to use dalteparin, but I'll go with enoxaparin. So skip last dose should be the evening dose, skipped before the surgery, not the day before surgery. And start VKA within 24 hours, your usual dose on which you were stable, and post-operative bridging or on post-operative day 2 or 3 can be allowed if the patient has a high thrombotic risk. So you can go 48 to 72 hours. Remember, bleeding can be much worse than, is more common and can be more detrimental than a delayed thrombotic event which may not come. So you have to wait against that. Continue for at least 4 to 5 days until the international INR is therapeutic, and then you can stop. Similarly, for DOACs, hold apixaban, and I'm using apixaban over here because it'll be used in most, even in CKD it is recommended. 24 hours before the procedure, so last dose of apixaban should be day -2. So you should take it, skip the day before the surgery, and the last dose should be day before. And you don't require bridging. Resume the day after the procedure, after at least 24 hours have elapsed, and when hemostasis is maintained. Now there are a lot of words in that. Now if the surgeon has messed it up inside, he will know. So if he needs to wait for 48 hours, he should wait for 48 hours. But if he's done a good job and he says, no, I'm fine, go according to guidelines, then that is it. Now for moderate risk of bleeding, hold for 48 hours and then go with for 48 to 72 hours depending on the clinical situation of the patients. So rough idea ये होना चाहिए 24 hours पहले और 72 बाद. That's your range. That's the limit you can play within. And you can come early also if you feel that the bleeding risk is low and this thing has been done complete. Now if you have a high risk surgery like CT surgery or a kidney biopsy, then you have to be careful. If you've had a dental procedure or an endoscopy, that's a different case. So you need to weigh the surgical risk also. So in the end, I would say that VKA should still be used because it's cheap. We are more comfortable with it. But understand the dynamics. You need to be therapeutic range at least 80% of the time to match this. This is still safe for bleeding, safer. Use resource at hand, learn to use the oral anticoagulants, bridge for high-risk patients only, don't bridge for everyone because it causes more bleeding and that causes more mortality. Unwanted and preventable bleeding can be more detrimental than extending the oral anticoagulants free period. So this is my last point. With this, I thank you.
Now for the next 10 minutes, we will invite the panelists for their opinion and question and answers.
Nice presentation by all our presenters, and it seemed to be that it was a reign of atrial fibrillation in this session, talking about all sorts and all corners. How do the patients present with either complicated, uncomplicated chest pain, and especially the last session with Dr. Amir, who the management of atrial fibrillation in strokes with DOACs, and when to stop and to having a post-operative care. And nice presentation with the hypertrophic cardiomyopathy, especially involving the pediatric cardiologist and management of ICDs. The whole program was very good. I would suggest to society that a sort of course of ECG should be put on, like the ECG drill that has been done in the American Heart Association and the ACC, and frequently It should be done in 3 or 6 months, involving all the cardiologists for training. Thank you.
So the atrial fibrillation, we see it very commonly. In the situations that were discussed, we see it every day in our clinical practice. It's very important for our trainees to be aware of these things. You know, the Church-Weiss score, whenever you see a patient, you have to calculate the score. You see the bleeding risk, and then the appropriate anticoagulation whenever, whatever strategy is important. The other thing is the hypertrophic cardiomyopathy is another condition that we as an adult cardiologist see in adult age. And again, most of the time that I have seen, the echo is a problem. The echo reporting, you know, when we revisit, we see the findings much different. So I think that's very important that when we see our own a patient with hypertrophic cardiomyopathy, we should confirm the findings on the echo, the LV diastolic dysfunction, whether, you know, and then the appropriate referral. Many patients, you know, we see these once a year or twice, patients who really need either intervention or referral to an EP specialist. So it's very important to know these patients who are higher risk for either sudden cardiac death or some of them need intervention for septal ablation, etc. So about this program, I think this is one of the very wonderful educational meeting that I have seen in the last 2-3 years. And I appreciate the effort by the EP community to educate all of us. Thank you.
First of all, I congratulate to the organizing committee, especially Dr. Ghazala, over in this excellent program, and bring this interventionist, cardiologist, general cardiologist, and electrophysiologist one platform, and to deal this common issue that is atrial fibrillation and other problem which leads to the sudden cardiac death. जैसे हम intervention cardiologist होता है कि एंजियोप्लास्टी मीन्स स्टैंडिंग फर्स्ट ऑप्शन, तो हमारे जैसे अभी कर रहे थे कि एट्रियल फिब्रिलेशन कर रहे थे कि एब्लेशन इज़ द, सो एब्लेशन के लिए पेशेंट को भेजें और डू द एब्लेशन, बट बिफोर दैट वी हैव टू look for the what are the factors which leads to this major problem in the community. As someone discussed that the majority of the patients with stroke, they have in background the atrial fibrillation and they present with the stroke. And these are the actually group of the patient. We look in the community, we give education to the community and look the risk factors which are producing these major problems. So as you know, this weight, diabetes, hypertension, these are the common problems. Everybody, I think, the awareness of regarding this is very important. Either coronary artery disease, either stroke, atrial fibrillation, other things. So we should consider on these things also in order to decrease this burden. Treatment, I think it's very important, especially in the paroxysmal atrial fibrillation is a miss in the general. I think here's experts are sitting here. So majority of the patient doesn't know they develop the event for 1 and 2 days. They're feeling of some palpitation and then they forget. And this repeatedly happens and this leads to the showering of clot brain. They reaches to the hospital when they develop the stroke. And I think this group of the patient should be addressed. And this should be screened in the general population, either to give. Second, the use of the anticoagulants in the stroke patient is very important when to use. This is very important in the post-operative patient. But if you have the tools in your area, especially CT, MRI, I think latest guideline is more effective. You can start on the day 1 in the TI, minor stroke, day 2, and then so on. But in starting these things, you should look for that the chances of bleeding in this high. And if you have the CT, MRI easily available and patient is affording, then you treat this patient aggressively. Otherwise, the rule of 14-6 is important in the general population. Instead of treating this patient, they are converting this patient into the major complication is the hemorrhage. Overall, excellent presentation regarding the sudden cardiac death. So again, congratulations to all speakers and the conference. Thank you.
Nice presentations. क्योंकि सारी atrial fibrillation की बात थी, let me go back in time. 1990 was a very important year for cardiac electrophysiology globally. Why was that? It was that the then United States President George Bush the Senior was visiting Japan. And while addressing the public, he felt dizzy. Was taken to a hospital, probably he fainted. And when he was taken to hospital, ECG showed atrial fibrillation. It was exciting for us in electrophysiology world, particularly because now we knew कि हमारे careers secure हो रहे हैं. That now that the US president has an cardiac electrophysiological problem, now EP was going to come up as a significant specialty. Importantly, people got very excited, at least the institution where I was getting training and in UK. They said, these Americans are going to figure out what causes atrial fibrillation. Well, there they were wrong. Because it wasn't the people in United States. It was actually the antithesis of United States than France. So, Michel Hessiguier's group in Bordeaux in the next decade, around 1999, they said, okay, it's something coming from the pulmonary veins. And that is what leads to this manifestation that we call atrial fibrillation. But let's be humbled. How much did our understanding of basic genesis of atrial fibrillation, what happened? Did it improve? I'm not so sure. Because again, as Tala remarked, that all that looks like atrial fibrillation on ECG may actually not be atrial fibrillation. And then all atrial fibrillation is not the same. And what have we achieved so far? Whatever human accomplishments ever since have been, we have become better and better in improving the manifestations, the symptoms of, and perhaps consequences of atrial fibrillation, be that through improvements in pharmaceutical therapy, anticoagulation, our understanding thereof, or various methodologies that have come in to try and ablate and control, at best, atrial fibrillation. But let's be humbled, we are still far from understanding the basic causality and pathophysiology. And it's probably, in the little that I understand, it's more to do with neural, something abnormal happening to parasympathetic innervation vis-a-vis parasympathetic ganglia on the posterior wall of the left atrium mostly. And that's why, we say that atrial fibrillation is a left atrial problem, flutter is more of a right atrial problem. So let's be humbled. Whatever we are doing a decent job. Just one comment, Dr. Sir. While doctors, the electrophysiologists are trying to figure out their domain, electrophysiologists को ना मशवरा दीजिए कि वो आके आपको ECG पढ़ाएं, क्योंकि मुझे डर है कि हॉल खाली होके दौड़ जाएंगे सब लोग. Thank you so much.
Okay, it's time for shield presentation. I would like to call Dr. Ashraf Dar on stage to present the shields. I would like to call first presenter, Dr. Yavar Saeed. It's coming. नहीं आ रही है. Dr. Amir Hamid. General Imran Majid. Dr. Tariq Ashraf. Dr. Nawaz Lashari. Dr. Ahmed Noor. Okay, we can have evening tea.
So
then we can start another session.
We have tea at the back, so we can start taking the tea and come back, and then we can start
another
with the
session. It would be last presentation. Thank you. Hello. I hope everyone is done with tea. Can we start the session? We are starting the session. Please be seated. किधर? I would like to call panelists on stage. My first panelist is Dr. Professor Najma Patel. She is the HOD of Congenital and Structural Heart Disease at Ziauddin Hospital. Professor Azam Shafkat. Dr. Hussain Baksh, she is Assistant Professor at NICVD. Okay. So our last talk for the session is Arrhythmia Management in Adult Congenital Diseases by Dr. Mohammad Mohsin, who was the first pediatric electrophysiologist of Pakistan. He did his fellowship from University of Alberta, Canada. Please, Dr. Mohsin.
Assalamu alaikum, and thank you organizers for giving me opportunity to talk about adult congenital heart disease and arrhythmias. I will start with the background of the problem. That is, few decades ago when our seniors started the pediatric cardiology, the congenital heart disease was considered as a pediatric problem. And the reason was the majority of moderate and severe complexity patients didn't survive for long. So it was considered a congenital and pediatric problem. But thanks to surgical colleagues and interventional cardiologists who did a great job in palliation and treatment of those complex patients, because of that better medical opportunities, the survival is increased, and as a result, those adult congenital population is increasing day by day. And in very much of developed countries, the population of adult congenital is already more than the pediatric patients. So if we look at the data from US in 2010, they published that they have 1 million children with the congenital heart disease, and at the same time they have 1.4 million population of adult congenital heart disease. So the number in America or US is already exceeding the pediatric population. And when we look at the cohort of those patients, around 40% are of moderate disease and 15% are complex disease with mostly single ventricle physiology or atrial switch procedures have been done in past. So despite the better survival to adulthood, they still have the problem that heart failure is very highly prevalent in those adult congenital heart patients, especially those patients who survive more than 40 years. The main reason for their morbidity and mortality is still the heart failure. So when we look at the causes of heart failure in that population, there is a bidirectional interaction between arrhythmias and heart failure. So the number one thing that we need to be kept in mind that if you are going to treat a patient with a adult congenital patient with some kind of arrhythmia, you need to be very aggressive in treating the heart failure, and that is we are already listening since afternoon in the case of atrial fibrillation that the substrate has to be correct and the heart failure has to be aggressively managed. In congenital heart patients, there are a lot of residual lesions and valve regurgitations like tetralogy of Fallot. They present in adulthood with a severe PR or PR. So if they present with the arrhythmia and you are not going to correct the PR, your all efforts to correct the flutter or whatever the atrial arrhythmia is ultimately go unsuccessful. So you have to first focus on treating the cause of the heart failure, and then you have to treat the arrhythmia at the same time. But the interaction is bidirectional. Many of those patients present with the arrhythmia and that lead to the heart failure. And if you look at the causes, there are many causes for heart failure and arrhythmia, like structural remodeling in the form of dilation, fibrosis, hypertrophy, and there is ion current and transport changes because of the hypertrophy and dilation. At the same time, when we look at the mechanism for arrhythmia and the consequences of arrhythmia, there are conduction disturbances, and because of that, there could be low cardiac output syndrome, hypoxemia, and tachycardia-induced cardiomyopathy that can lead to heart failure. So it goes side by side, and you have to treat both of them, not only one of it. So what is the burden, and how frequent you see patients of adult congenital heart disease with those different kind of arrhythmias? So burden is enormous, and there is a huge population who has these problems in the growing age. So if we look at the most common cyanotic heart disease, that is tetralogy, and most of the patients go for the biventricular repair, they still present, 1/3 of the patients present with some symptomatic atrial tachycardias in their adulthood, and 10% develop ventricular arrhythmias and have risk for sudden cardiac death, and 5% population still have surgically or acquired AV blocks or sinus node dysfunction. Similarly, when we look at the Fontaine procedures or single ventricle patients who are palliated with the Fontaine procedure, around 50% of patients with the single ventricle within a decade of surgery present with some kind of arrhythmia. These risks were more in old kind of Fontaine surgery. Now we have like extracardiac Fontaine. They have a little lesser chance of developing atrial arrhythmias, but the risk is still here. And the last most common population we saw in past decades is the transposition of great arteries who are being palliated or corrected with the sanding or mustard procedure. Almost all patients develop the sinus node dysfunction, some atrial arrhythmias within 10 years or a decade of their repair. So the burden is enormous. And when we look at the causes, so there are pre-operative and post-operative causes of developing those arrhythmias because they are very special group of patients. They have pre-operative risk factors that in the shape of like anatomical problem like sinus node dysfunction. We see in patient with the isomerism, there is a left atrial isomerism in which there is a high prevalence of sinus node dysfunction. And there are other congenital disorders who have AV valve regurgitations which lead to atrial dilation, and it can lead to the lot of arrhythmias. There could be abnormal AV node morphology in like CCTGA or corrected transposition or twin AV node physiology and accessory pathways in case of Epstein anomaly. So there are a lot of preoperative causes of developing arrhythmias in those patients. To add on, there are postoperative causes as well, like sinus node dysfunction. If you are dealing with a sinus venosus ASD, partial anomalous veins, the surgeon is at risk to injure the sinus node, and these patients can develop sinus node dysfunction. Similarly, in Sanning or Mustard procedures, in which surgeons do a lot of procedure in the atrium, so they are also risk of sinus node dysfunction. Similarly, there are atriotomy scars that lead to the re-entrance circuits and lead to intraatrial re-entrant tachycardia. Commonly we call it flutter, but it is different from flutter by having slower rate than the flutter. They usually go from 150 to 250 beats per minute. And then there are cause of mechanical AV node injury, regurgitations again, and ventricular abnormalities that lead to a lot of arrhythmias in those population. So when we look at the specific arrhythmias, there are certain arrhythmias that are being associated with a specific type of congenital heart disease. Like in Epstein anomaly, there are like 20% of Epstein patients present with WPW syndrome. In CCTGA, heterotaxy syndrome, you can have twin AV node physiology, not physiology actually, you can have a twin AV nodes, and there are other lot of arrhythmias that can happen in specific congenital heart disease, and we should be aware of those. So I will go through a bit briefly about common types of arrhythmias that you can see in adult congenital heart disease. One is ORT, orthodromic re-entrant tachycardia, that you can get in patients with Epstein anomaly. And many of you guys know that 20% of patients with Epstein anomaly born with WPW syndrome, and then they can present with some kind of tachycardia at any age, before surgery, after surgery. So you should be very careful when you plan any surgical intervention for those patients for treatment of associated arrhythmia or any accessory pathway. Similarly, you can have a twin AV node, and you can have a sling that is called a Monckeberg sling in heterotaxy syndrome, CCTGA, and that also induces a re-entrant kind of tachycardia between two AV nodes. So you need to be very knowledgeable about those structural changes that can lead to many types of arrhythmias. The other most common type of tachycardia you see in adult congenital heart patients is the intraatrial re-entrant tachycardia. We call it IART, and commonly it's been called as the atrial flutter. The reason is the mechanism is almost the same. It's a re-entrant tachycardia in the atrium, but there are differences. Usually they are slower than typical flutter. They run at rate of 150 to 250 beats per minute because there is a lot of fibrosis, scarring, and they are usually slow. They can be found anywhere, not necessary at the location of cavus tricuspid isthmus or around the tricuspid valve. It can be around atriotomy scar, any area of fibrosis, or any surgical intervention that was done. So these arrhythmias, these re-entrant tachycardias can be found anywhere, and you can see in this 3D image there is a circuit that is going around the tricuspid valve. So this is the ECG of one of those patients who present with irregular heart rhythm. That is a ECG of adult congenital patient. And when we work, we trained as adult congenital EP person, it is a conventional teaching that whenever you see a heart rate more than 100, you should have very good reason to justify that the patient is in the sinus rhythm. So you have to prove that patient is not in any kind of tachycardia because they are slower and they can be easily missed. So if you are not going to look in very detail, you can easily miss those tachycardias because they are slower and they can be easily missed. So in this picture, if you see there are flutter waves, and if you see the rate of those flutter waves, it's around 400 millisecond or 40 millisecond. And if you look at the rate of those flutter waves, the rate will be around 170 or 180 beats per minute. That is very slow as compared to the typical flutter that goes around 300 or 400 beats per minute. So it can be easily missed, especially some patients present with 2:1 tachycardia, 2:1 ventricular conduction, and in that case the 1 P wave is usually merged with the T wave and you easily miss those tachycardias. So there are atrial fibrillation. I am not going to go into very much detail of atrial fibrillation because you already heard a lot, and there are risk factors for ventricular tachycardias in those patients as well. So there are bradycardias in adult congenital patients as well, and the most common reason of bradycardia is the sinus node dysfunction. And we already discussed there are developmental defect at the caval and triatrial junction that can be associated with the anatomical problem, and then there can be functional problem of the sinus node. And the one more cause these patients develop sinus node dysfunction is if the surgeon is going to work in the area of sinus SA node or in the territory of blood supply of the SA node. So these patients can develop sinus node dysfunction. And then we know the AV blocks can present in the congenital heart disease as well, like CCTGA that has the 3% risk every year of developing a new AV block because of the abnormal AV node morphology, as well as there is a risk of surgical related AV node block at the time of any surgical intervention or any catheter manipulation. So in LTGA we know there is a high risk and there is susceptible to the traumatic injury as well. Excuse me, band ho gaya. So now I go into the management strategies for those arrhythmias. So the number one thing is you have to have a clear idea what kind of arrhythmias these patients can have, and then you start thinking how to manage that. So the number one thing is if there is a heart failure, you have to manage that appropriately. If there is any hemodynamic abnormality, you have to go and treat it before treating the arrhythmia. Because otherwise it will come. It will come again, you control it briefly, you use high doses of antiarrhythmics or other medications that can have side effects. But if you are not going to treat the underlying hemodynamic abnormality, it will come back. The consensus for us, the Pediatric and Adult Congenital Society, is that the rhythm control is obviously better than the rate control, and it's not same for the AFib in adults. We think that the rhythm control is better, but again it's an expert consensus because we think that the atrial kick is very useful in those patients with the low cardiac output, heart failure, and we have to go aggressively for the rhythm control. So what are the options? What are the tools? So the number one tool which we use is the pharmacological therapy. And what kind of drug we want to use? It depends on many other factors that you start thinking when you see any patient with the arrhythmia, adult congenital. You have to be carefully look for sinus node dysfunction because all the antiarrhythmics slow the sinus rate as well. You have to look for the AV node conduction, either it's normal or compromised or having some high-grade block. You have to think about systemic and periventricular dysfunction, associated therapies, age, childbearing age, and other comorbidities. So the other thing, when you look at the acute pharmacological therapy of those arrhythmias, the class 1 or indication is before starting the antiarrhythmic. It should not be the reflex action to start any antiarrhythmic medication. You have to look for the potential coexisting factors and then you decide what you are going to do with that patient. So there is a lot of concerns for use of amiodarone in pediatrics and pediatric societies because of the high chances of developing side effects. So when we look at the amiodarone use in adult congenital patients, especially with those patients having some kind of atrial arrhythmias, the acute success is pretty good. But with the time, when you look at the Kaplan-Meier index, your atrial arrhythmia recurrence goes down, but at the same time, there is a high side effects profile that goes up and up with every passing year. And what it can lead to discontinuation of therapy in around 60% of patients. So when you are going to commit to a pharmacological therapy, especially amiodarone, you should have a plan B, what you are going to do after a year or 2 years. It's not for life, and probably the recurrence chance will be high if you are keep on them on high doses of amiodarone, and by doing just a reflex action, increase the dose every time the patient comes with a recurrence. There is a huge side effect profile. And we saw the patient adult congenital, they have a high risk for pulmonary hypertension as well. Many of those patients has pulmonary hypertension, and one of the feared side effects of amiodarone is the interstitial fibrosis. So you need to be very careful while using amiodarone. So for acute success, it's a good drug to start with, but not a long-term, it should not be used for very long-term. You should have a plan B. What you will do after some years. So again, being a EP physician, catheter ablation is always option, and it's now a consensus that before committed to a pharmacological therapy, you should start thinking that how you can offer a better chance to the patient by giving them chances of catheter ablation. And for atrial arrhythmias, when we look at the data, the acute success for catheter ablation is 75%. It's getting improved by day by using the most recent technology, 3D mapping, and a lot of other emerging technology. But again, the success is 70%. Moreover, there is a chance of recurrence, as we talked in the AFib, that it not go forever. It will come back, so it can provide you a bridge between pharmacological therapy and arrhythmia-free interval. The important point is there is a lot of technical issues when you talk about the catheter ablation in those patients. So it's not a piece of cake that you wake up someday and you say, I'm going to ablate a patient with sending. You have to have a very proper pre-procedural planning that maximize your safety as well as your chance of success. One of the important aspect is when are you going to plan the procedure, you have to read the operative notes, surgeon notes very carefully. And you have to have the idea how surgeon makes the suture lines, how he do what areas he manipulate during the surgery. So surgical notes are very important in planning the procedure. At the same time, there is a lot of problem with the access. These patients have a lot of like 4 or 5 times cath done. There could be venous blockage. There could be anatomy that you can't enter into the heart, like the patient is having a Fontaine palliation, and you can't enter the heart through the vein. So you have to think about how you are going to get the access. So access can be limited by venous anomalies, vascular obstructions, there could be stents, there could be conduits, patches, prosthetic material. So you have to have a very thorough plan for all those problems. And last is the three-dimensional 3D mapping system that helps a lot from last decade. And since we are using the 3D mapping, the success rate is going up and up. So the other tool is the device therapies, and I'm not going very much detail into the indications that are sinus node dysfunction and AV blocks. That usually is the class 1 indication for pacemaker. The other thing is chronotropic incompetence. You have to be carefully look for the patient's symptoms and how the chronotropy is working for them in case they are symptomatic. Because of chronotropic incompetence, in that case you can have a pacemaker implanted. And the last reason is many of those patients present with the tachybrady syndrome. They have the sinus node dysfunction, plus they have those IARTs going on. So those patients can be treated or helped by having the pacemaker, and you can pace them at a bit higher rate, like 60, 70 beats per minute. And it can prevent the tachycardia by not giving the chance of any PSE to come in and initiate the tachycardia. Again, for pacemaker, there are technical difficulties that you have to be very careful of, like congenital venous anomalies, acquired venous occlusion, inability to access a chamber, surgical obstacles like patches, conduits, and baffles. There could be intracardiac shunts. There could be a ventricular geometry and position. And one very important point that I want to highlight is current pediatric pacing guidelines says there is, in the presence of intracardiac shunt, transvenous lead is class 3 indication. And when we talk to pediatric electrophysiologists in North America, they are of the opinion that yes, it's contraindicated in the case of intracardiac shunt. They didn't define it. Either they are talking about left to right shunt or right to left shunt. They say it's contraindicated. But at the same time, we need more data from developing countries where we can convince those North American physicians and societies that isolated left to right shunt can be implanted with the transvenous pacemaker, but till now we does not have any data to prove that there is a high risk of thromboembolism with the transvenous leads in that case. So some of the X-rays of X-rays with the unconventional transvenous pacemaker. This is a patient with having a mustard procedure with the LA and right ventricular lead. You can have to put a transcutaneous ICD in some situation. You can have epicardial CRT, have to be placed in certain situation. We talk about primary prevention ICDs. There are many risk factors, especially for tetralogy of Fallot, and it's keep coming in. The high risk are those patients who present with ventricular dysfunction. And cardiac resynchronization therapy, CRT. Till now, we have no good evidence that it can be beneficial in pediatric or adult congenital patient. The only patient group that show benefit is patient with the CCTGA. We can think of the implanting a CRT, and then the His bundle pacing we talked, it can be more physiological pacing. So from me, take-home message is in patient with congenital heart disease, arrhythmias and heart failures go hand by hand, and they coexist, and you have to treat them at the same time. Early and aggressive arrhythmia management can potentially mitigate the impact of arrhythmia on heart failure exacerbations. Thank you very much.
Okay, we have 10 minutes for discussion.
after 10 years, we have more adult patients with congenital heart disease, operated or unoperated. So problem is that there is problem with our community, that what they feel after surgery or catheter interventions, they feel that their patient is okay now, they last follow. The main problem is they do not follow in a proper time and place. So apart from these arrhythmias, there are much other problems we are facing in our clinics. So it's a very important that we should ask them for proper follow-up in this case.
Nice presentation, Mohsen. I would like to ask you even that many times we have controversial opinion about the pacemakers between electrophysiologist and me. Like in patients with congenital heart disease, post-operative or something, I think the guidelines are different from those which are for complete heart block or congenital complete heart block or ICHD, ischemic heart disease, whatever. And we must have some threshold, we must act earlier to prevent the catastrophe or after complete heart block or arrhythmias. And they need more intensive and early intervention for arrhythmias and for complete heart block as compared to other patients. Like as far as the ablation, I would like to ask you the role of permanent pacemaker in place of ICD in many patients. We used to do that, like hypertrophic cardiomyopathy or other things. We are in adult, if they are were adult, we used to put the ICD. We put permanent pacemaker to avoid this. What is your in long QT also in small children?
So the number one thing is congenital heart block versus acquired or post-operative heart block. So there are certain differences. There are differences in the rate, which we kept the threshold for implanting the pacemaker. In congenital, the cutoff number, as per guidelines, currently average heart rate of 50 less than. And if we are seeing a patient with some congenital heart problem, this number goes to 70 or 75 less than average heart rate. So this is number one. And the other thing is your question for ICD versus pacemaker. So pacemaker is usually for the bradycardia. And especially in hypertrophic cardiomyopathy, the main reason of sudden cardiac death related to arrhythmia is ventricular tachycardia. So generally pacemaker does not help in preventing those events because it does not have any ability to terminate it. Sometimes we get lucky that some of those atrial ventricular tachycardias or VFib is bradycardia associated or cause dependent. So in that population, you may get some benefit, and similarly, especially in long QT type 3, where the arrhythmia is pause dependent, in which you implant a pacemaker to prevent those long pauses, and in that scenario, pacemaker is of utility. But the thing is, you should be very careful and you should be very clear what you are going to do is for what purpose. It should not be implanted blindly for anyone. Right? So anyone come with a syncope, you should have a diagnosis before implanting anything, either pacemaker or either ICD or whatever you are doing. You should have a diagnosis before that, and then you can think of. So in some scenario, yes, pacemaker can help by overdrive and by preventing those pauses, but otherwise it does not have any specific therapies for ventricular tachycardias. The new model of pacemaker does have algorithms for treating the atrial tachycardias or atrial flutters by overdrive pacing, but generally pacemaker is for bradycardia and ICDs for ventricular tachycardias and VFib.
Do you have the facility of ICDs in very small children here?
So the problem is, yes, technically we can put in, but the problem is the size of the ICD is significant. And when you going to implant a transvenous system in a small child, there is a risk that you give a big loop of ICD lead, and that is very heavy lead, and it's usually 8 French or 9 French lead. So there is a risk of significant TR with that. So you try to avoid in those small kids. The other problem I face is the risk of erosion, skin erosion, and if it's get infected, you have to take out everything. And then you are stuck in a middle because you are committed to ICD with a patient, and now you have the infection and you have to explant everything. Plus, for last 1 decade, initially the Pediatric Electrophysiology Society was very aggressive in implanting the ICD because they were new and they tried to compete with the adult guys. But ultimately, in last decade, what they learned is there is a huge psychological impact of inappropriate shock in pediatric population because they have the sinus rate of 180 or 190 beats per minute, and the ICD detects as ventricular tachycardia. And I saw a patient during my fellowship. She was like 16 years old, hypertrophic cardiomyopathy, and she was celebrating her birthday and got a shock. And she had a first shock in her life, and she was continuously crying for 48 hours. So we involved all the departments, psychological departments, to calm her down, but it was a huge, huge impact on their lives. So it's not my decision, it should be mutual decision between the parents, between the patient, between us, and we should not dictate them what to do. It should be mutual decision between us. We should tell them the risk and all the chances of complications that can happen with those ICDs. So yes, for small children, we can implant an epicardial ICD, but again, the chances of complications are high. So you need to be very careful about the risk.
Sorry, I don't have much knowledge about the ICDs, but can't you set the rate at which it delivers? Because you are in children, it may normally after inactivities, or it may go, heart rate may go 180, or even in very small children up to 200.
Yes, we can program it, but again, the risk of missing it, and it's not only the rate because of the sinus tachycardia. There is a risk of lead fracture as well. Yeah. There is a far field sensing as well. So there are a lot of technical issues in the pediatric population because there is a like 20% risk of inappropriate shock when you implant an ICD. So you need to be very careful. You need to convince yourself that this patient definitely need an ICD, and then when you commit it, you proceed for that.
Thank you, Mohsin. So adult congenital, when we did our fellowships, we all trained on adult congenital, and those were the patients where you used to get a lot of hands-on, and you used to get used to those patients because they were recurrent. Now the problem in Pakistan is that we are always given one chance, and we are with limited armamentarium. And we know that with these congenital baffles and everything, you're working from the left, right. It's a very complex, complicated issue with recurrence and with a low success rate. So, the hall over here and in the morning, in the earlier sessions also, people are taking home this message that EP is ablation, that's the end point. My question to you is, with all of this complexity, especially in this special population, what is short of ablation, or let's say if you flunk ablation, what do you do with these patients with intra-atrial tachycardias in this population? So would you have any insight on that?
So, Dr. Ahmed, thank you for the question. But so you can have a pharmacological treatment. I see a very good response with the anti-tachycardia pacing to prevent recurrences of those atrial tachycardias. That's a big utility. You can use, especially in those patients who have the associated AV blocks as well. So unfortunately, what I come to know that we does not have those pacemakers with anti-tachycardia pacing abilities in Pakistan till now. So we have to, as a society, we have to involve the industry, guarding those devices. And yes, this is not a one-time go thing, like you go, you ablate the substrate, and it's go forever. So you play with the immunodrone, you play with the antiarrhythmic, and there is a point to come in when there are significant side effects and you decide to stop the medication. At that time, you can go for the catheter ablation, get few years of medication, planking period, and during that you can take off the medication, give some time to patient to recover with those side effects, and if it's came back again, Then you start again discussion with the family, what they want. They want again starting the medications, go for the ablation, or do some device therapy. So it's a, not a straightforward answer for that.
So, sorry, I just one question from Mohsin, for Mohsin actually, it's me. Correct me if I'm wrong, in patients with congenital heart block, is now, I think probably a consensus that it's not whether we need to do a pacemaker or not, it's a question of when. Is that right? Like it's not that you will not put a pacemaker in these patients, it's the question of when would you do it. I think that's more of a question rather than not putting a pacemaker in patient with congenital AV block.
So interestingly, 2021, there is a PACES guidelines about the device therapies. So when we look at the indication for pacemaker in congenital heart blocks, there is no class 3 indication. So there is class 1 indication and class 2 indication. So if you implant, despite patient is asymptomatic, it's still beneficial. So there is definitely a mortality benefit in implanting those patients. Again, question is when. So there are clear now numbers, they give some average heart rates. The other thing is the patient is developing ventricular dysfunction, complex epilepsy, and there is aortic root dilation. So there are multiple other factors they try to put in to give you an idea when the patient needs those pacemaker. So there is, so what I try to do myself is I try to take them to the age where they may avoid the surgical epicardial system and we can put a transvenous system. But again, this is a very short 1-year experience that I opted this strategy. It could be completely wrong or right. For the society, pediatric society, they want that we start with the epicardial system at least past 10-15 years with the epicardial system, because there is a risk of venous blockage as well. If you are suspecting that your patient is going to live 60 years, they are going to get 3 or 4 leads, and then there is the vascular obstruction as well. So you have to deal with that. So our approach is initially start with the epicardial system, spend get 10-15 years, whatever these leads give you, and then go for the transvenous system. And yes, there is no age cutoff. There are numbers, there are some parameters you can look for in Holter, and symptoms you definitely have to implant.
Sir, can you please stay back? Can you give shields to the presenter and the panelists? Dr. Mohsin? Yes. Shield. हाँ. Dr. Najma Patel. Dr. Hussain Baksh. We have 4 presenters from the allied group as well. I would like to call Dr. Abdul Mueed. Dr. Sajid Sheikh. Dr. Kubra and Dr. Maqsood Alam. clap. Okay, our last session is on 3D mapping overview industry talk by Mr. Rasmi, Bioscience Webster. Mr. Rasmi. You're welcome.
Hello and welcome everyone. Welcome to the last session for today. Actually, my session will be a joint session between myself and Professor Laqat Zaman. So I will be covering the technology part, and Professor Zaman will be covering the real life cases demonstrating our technology. So first, let's start by introducing myself. My name is Rasmi Basyuni. I am the Clinical Development Manager for Middle East and Pakistan. And I'm here to represent my company, Bioscience Webster, which is one of Johnson & Johnson group of companies. We've been in the EP market for the last 25 years. And in today's presentation, I will take you through what we can offer in the field of EP. So first of all, our company, we are active in many aspects when it comes to hardware, software, generators, and disposables, mainly diagnostic and ablation catheters. So because I only have 30 minutes today, I will be covering only the hardware and the software part. So for those who never saw Carto3 system, this is our 3D mapping system, which is on the left. And it consists of many parts that are used together in order to be able to visualize catheters in 3D manner with the idea of reducing fluoroscopy. So let's start with the technology, hybrid technology. Why is hybrid? Actually, we have two technologies working hand in hand. The first technology is the current-based technology, and this is the technology that is used in order to visualize any catheter which is connected to the system. But the pitfall of this technology that it has low accuracy. Together with the second technology, which is the magnetic technology, which offers much better accuracy, but one of the pitfalls that it can only visualize one catheter. So what we did as a company, we combined both technologies, and this is why it's called hybrid, in order to be able to visualize any catheter with a very high accuracy and not to be affected by any biological changes. So some of the key system features are ACL, FAM, and COC. I will take you through each one by one. So first, ACL. ACL stands for Advanced Catheter Location. And actually, this is the pure or the essence of our accuracy in the system. And what you can see here on the image is an X-ray image for the heart, where you have two catheters, the lasso, which is the circular catheter, with ablation catheter. So imagine that now you will be seeing the same catheters in 3D, which is matching like almost 100% what you can see in the X-ray, which this translates in accuracy of less or equal to 1 millimeter. And this is the highest accuracy that you can find in the market nowadays. When you are talking about accuracy, you are talking about everything when it comes to the catheter shape, to catheter movement, and even when the catheter is changing from one shape to another. And this is what you can see here in the lower, like when the lasso is in the IVC, it will be stretched exactly the same what you can see it on the Carto3 system. So it's very highly accurate. How can we visualize the other catheters? It's not only our catheters, we can visualize any catheter by using the patches, which are placed 3 on the back and 3 on the chest. And while we are doing so, we can visualize up to 8 catheters in one procedure. Moving forward to the FAM. What does FAM mean? Actually, FAM stands for Fast Anatomical Mapping, and this is what we are proud of, that this is one of a new advanced mapping technique which allows you to collect geometry while you're moving the catheter inside the heart. So The speed of creating geometry depends on the speed of the physician and how quick he or she is moving the catheter. So the accuracy of our FAM or our geometry, it's like a CT-like. So you have the image on the right. This is a CT scan for the left atrium. And this is what you will have while using our technology, using the FAM or the fast anatomical mapping. I will show you some examples of what I mean by maps. So we have several types of maps. You can do a voltage map, which is the one on the left. So this will measure the amplitude of the signals and give you the red is the areas of low amplitude, and the pink is with the healthy tissue. You can have anatomical maps, and all of them are for the left atrium, and this is usually used for to treat atrial fibrillation. The one on the right, this is LAT, which is local activation map. This is the third type of map that we can create. And lately we introduced a new map called coherent mapping, and this is the latest technology that I will cover in the last slide. So on top of these maps, there is one last map, but I didn't add it because it's a video, which is called propagation map, where you can see the propagation of the arrhythmia while you are mapping it inside the heart. So moving to the third part of the key system features, efficiency. So our system is very efficient. Why? Because everything is connected to one system. So everything into one hub. So this will improve the signal quality. This will reduce time. You will have cables plug and play. So the one on the left, this is what you will do during conventional cases. You have to plug pin by pin, while when you use the 3D mapping system, you have auto ID, quick cables, plug and play. So no place to have even some errors in the pins placement. Moving to the second part, which is the base software enhancement, which is available in all systems. The MIM. MIM stands for multi-electrode mapping. At the beginning, we started with single, which means that you could take one point at a time. But later on, we introduced our MIM technology where we could... You can use a pointer if you want. Yes, perfect. Yes. So where we can now take so many points in a very short time, and we have, at the moment in our portfolio, we have 3 MIM catheters, which is the Lasonav, Pentaray, and Decanav, and soon we will be introducing another 2 catheters that are coming in the pipeline. If you need more information about them, you can get us at the booth. So, but especially I will show you the Pentaray, which is our best MIM catheter, where you can take so many points in a very short time using our technology called Confidence. And here I'm showing you a very small example of using it. So this is a case where we are using the Pentaray, our MIM catheter. So at the moment we are collecting 15 points. This video is less than 40 seconds. In less than 40 seconds we could collect more than 100 points. So this was like impossible in the few years ago, but nowadays we can collect points very accurate. The system will automatically annotate them using the confidence module, and all what you have to do is just to move the catheter around and the system will do the rest. Accuracy. So all of us know that each patient breathes in and out and their heart pumps. So this is something good, but when it comes to mapping, this can create disturbance. Why? Because we need to map in one phase. If you are moving, the heart is moving, the lungs are moving, then this can create inaccuracy. So our system will train, they will know how the patient is breathing, and then they will exclude the inhalation part and focus only on the exhalation part, which will add even more accuracy to the map. So this feature is also available in all the systems. Now my last part, and this is the most exciting one, where I will be covering some of our software modules. We have so many available, more than 15, but I will cover only the main ones. And these are available upon request. So the first one is the car-to-sound module. Actually, we are, as I said, we are a hub. We are also integrated with all the systems inside the cath lab. One of them is the ultrasound, or the intracardiac echo. So we are compatible with all mainly with the Siemens and GE, where we can import the ultrasound images and we can create maps using the intracardiac images. And this is not externally. We have a catheter called ICE or SoundStar or AcoNav, which goes inside the heart, and we can build the heart from inside and see everything intracardiacally. The second module, which is the most famous one, which is the Carto Smart Touch. And this is here we are talking about contact force. Of course, we realize that each physician would appreciate if he's pushing too much or if he is not pushing at all and he's in the blood pool. So what we created is a software together with a new catheter where we implemented some springs on the catheter that would give us some force readings. And this is what you see here, for example, 41, which means that you are, if the number is above 30, it means that you are pushing too much and you need to take it easy. If you are having only 5 grams or less, this means that you are not touching the cardiac tissue and you need to improve contact. This is something that we created almost or invented and released in the market 8 years ago, and now it's a standard in all other technologies using the contact force. Moving forward to the confidence, where I touch point quickly about it. So confidence gives you the ability of not focusing on annotating signals or even looking if you are touching or not. The system will do it by itself. So what you have to do is to set some filters, tell the system what you need from the signal, like you need to be within a certain time, you need to be touching the cardiac tissue, you need to be within a coverage area of 1 millimeter. So you set filters, it's user defined. Once you have it there, the system will collect the points automatically. Then we have the TPI, and this is the tissue proximity indicator, and it will measure by using the impedance of the difference between the cardiac tissue and the blood. It will determine if you are in touch, you are in contact or not, and we only collect the points which are in contact, so no more internal points. The third point, map consistency. The system will calculate each point with the neighborings. If they are outlier, the system will remove it automatically from the map, so you know that all the points are homogeneous and all of them make sense together with the mechanism of the tachycardia. The last point, and which is very important, is the wavefront annotation. The system will look at the unipolar signals, which is the negative slope, which is the best way of annotating the signals, and it will do it for you. Moving to the CartoUniView, as we said, we are integrated with ultrasound. Actually, we are also integrated with the X-ray. So what you have to do, and this is also one of the steps that we need to do to reduce fluoroscopy, you just have to take you just have to take 3 views, AP, RAO, and LAO. They will be transferred to the machine, to the Carto as a background. And you can take even the lids off, and you can do almost near zero fluoro case. So you can depend on the images that you have in the background, and that's it. PASO. PASO stands for pacing software. You know, when we want to do pace mapping, we always have to compare with using our eyes if this is matching with the PVC, the clinical PVC. But each one of us sees signals differently, so there is some sort of errors. But now the system can compare the PVC with the pacing map, and it gives you a percentage of correlation. So what we will be targeting is something above 95% that will prove to you that you are on the right spot. VisiTag. So this now comes to the ablation. So again, it's filters. It's a user-defined. You can tell the system when to take an ablation tag, and this is where it will tag the place where you did ablation, so you can come back to that spot, or you know that you already ablated in that spot. So you can put some preferences that you need to stay there within 3 minutes, 3 seconds, 3 millimeter, within a force of above 5 grams, and the system will take it automatically. And the beauty about it that you can go back to that tag, double-click on it, and you will see how much watt you delivered, how much temperature it reached, how much impedance drop, and how much force you applied. On top of the visit tag, we have the ablation index, which is a non-linear formula integrating time, force, and power. By using these 3 parameters, the system can give you a tag or an index. Based on the clinical literature and the clinical studies that we did, we recommend to have 380 ablation index on the posterior wall and 500 on the anterior wall. So instead of looking at temperature, power, and impedance drop, you can just look at one parameter, which is the ablation index. CartoSig, this is, let's say, an upgrade for the CartoMerge. So you can bring the CT image, cardiac CT image. Within one click, the system will automatically segment the heart into chambers, even the coronaries, even the esophagus, and you can import it in the Carto before even starting mapping and do your case. So this will give you an indication even how many veins the patient has, if he or she has common osteum or they are more than 4 veins. So now moving to one of our latest products released in the market, VisiGo, and this is actually a sheath. It's a bidirectional sheath, so it's deflectable, which deflects 180 degrees on both sides. It gives you a better understanding of the relationship between the catheter and the sheath. It gives you also a better understanding of the orientation of the sheath, and also it gives you better stability and better contact. But what is very unique about it, and this is something that only exists with VisiGo, that you can also visualize it on the 3D mapping system. So you don't need to push fluoro. This is actually the VisiGo. And now we are inserting the catheter, so you can see the sheath on the system without using the fluoroscopy. Our latest, let's say, upgrade or software that we released recently this year in the market, Carto Prime. Carto Prime consists of 4 features. The first one is coherent mapping, and this is the picture that I showed at the beginning. Actually, what we do, we need to do proper mapping. We need to map the whole chamber. We need to map the whole cycle length of the tachycardia, tag the scar tissues, tag the double potential, and then the system will give you a better understanding and a simpler understanding of the mechanism of the tachycardia. You will see the scar or the snow zones, what we call slow or no zones, in brown. You will see vectors, which will represent both velocity and direction. So velocity means if the vectors are thick, it's a slow conduction. If the vectors are thin, are fast conduction. And you know that we need to target the slow conduction within 2 snow zones or within 2 scar tissues. This is an example. So first we do our LAT map, and then we activate the coherent. The brown are the scar zones or the snow zones. And as you can see, the vectors are moving, showing the direction and the velocity of the mechanism of the tachycardia. So what we would like to see is to look for the thick vectors that falls between 2 scars, so we can identify the shortest, slowest isthmus. And in this case, as you can see, here is the perfect spot for an atypical flutter. So what we did here, we just did some few ablation, and the tachycardia was terminated. So instead of doing a complete roof line or complete mitral line, you just do coherent, and you will have the simplest way of terminating. This is my last slide about the technology. So another features in the Carto Prime that will be mostly into the ventricle is the LAT hybrid, LAT hybrid. By hybrid, I mean the system will collect the point during PVC, but location-wise, it will be in sinus. So every PVC will be linked to the sinus beat, which is that comes before. So with this, we know with the PVC, the heart will be moving, shifting, but we need to collect points during sinus. So this will add more accuracy to the map, because if anyone would do PVC, you will notice that we will terminate the PVC somewhere close to the earliest point, while in theory, it should be on the spot, but this is because of the fact that the heart is moving during PVC, so we need to collect location-wise points during sinus. The second one, and this is one of my favorites, is parallel mapping. And this happens if we have more than one morphology, 1, 2, 3, up to 4 different morphology. Previously, we would map one by one, but nowadays we can map up to 4 at the same time. We ablate the first one, we switch to the second one, the map is done. We just go and ablate without the need of remapping and wasting more time. The last one is the map replay, and this is when we are mapping a tachycardia, and in between another tachycardia will come in. So we don't need to worry, we don't need to that another tachycardia came and disappeared. What we can do to focus on the one that we are doing, and at the end we can do retrospectively a new map based on the information that we collected at the beginning of the case. So the system will look at the previous points and create a map without the need of remapping the whole tachycardia. So that was all about technology. My last slide will be about Pakistan. So as we said, we've been in the market in the EP as Biosense Webster for 25 years. We partnered with GMS, who's our exclusive partner in Pakistan Global Marketing Services in 2018. And successfully, and alhamdulillah, we managed to install the first Carter 3 system in January 2019. Since then, we did more than 160 3D complex cases using Carter 3 system in Pakistan. And nowadays, year to date, we are 41, and we are targeting to close this year by at least 70 cases. And inshallah, next year, we will do more than 100. Nowadays, we have 5 centers with active Carter 3 system in Pakistan, FIC, RIC, PIC, Aga Khan, and our last addition was Shifa International Hospital. And with this, I would like to introduce Professor Laikat Zaman to the stage so he can take us through some of the cases that they have done in the Shifa Hospital. Thank you very much. And by the way, all the maps on the right, they were done here in Pakistan. Thank you.
Which one is slide advance? This one? And the laser is this one. Okay. Not working? Okay. All right. Okay. Thank you. I think this is giving a talk like any of you who have attended the ACCR, the Heart Rhythm Society. And the last day when there's a half day, you will find that people will have their bags in the room and there will be only like 1/3, 30% people. But nevertheless, the most interesting topics are at that time. So that's why I was telling Azam, I said maybe I'll give a virtual lecture so they can look at their iPhones and stuff and stop somewhere and look at that, because I know that will be less audience. But nevertheless, Rasmi gave the talk about the technology issues, and I won't talk into that, but I'll just give you a little overview of what the system can do. And I tell you, really, when you become comfortable with it, the people they have seen, you know, there is no lead. We just go like this, and it feels very comfortable, you know, when you do the procedure. Actually, for atrial fib procedure, back in the US, you know, I had a chair, there will be sterile things in there, and I'm just sitting in there with a foot on the ablator and then just moving, sitting, and with a little music in the back. So it's quite comfortable. Do we have the slides? Can you put the slides on? Can you put it on? Because the time is going to be, where is the time thing? So I should see. You know, where is your timer? So I should keep in time. Come on, you are working like a slow pathway. Or really the very slow one like the PJRT, the slow retrograde. Or actually I would say, I will show you the slow here. Okay, you will be, the last one will be slow. Okay, so do I point on this thing? Okay. So just to tell you that why do we do 3D mapping? You know, why not just the fluoroscopy? One is for complex arrhythmias, because, you know, me and Azam, we grew up with the beginning of electrophysiology and ablation. So like I say that I grew up with DC ablation, we are going to be back to DC ablation but modified form. We won't talk about that here, but we have seen the history. So old days it was a paper and you do this and that. So complex arrhythmias, you know, you need this stuff. Correlate anatomical with electrical information, that's important. more accurate catheter location, very important because you have a resolution of about 1 millimeter. X-ray really is very gross. And using 3D navigation that, sometime in future we will talk about that you can come to, I will show you actually here. Accuracy, really right on the spot. If you know where you are going, you can go right there. It makes you get there. The other important thing is tag areas of interest. Whichever area, if I say that there is an area where there is good electrogram, I tag it, give it a color, I can go back there with ease, with a great ease. It's like a GPS system. You know that the Shell gas station is there. It tells you, you just go over there to the Shell. Recall back and reposition, very, 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 very important. And I will show you a case here where you will see that the arrhythmia got terminated by catheter moderation, bump termination. With X-ray, forget it. You don't know where it was, only it is in your head. Okay. But here you can go exactly there. Recognize prior sites of ablation. This is very important because with X-ray, let's say a simple thing like accessory pathway. Here you will see that with 2 ablations we were done because with X-ray you will go back there, you will look at electrograms and say I'm ablating, no success, you go back over there and you are ablating in the same place. But here you know exactly where you have ablated and you don't go there. Better identification of subtle differences in local activation, high density mapping. So you will see that one, examples of that. I will show you maps where there are like 3,000 points. Now why the hell do we have 3,000 points? Because you are looking for these scar tachycardias at a very close resolution. So that gives you another, that subtle differences in local activation. And then the other is the identification of abnormal substrate, very important for things like, let's say, scar-related ventricular tachycardia, just to give you the example. Then again, the congenital disease, Dr. Mohsen, when he was presenting this thing, I was telling you when somebody asked question, the efficacy, the thing is with coherent mapping, for example, this is one advance. Coherent mapping is really, if I give you, I'm just going a little ahead of time, it would be like when you have a Google GPS and the traffic is blocked in some places, right? It gives you a route that you go this way, because it knows where the traffic is blocked. So coherent mapping actually is intelligent, which gives you the conduction time and also the conduction velocity vector, and then also tells you the conduction barriers, and put it all together to give you a map. And as you will see it here, and I think in your cases like tetralogy fellow with the patches and all that, combined together with non-invasive imaging like MRI, really you will come to a precise location of the circuit and particularly the isthmus where you can ablate. The other one comes is, very important for, this is the one, if I teach anything to fellows and all that is that, reduction of fluoro exposure. First, if you have a system where you don't use fluoro, and if you use fluoro, for God's sake, don't keep foot on the pedal, and I mean the foot on the pedal, don't keep on fluoring, and do all the other precautions like low frame rate and all that. But if in this system, you don't use the fluoro. I mean, I don't use fluoro. The only fluoro I use it, and again, I don't have to, and I have done it zero, like transeptal, like 1 minute of fluoro, but that's also on 3 frames or 2 frames per second. So really it is near zero or zero fluoro. Okay, just to give you a little experience when we started here in Shifa. And, as always, when you come to a new place, you get something which is not usual, right? You come to the first thing. Like I will tell you another case which I did in some other place which was not usual. But you should be ready for something which is not usual, right? Okay. So I come in here, the patient comes in, say that this patient had AV node reentry and had a left bundle aberrancy and an AV node reentry, because if you look, I won't tell you here, but you will see somewhere in, I think I don't have the thing, but in one of the V leads, you see the retrograde P wave there. So it was thought, so when we did it, And the tachycardia induced, I told Dr. Asad, I said, this is not there. This is somewhere on the other side, a little bit there. Now this patient was getting this tachycardia induced very easily by pacing the atrium, and will not give us chance to map during sinus rhythm or during atrial or ventricular pacing, whatever. So we said, well, we have to map him in this one, but I know where it is. Let's go there. So we went there. Okay, first we created the map, with 3D mapping we create the anatomy as we did here. This is the, you can see that unfortunately he told me that this thing is not working. Oh, it's working. Okay, so you see this is the right atrium, inferior vena cava. This is the coronary sinus. Yeah. Okay, this is the coronary sinus, and okay. Now it's working. Okay, all right, good. Okay, so then as we position the catheter, you see the catheter. Now, we didn't know this. We did not know this, okay? Tachycardia terminated. So what we did, we used the Kato replay mode. We came, and you can see the beauty of the system is that the system is recording continuously electrical and anatomical information, and you can come to, you can go and you say, okay, I want to see where is this. So it will tell you exactly at that point where the catheter was, and we put it there, and then if you can see, I cannot see that it's, okay. Okay, now you can see that it's very hard to point from here, but you can see the yellow figures. Yeah, I just want to finish before the mark comes. Anyway, you can see those yellow dots are the His bundle, and then you can see the catheter here, and you can see the blue dot there. The blue dot is where the arrhythmia got terminated, and as you can see, as it got terminated anterograde through, basically this was atriofascicular pathway, if I just summarize it. So we know that this is where the pathway is. We gave 2 or 3 ablations in that area, and then waited for about 30-40 minutes, isoproternal and the whole stuff, nothing there. The next case is, now you will say, why the hell is he doing AV node rented tachycardia? I am doing with conventional. I say, yeah, but I don't want to put the lead. That's my first thing, because I'm an old guy and I need to play my golf. So I need some stability and some flexibility. So that's my, no, there's more than that, more than that. The thing is that, with fluoroscopy, it's very hard to know, because now I learned this more while doing the conduction system pacing, that the His bundle recording is just one place. It's a broad area. You can be 2 centimeters away, like he presented this morning. And we do AV node ablation after His bundle pacing, so I know a bit about it. So what we do with this one is we map the His bundle area. You see those yellow areas, and then the other advantage of these systems is that you can measure the distance between the 2 points. So if you will see there, this says 7.1 millimeter. So we ablated in different areas, and the closest point there was 7.1. I said, no, the other above that is danger zone. We are not going to go there, stay below. So you can see this red one there. I think you can see it. The middle, not the bottom red, the middle red. And the next slide will show that this is 7.1, that one is 13.7. Okay. Had I not known this, that is my danger zone, I would have gone up. What has happened? Heart plaque. X-ray, you will go up. So it's not going up. It is all in this area. The slow pathway is anterior to the coronary sinus arch, usually in the middle, but could be up, down, but not above. There's no point in going up. It is being in the right spot and then knowing. So we ablated there, and we got good junction rhythm, arrhythmia not inducible. Next case is a simple Wolff-Parkinson-White syndrome with by EKG looked like a postroceptal pathway. And I call the postroceptal area as a Bermuda Triangle, where things could be anyway. Similarly, the person who was mentioning the PVCs in the morning, I was looking that he will be talking about RVOT, coronary cusp, summit, pepperoni muscles, because that's my favorite. But you know, because that area again is like, you could think arrhythmia is one place, RVOT, but it's actually in the coronary cusp. So this is, what happens here is that the septal tachycardia, accessory patches is the broad area, they can be in a broad area. But in any case, we mapped it out here in the right posteroseptal area outside of coronary sinus, and you see the color map, the red indicating the early, and then we tag, that's another thing beautiful, we say which is the point of interest. So the blue is the point of interest. Now we can, it doesn't matter, my catheter can be anywhere, but with ease I can come back precisely to that. So we came over there and we gave a, yeah, good, now is good. Now, like in the US, they say, now you are talking. So gave me this laser which is working, now you are talking. So we give first ablation, you see this little red area here, the arrhythmia went away, the pre-excitation went away, but came back after 10 minutes, okay? So then we waited and it was there, and then we found, because it's right there, so we came over here, and after that, this was successful. So now, because I have done with X-ray, it's not that, you know, people keep, sir, hum to conventional karte hain. I've done conventional for a long time. You know, I would say if you accumulate your experience, we have done more than that. But why I don't do conventional? Because less radiation, accuracy, and I won't give not too much ablation. You know, we'll be ablating and ablating and ablating. Okay. Now comes the, what's the time? Okay, good. Because I need to show you the good stuff in a less time, in this limited time. Now comes the fun stuff, what the Americans, the fun stuff. He already showed that. This is a patient we did, you know, somebody was asking about efficacy of catheter ablation and all that. The point is, it's like anything else. You know, if you shoot something, it's how is your, or if you play golf, I'll give example of golf. I don't know if there are any golfers here. If your setup is good, if your target, you look at that and you set up good, your shot is going to be good. Your efficacy is going to be good. But if you are just doing it, your efficacy is going to be 40%, 50, 60, whatever. And then you have to have some measurable effects, like if, you know, I don't want to go into details. At another talk, we will talk about that. But efficacy depends upon, somebody gave a very good talk about selection of cases. That's important. You select your cases, and then you do the procedure right, then your efficacy is going to be good. So this is, quickly, this is like a voltage map. This is before ablation, this is after ablation. And the different colors indicate I think here this is 0.2 and this is probably 0. I cannot see it here. You usually put it 0.5. Yeah, we select a lower threshold. So anything which is less than 0.2, the red one means the scar tissue. Above that is a variety of voltages, different colors. But if you see here, this is, okay, I purposely took out this is post-ablation. I purposely took out the tags for ablation because it looks ugly. You know, I tell them take it off. I will show you the one with ablation tags, but to look at pretty, I took out the tags. So you see here, and you look at here, okay? Because those areas are now blocked. There is no conduction. This is the PA view. You see, I call this guy Shlomo. The Shlomo's head is looking at us, so that means it's posterior. The next one, which is my favorite view for these right side veins, is the right posterolateral. So here you see the right superior vein, this one the right inferior vein, and in between is the carina. And you see that there, the carina is very active. You know, here the beauty is that you can see the substrate, and you can see that it's ablated. And you see here now the ablation tags, here also, and they're also in between in the carina between the two veins. So after ablation, this is silent. So we got the pulmonary vein isolation here. Next is This is the same thing showing without the tag, so we will skip. Next is a patient with a persistent atrial fibrillation. So with persistent atrial fibrillation, usually what you have is many times you find that the pulmonary veins are already, they are silent, but you have a substrate mostly in the free wall. In the free wall is left a variety of places. Then you have to hunt for those. You have to hunt for those, sorry. So here if we see on that side is on the right side is a anterior view because the Shlomo's eyes are looking at us. Okay? So this thing over there is the left atrial appendage. This is a common right vein, and then these are hidden, but under you can see this is a scar. Scar. This is healthy, the appendage, and this area here in front of the right vein we ablated. Then we ablated the roof of left atrium because there was conduction. You see scar here, scar in the back, but here there was. And then look at this LAO view that we went in the ridge between the left-sided vein, left superior vein, and the left atrial appendage. So the beauty of this is that you can really see the anatomy. This is like a little valley. Here you go through the valley, and this is the hardest part, the two hardest parts to get by catheter ablation, and that's why most people don't do this catheter ablation with radio frequency, because this takes a little bit experience. You know, but we can give you those tricks because we have done this for a long time. How to get here, how to get to the right side, right inferior vein is the most difficult. But when you start, we can give you those tips and tricks so you don't go through those. Okay, 2 minutes left. Okay, in 2 minutes, what I'm going to do is I'm not going to show this one. This is basically I'm not going to show this. This was a flutter. He already showed a propagation map, so I will skip that. I think I should show you. Okay, it's coming actually. You can see that. And then I'll go, it's a propagation. This is a patient who previously had atrial fibrillation ablation, and you get post-ablation tachycardias. This is a flutter circuit, which is going through the, also through the mitral, but it is not completely going through mitral. It's circulating around the right pulmonary veins and also going partially. So we chose an area where it was going easy area, which is between the two anatomical barriers, which is the mitral valve and the left inferior vein. So we ablated there. I will skip this quick. Okay, this is the coherent map. Now this is, you can see that this patient is post-ablation, and you can see that there is an area, broad area of red. It does not give us the exact idea that what type of tachycardia this is and where is the focus and all that. And this is going to be the coherent map which will next come. And if you see in the coherent map, now it is giving us an early meet late, but the standard LAT map did not give it to us, okay? So as you will see, bottom line is this is like a figure of 8 re-entry with with activation waveform going around both veins, this and this, and exiting here. And that only coherent will show you because it shows you the directionality and also what he was talking about, the velocity, because in this area, if you look here, these arrows are triangles are thicker, these are thinner. So here is in this area, the conduction velocity is slow. Okay. So let's see, where does it play? Yeah, there it is playing. If you can look at that, it is coming this and passing here. So anyway, okay, now the other thing is that, it's 0 already. So I will just finish. This is the penta-ray catheter located in that area and shows you a fractionated delayed potentials. Okay. Let's skip this. Let's come to the last one. I won't show this. Is ectopic tachycardia. I won't show this. Let's come to. Okay, this is the one. Yeah, This is another one similar, but this is a very beautiful case. Okay, now I'll just show this quick. This is where the congenital person left, because this is really for him. I think he is having coffee or something. The congenital heart disease guy. This is the scar-related, this is what he would learn, scar-related tachycardia. Not this one, I'll show you. This patient had 2 ablations in the left atrium, PVIs and linear ablations here and there, and then another 3rd ablation in the right atrium for some kind of atrial tachycardia. So he had, you know, you will have scars everywhere. So we said we will map the left atrium and then right atrium. Left atrial map quickly doesn't show you, shows you a broad red area. This could be ectopic, or it could be simply coming from the right atrium. So we said, no, it doesn't make sense. So we went to the right side, and in the right side, you see there, if I can show you, that there is, you will see scar tissue here, there will be scar here, and the wavefront will be going here. Okay, just see this, and then we are going to finish. Okay, you see that wavefront going there from, you will see it is, okay. It's passing, okay. Anyway, let's come to the last. Okay, this one basically is showing you, I will skip this one because this is a propagation map. So, this is showing propagation in the right atrium, and then behind, on the other side, is the left atrium where it is going passively. So that red spot, broad red spot, what was showing was that that was the passive coefficient going from the right atrium to the left atrium. Okay. Then what you need to have is, you need to have a Rasmi with you. Where is Rasmi? Yeah, you need to have a Rasmi. You know, I'm just saying that a good technician or a good person, right? Because, and this is where we, in Pakistan, our deficiency is lack of technical staff, period. Okay, physicians are there. They know what to do, but, you know, if the physician can be confident that, you know, this map, when I was doing, the girl was doing, and she draw the line for me and said, Doc, ablate there, and I ablated there, patient sinus rhythm, and we paced from both sides, and then confirmed that there is a complete block. Okay, and thank you. So if you would have any questions about 3D mapping as far as physicians' use is concerned and things like that, and whatever, you know, come in, ask questions, and, you know, we will, if I don't know it, I'll find the solution at a different time, but it's fun to have, you know, because you can understand the mechanism, you can look at it, it makes things much pleasant.
I just wanted to say thank you, Dr. Zaman. Very kind of you, sir. I think this has been a wonderful session. Thank you, Razmi and Dr. Zaman. I think I especially like this new format where you get the vector and the size of it, and the small arrows showing you. It makes things much clearer than just the old propagation maps the way it used to be. I think if nothing else from this conference, it's been a pleasure to see Professor Liaquat Zaman amongst us. And I think his presence over here, especially since one of his principal reasons for coming back to Islamabad is to help promote EP in the country. And I think he is going to be a most welcome and wonderful addition to our small community. So thank you, Dr. Liaquat, for being here.
You know, he is very old friend. Very old friend, we know each other. And one of the things which we will do together, both in training, research, publications. And I think like Dr. Mohsen, I think, right?
Yeah, Mohsen, yeah.
Is he here?
Yes, Mohsen.
Yeah. So what really, I think that I will talk to you and we should gather some of these scar-related tachycardias, be it tetralogy fellow, but mostly atrial, if we do, because I will work with you, we'll do the coherent mapping, and I will tell you the result should be good because where, you know, if the coherent knows where the scars are, because what coherent does, it's the same thing like us, but it's more advanced, that it looks at the conduction barriers, conduction velocity, puts it all together and gives you some kind of where the wavefront is going, and we can look at it much easier. Right. Okay.
So thank you once again, Dr. Zaman. And I think, Ghazala, I sort of bagged the stage. Is there any announcement to make or anything? So. Okay, so.
What?
So it's a very, this is an important announcement you have to make because I won't. Okay, on the group, okay, that's fine. So that's wonderful.
No, what I would say on my behalf is, because, you know, I am your guest and this is my first visit here, that, and of course my other good friend, old friend is there, Imran, you know, we know each other since long time. And, you know, he grew up, we both grew up, all of us, we grew up with electrophysiology. And we are happy that young people are here, they are doing that. And I think we need to keep this tradition like what you are doing, this great work, and build up on this and improve it. And I'm very happy to be here.
Assalamu alaikum. Just one little announcement on behalf of the Pakistan Heart Rhythm Society. I would just like to invite all those that might be interested for a meeting at 6 o'clock at the boardroom. It will comprise of just a very brief agenda. If there is anything that anyone wishes to be discussed, please feel free to share with me right now. Thank you.